Good morning, everybody. We're going to get started with the hearing on Senate Bill 555. And I see the prime sponsor is here. Senator Avard, thank you for visiting us.
Oh, you're very welcome. By the way, Representative, I want to let you know
Oh,
good bill.
awesome.
Appreciate everybody here. And so for the record, I'm Senator Kevin Avard, all wet, and as you can see, I'm melting. It's because it's
pouring
raining
out
like cats and dogs out there. But I am the prime sponsor of SB 555, and I am representing District 12, and I'm still out of breath from running up those stairs. Representative, how are you? All right, so thank you, Chairman Hunt. You look a little different today, but that's okay.
He's in Senate Commerce right now, so he'll be back.
Oh, I hope they treat him nicely there. And for the record, I am Senator Kevin Avard, representing District 12, and I'm here today to introduce Senate Bill 555, which strengthens annual reporting requirements regarding pharmaceutical rebates and requires at least 50% of the rebates to be shared with the consumers. I'd like to start off by providing a brief history of this issue, seeing that the legislature has recognized the importance of this in the past. In 2020, we enacted RSA 415A7, which requires rebates to be shared in one or both of the following ways. One, provided directly to covered persons at the point of sale to reduce the out-of-pocket costs. Secondly, retained by the insurer to reduce premiums. The statute also requires insurers to file an annual report with the insurance department to verify compliance. An initial report from the insurance department shows that insurers are complying with the verification provisions by filing an attestation, but no details of proof of compliance is part of that, which is not what the legislators contemplated when they passed the law and acted. And additionally, the statute sunsets July 1st, 2024. Senate Bill 555 makes minor modifications to the current law, which comes to us after discussion with the insurance department, the governor's office. This bill provides New Hampshire Insurance Department with the tools to appropriately verify the rebates held by the insurers, and which are to reduce the premiums. And yet, as it is drafted, to ensure that no proprietary information is made to the public in doing so. Additionally, this legislation requires that at least 50% of the rebates that the insurance companies or the PBM negotiates with the drug manufacturers to lower the actual price shall be shared with the patients at the pharmacy counter to help consumers with their out-of-pocket expenses. And why should consumers have to use the list price when many of these cases that are not in actual prices being paid by their insurance company? I would like to highlight that this legislation also requires 50%, which in my belief is already a significant compromise. Other states have adopted laws requiring 100% of the rebates shared at the counter, and at least 8 other states are considering similar legislation this year. However, this proposal strikes a balance of controlling premiums and helping patients with their needs at most in the pharmacies when they are faced with out-of-pocket deductibles and copays imposed by insurers. New Hampshire consumers are paying more of their out-of-pockets because of the actual drug prices is not being used when the calculation takes place. I want to provide you with an example of how this would work and why it's so important for our constituents. Take Frances, for example. She has diabetes and a chronic respiratory disease. She's enrolled in a high deductible plan with copays for medicines. And once her deductible is reached, let's assume she takes the medication with the list price of $200, but for which her health plan receives a rebate of $100. Without this bill, during the deductible phase, Frances will pay $200 of her medicine, even though her health plan only pays $100. If this legislation passes, at least 50% of the rebate received by Frances' health plan would have to pass to her when she buys a prescription, which would save her $50. To some people, that's a lot of money. I'm in houses every week. I clean for a living. I see rich people and I see poor people. I see people in wheelchairs and with all kinds of prescriptions sitting on the counter. And I'm sorry to interrupt my own testimony, but you know, there was one lady where I did in Nashua. She's by herself. She's got a whole row of medicines and she's got her coins lined up. She's got her, it was amazing. And that's how she paid for her drugs. It meant a lot to her. You know, $10 can mean a lot to some people that are destitute. $50 can mean a lot. There was another individual that I met. He was in a wheelchair. I did a flood job for him. Nice house. Property taxes went up. His food went up. He's all by himself. Even his dog food went up. And he shows me his prescriptions of $1,200 a month just to stay alive. Military guy. We're not asking for 100%. We're asking for 50%. Anthem already does this at 100%. So when she's buying prescription with, sorry for interrupting, but as a result, instead of paying the $200 for her medicine, she would pay no more than $150. And with the lower out-of-pocket costs, Frances may be more likely to take her medicine prescribed by her doctor, potentially resulting in a better health outcome and potentially avoiding emergency room visits, hospital stays, and other costly services. You'll likely hear that the passing of this bill will drastically increase premiums. And I'd like to point out to West Virginia, whose law also requires insurers and PBMs to share 100% of their savings they negotiated with the medicines directly to the patients. In 2023, insurance rates finally indicate that the premiums increased in West Virginia are in line with national premium increases in 2023 and did not dramatically increase. There is also a Milliman report which shows that in Arkansas, who also passed 100%, that there was no meaningful impact on premiums. Again, the proposal before you allows the insurers of the PBMs to retain 50%. It's a compromise of the savings of the premium reductions and allows insurer of PBMs and of the higher percentage of savings to reduce the premiums than the West Virginia and Arkansas mandate. You may also hear about the rebates that are passed through would be difficult to implement. However, it should be noted that the insurance department filings did require under current law. Anthem indicated that beginning in 2021, they've implemented 100% rebate in New Hampshire. And they share it with their consumers at the counter for their individual and small and large group markets. For some reason, this never came to our hearing in HHS. Not sure why, but it wasn't there. But I think it's significant that there are people that in New Hampshire that are getting it at 100%, but that there are some that are not. And I'm a little excited because I also know that there's a lot of resistance to this bill. And I find that objectionable because we're trying to put money back into the people's pockets. I think this is a very important bill. I think this helps people that are on fixed incomes who do not have Anthem. Additionally, when considering this legislation, the Senate adopted an amendment to in further consultation with several departments to exempt Medicaid, Medicare management programs, and the Ryan White HIV/AIDS program, and self-funded plans such as the state employees' health benefits. These changes would result in no fiscal impact. And I emphasize that because somebody handed me a fiscal impact that said it was going to be $30 million out of the state's pocket. It wasn't true, and I take great offense to that. And I'm still processing that in my mind. The New Hampshire legislature has an opportunity to truly help Granite Staters afford their medications where they need it most, at the counter. We recognize that 4 years ago, we passed the current law, and SB 555 will help improve the drug affordability for thousands of our constituents. And I ask this committee to support this legislation. There are some very smart people in this room that are going to be talking to you that will have point and counterpoint. I have to get back to committee because I still have other bills that we're trying to exec. So I'm going to ask you to hold your questions and have them. And I know the insurance department's here and others. So I'm asking you to pass this bill. I think it's a good bill. I think this puts a little bit of extra money back into the pockets of people that I see. I see them. And I know this would help them. That little bit will help them. And so with that, God bless you all, and thank you.
Thank you, Senator Avard. Appreciate your testimony. If you have written testimony, would you mind giving it to the clerk? Just passing it up. Thank you. Senator Susi, did you want to testify on this bill? Yeah. And you support the bill?
Thank you very much, Mr. Chairman, members of the committee. For the record, I'm Anna Susi. I represent Senate District 18, comprised of the town of Litchfield and 5 wards in the city of Manchester. I don't want to repeat the points that Senator Avard has already raised, but I am a co-sponsor of the bill, and I do think that as complicated as many of the pharmaceutical issues are, this is one of the few pieces of legislation that's distinct and that provides direct consumer savings. We've talked a lot about the cost of insurance and the effect of pharmacy benefit managers on the system and the process of retail. But this bill would actually, at the point a consumer makes their purchase, would realize the savings for those consumers. And for that reason, I support the legislation. I'd be happy to answer questions. And
Representative Spear.
Thank you for answering my question. We were given from the insurance department their analysis. It was a 2023 December analysis of the insurance market. Mm-hmm. And on page 49 of that market, it says that that without rebates, premiums go up approximately $40 per person, per member per month. Now, in the previous testimony, we talked about impacts to people at the counter. Mm-hmm. We have finally made a dent in New Hampshire with respect to getting more people insured than we ever have. In the previous years, we didn't have Medicaid expansion. The single biggest reason people say that they are not insured is the cost of premiums. Mm-hmm. According to the insurance department analysis, the cost for premiums are going to go up $40 a month. So we're going to be dropping people off the insurance rolls. In order to give the benefit, which many people, there are ways to get some of these benefits other ways.
Question.
And I'd admittedly, my question is this. Oh, you're right. I should ask the question part. Have you, when in making this bill, was any analysis done to see how this was going to impact the cost to the insurance base that we have in this state?
Mm-hmm. Thank you, Representative. I based my testimony on the fiscal note. The fiscal note was certainly what was considered when the legislation was introduced. I think I would answer it in 2 parts as well, that when we're talking about this, we're not talking about every single insured individual, because as you know, the commercial market is a segment. There is Medicare, there is Medicaid, there are different plans that are self-run plans.
I'm sorry. This analysis is only on those groups that are covered by our insurance department.
Okay, I'm trying to answer your question, Representative. So that's the first part of the question, is that we're looking at different segments of people that are insured. The second part that I would say to you is that there is a major insurer in this state that's already giving 100% of the rebate. So to suggest that every premium is going to go up by $40, I don't agree with. I don't think that's accurate. That was not information that was provided to us, and I just respectfully disagree.
Okay.
Follow on.
Follow
Or-
up.
Yeah. I've talked to Anthem, and yes, this year they do. That doesn't mean every year they will be able to. Remember, insurance companies are regulated. 85% of the large market and 80% of the small market has to go. So my question is, I'm trying to put this in a question format. So my question is, the analysis has to be done over time. And the analysis has come from the insurance department. It's not like we made it up. I mean, this is official information that we were given. It's very difficult to find the basis on which you are disagreeing with it on. So can you explain that?
Well, Representative, as I said, that analysis was done after the fact. I did not get the opportunity to review the analysis before I was here. I told you I'm basing my testimony upon the information that we had at the time we voted in the Senate. I do recognize that it's a snapshot in time, but I would suggest that analysis is probably an analysis that's a snapshot in time. I don't have it in front of me, so I don't think going back and forth, I'm not going to be able to read 49 pages between now and the time the next person is able to testify, but certainly we'll take a look at it afterward. I'd be happy to.
All right. Any other questions? Representative Magoo.
Thank you, Mr. Chairman. Thank you, Senator. Welcome to Commerce. Nice to see you. Your constituency is a little bit similar, I think, to some of Senator Avard's in that you have some city constituents. So I wonder if you could speak to a little bit about the impact of constituents who have multiple needs for pharmaceuticals and prescriptions, and potentially, as he described, high costs and scrimp and save to pay for those, and potentially have to take their prescriptions every other day or ration, or just are unable to comply with the prescription orders. And the long-term impact of going off those prescriptions and the impact on the healthcare costs, thereby dealing with the health problems caused by not being on those prescriptions. Just say, for example, a diabetic who goes off their sugar management pills or injections or whatever, and then that drives higher healthcare costs. Do you think that this bill, if it helps people stay on those medications, could that actually drive healthcare cost savings? Has there been any discussion or talk about that?
Well,
that type of issue?
Thank you, Representative. The issue of insulin is something that, we've dealt with here in this state to reduce costs. It's been dealt with at the federal level. But you are right. Many of my constituents do have to make choices of whether or not to pay a bill, buy groceries, pay for certain pharmaceuticals that are costly. There are instances where people are making choices. Some of them, for their own health, are bad choices because they were prescribed medications that they need. To the extent that they're not using them appropriately, then you're right. There is a potential for greater impact on cost because it may create more chronic conditions that lead to other healthcare issues down the road.
All right. Thank you. Looks like the chairman's back. I was going to call
Welcome,
Representative
Chairman Hunt.
Leon next, so I'll suggest that.
Thank you.
Thank you, Senator.
Good morning.
Good morning. For the record, I'm Representative Erica Leon, representing the town of Derry, and one time offered a position of providing Wall Street analysis over PBMs back in their early days. I decided to stay with implantable medical devices because I thought those had a larger net overall. benefit to society and to patients. So looking at this, the whole intention of PBMs and these rebates is to be able to make sure that when there are these choices, the cost and the rebates are shared with the people who are taking these medications. The cost of these drugs is incredibly high. And we discussed on another bill the issue of financial toxicity. If somebody's not able to afford the medication that they should be taking, then that leads to worse outcomes, especially if they are taking a lower dose or foregoing doses because they're unable to pay for those medications. Drugs are expensive because the approval process is expensive, but the process of having rebates in order to help people pay for their drugs is a good way to mitigate that. And I believe that it's absolutely crucial that we pass this along to those people who are taking these expensive, life-saving, life-improving, or life-prolonging medications, so that the cost to them is mitigated, as opposed to having people within the whole healthcare ecosystem sort of suck up those rebates instead of sending them to the end users as they're intended. So I support this bill, and with that, I'll take any questions. But I have to say I haven't gotten quite as deep into all those details of the wording as the senators. So keep me at the surface for my questions, please.
Okay, Representative Burrows.
Hi, Representative. Thanks for taking my question. Do you know where this disconnect may be between what Representative Spear was talking about, that this will increase premiums, and the Senate that said that that's not going to happen? Do you have any insight as to that?
Thank you for the question. Looking at the fiscal note and how it impacts Medicaid, in Medicaid, they use that in order to offset the costs. We may have insurers that are doing the same thing, but when you look at it, individuals have individual needs. And right now, the difference that you would have on one of these private insurance plans, I'm really not sure. I really don't see how that would flow through to the people who are the higher users of the healthcare system, who need these expensive drugs in order to live or to thrive. And while that sort of spreads the good amongst everybody, these are the people who have to pay this higher copay and this higher out of pocket for their medication. And to me, I think it's important to make sure that those individuals are able to continue to afford and to continue to take the medication as prescribed, as opposed to looking at the overall cost of insurance.
Chairman Hunt?
Yes, right. Representative Herbert did ask before.
You used the phrase, I think you said medical toxicity. And to me, I immediately said, if that's a real thing, and I suspect it is, then what is are we holding harmless those people who are producing medical toxicity? I mean, is it as if we're representing a huge constituency? Some are wealthy, some are not, some are healthy, some are not. And when you say something like that, to me, that sounds to me as a litigational opportunity if some of the players here decide that they want to or don't want to reduce any prices or do any rebates.
Well, thank you for that question. I was talking about financial toxicity, not medical toxicity, because any drug has an overdose rate. You can overdose on drinking too much water. So there are risks with any treatment, because it distills your electrolytes. But when you look at that, there's the medical toxicity, and the dose makes the poison. That's part of the risk that you take when you're taking drugs. The financial toxicity is helping to do what we can without undermining the whole process of bringing new drugs to market, to make sure that people are able to afford the medications they need. Because if you are cutting your pills in half or only taking them half as frequently, because of that non-compliance with your prescribed medication, you will likely have worse outcomes. There's other people that just don't do the treatments. They may not take a medicine that deals with their side effects because it's more expensive, and because they don't take the drug that helps with their side effects, they can't can't treat their condition appropriately. So the whole idea of rebates was to be able to push some of that back to those end users, those people who are taking these medications. And I believe that having this drive that back through to where it should be is a good step from us. You can never remove any potential of litigation from the world of medicine, but I don't see this creates any new or unique risk for us.
Okay, now Representative Spear.
I'm trying to form this in a form of a question, and I don't want to say, would you believe, but in investigating this, which is in that way that I typically have, rebates are a negotiation carried on by PBMs on a volume basis to be able to put insurance, to be able to put drugs on a lower level in a formulary. It is nothing to do with patients. It has to do with where it is in the formulary so that the patients can have a lower copay. But if we're going to be taking that bulk of money that was negotiated out at the risk, now right now, any drug company, insurance company is allowed to put the rebates at whatever level they want and use them how they can feel with their business plan in order to meet their legal requirements. If we force them into one segment, and if we give those rebates, take those rebates away from the cost of premiums, aren't we also just throwing more people off the insured rolls, which has no benefit to anybody and is a very bad impact on the state, as we have seen over the years? Do you not see that? I don't know how to ask this question.
No, thank you. It's an incredibly complicated process, and it's one where the insurance companies, the drug companies, and everybody else involved are continually responding to legislation and rules at both the federal and state level. There are a lot of things that we have done here and that we've done in the state and we have done federally that make insurance more expensive than it needs to be. So I'm highly sensitive to all those times when we do things that make insurance more expensive than it needs to be. And we need to address those. When you look at the use of these rebates to put it in a different tier on the formulary, there is some argument that if you have something that has a copay for $10 instead of $20 or $20 instead of $100, that's in effect getting a rebate because it's on a lower formulary. But the question becomes is what is the discount that they are getting from the drug manufacturers in order to shift it to that formulary? Because there's a benefit to the drug manufacturers as well to have those volumes. When I was an analyst covering companies, some of those companies were device companies, but they also had drugs. So the more consistent of sales that they had, even if it was a lower price point, is rewarded by investors. So there's a benefit to those drug companies from having those consistent sales, even if they are at a lower price point. So that helps them. And the PBMs, there's the benefit to them in order to capture as much of the rebate as they can. What I'm looking at is, my neighbor who's going to the drugstore and trying to make sure that she can afford her medication and making sure that she is getting some of that rebate, not just in changing what tier it's in, because they're not required to change the tier in order to pass it along, but just to make sure that those people whose lives depend on expensive medications get some of this, because drugs are expensive because it costs over $1 billion to bring a drug to market. And a lot of the other efforts in order to give lower cost drugs to patients, some of the compassionate care, some of those have been short circuited because the way that the Medicare and Medicaid payments happen, if you give drug to free somebody, then you're going to have to give it to free to everybody on Medicaid or on Medicare. So it's highly complex, but I think that given even all the complexity, this is a way we can help the people of New Hampshire. And I don't think it's going to have a meaningful impact on premiums.
Thank you very much.
Thank you.
The chair will call on DJ Betancourt from the Commissioner of Insurance.
Good morning, Mr. Chairman, members of the committee. As you well know by now, my name is DJ Betancourt, and I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department. I am joined this morning by Michelle Heaton, the department's Director of Life and Health. I'll be candid with you. With the exception of Senate Bill 173, no piece of legislation has absorbed more of the department's time and focus than Senate Bill 555. Not that we are complaining. We enjoy working on significant legislation, and we realize that it is an important part of what we do. But the consequence of that is that this will be some of the lengthier testimony that I have provided to this committee. So with that, as it pertains to where rebates should be applied, be they at point of sale or integrated into premiums, that is a policy decision for you to decide. As has been mentioned, you're going to hear a lot of competing testimony this morning, and you will have to determine what direction is best. The only comment that I will make, because you are going to hear, and in fact you have already heard, a reference to the department's annual hearing report that does touch upon prescription drug rebates. That piece of it, of that annual hearing, was conducted by the actuarial firm of Oliver Wyman, and they reported that the actuarial value of prescription drug rebates in 2022 was $38 per member per month, which represented an 11.7% increase from 2021. The $34 expressed as a per capita annual cost, with that all equates to $456 per person in 2022, up from $408 in 2021. Across commercially insured markets, the total value of rebates, again according to Oliver Wyman, was estimated to be approximately $90 million in 2022. So along that line of logic, if this legislation were to pass with the 50% rebate at point of sale provision, approximately $45 million could potentially be absorbed into premiums or applied as upward pressure on premiums. Now, the question that has been asked, and I'm sure the question that perhaps is on your mind, is that likely to happen? And I have a wholly unsatisfying answer for you. I don't know. I'm not certain how the commercial market will respond to the 50% rebate remit requirement at the point of sale. The reasons why, for example, are a person has a $15 copay for a drug that costs $500. If the rebate on that specific prescription is $400, the copay is still $15. And even if the $15 copay is waived to reduce the out-of-pocket cost, only $15 would be credited at point of sale despite the $400 rebate. Beyond that, we do not know how the market will implement the systems to guarantee the 50% rebate. Some may try to work around the requirement, while others may choose to eliminate rebates entirely. Perspectives and opinions vary on that point, as you will hear, and as you've already heard, but I just cannot tell you with any certainty how exactly this will play out. As I have said, how you choose to proceed is your decision, and we will execute whatever decision you make. But because the actuarial analysis was essentially department work product, I did want to address it. With all of that said, I am here to advocate for the transparency and accountability provisions in the proposal before you. When the legislature established the current arrangement a few years ago, the department was tasked with collecting reports from carriers on how things were unfolding with rebates and premiums. Unfortunately, we discovered that those reports, the reports that we got, and for those of you who have gotten them and have reviewed them, I think would agree, that the law did not provide us with the authority or the tools necessary to get data that was of value, that could give us a comprehensive understanding of how things were playing out. And frankly, my team was a bit frustrated that we lacked the ability to provide something to you of high quality. We always try to do that when given a responsibility or a charge from the legislature. So this amendment, or the proposal, attempts to address that issue by specifying more clearly the data, information, and methodologies that the carriers and PBMs need to provide the department so that we can adequately report back to you. It strengthens our ability to provide oversight to this important segment of our healthcare delivery system. And this will better, as I said, allow us to understand how things are playing out and make public, where appropriate, to avoid disclosure of any proprietary information, a much more detailed analysis to policymakers and the public. So we do support, as I said, those transparency and accountability provisions of the proposal. With regard to sections D and E of the proposal, those sections are related to anti-steering initiatives that some other states have created to prohibit. Our position is that laws prohibiting steering by PBMs to their mail order pharmacies inhibit the economic benefits of vertical integration. In terms of what we would suggest you to consider as you go forward, is to try to find a legislative approach that balances the importance of transparency with financial incentives to promote efficiencies in prescription drug delivery. We believe that that can produce the best result for consumers. Finally, I do want to address a bit of a misunderstanding of sorts. The claim has been made, and I've heard it in a couple of different forums, that the New Hampshire Insurance Department wrote this bill. I want to clarify that. This is not a department initiative. This was not something that we wanted to wade into. As I said at the outset, we believe that this was a policy decision for all of you to make. That being said, in the fall, we were engaged by the governor's office. He was conceptually thinking about trying to bring some ideas and proposals forward on this topic. He asked us to put together a proposal that would reflect a 50% rebate at point of sale. We provided him with language, as we would do to any of you that asked for our assistance. But this was not an initiative of the department. As I said, we simply provided the governor's office with functional language to carry forward what it is that he wanted to put before you for consideration. So I did want to clarify that. And with that said, Michelle, was there anything you'd like to add that I've missed? No. Michelle says no, so I'm happy to take your questions.
Okay. All right. Representative Spear.
Thank you. I read the report in quite a bit of detail, and I thought it was very informative. But one of the things that I saw was that for the last 3 years out of 4 in the report, it keeps showing rates going up little by little by little by little. So the pressure is already there to raise rates. And we hit a 4.9% uninsured rate in this state, which is probably a record. I don't know, you could answer that. But it was down from 6.1% a few years ago. Do you envision that if rates hit a certain point that people are going to start dropping out of the rolls?
Sure, that's always a risk, and that is always something that we're very sensitive to. One of the biggest roadblocks to consumers being able to get access to care is cost. And it is why this state and the federal government have spent so much time and effort and resources into trying to bring down premiums, particularly in our individual market. I'm proud of the fact that the state moved forward with a 1332 waiver a few years ago that has helped bring premiums down in our individual market dramatically. And the combined efforts of the state and the federal government have resulted in New Hampshire having some of the lowest premiums in the Northeast. And I think that's something that we can all be proud of. So we are sensitive when we see proposals that could begin to erode or undermine those efforts. In terms of why premiums are going up, there's a number of different reasons for that. It's the reason why you all, many years ago, put it in statute that we have to conduct an annual hearing every year to disclose the analysis of what we are seeing that is driving healthcare costs and premiums. We do that every fall. We encourage all of you to attend, but if not, those sessions are recorded and you can take a look. And it's not just the department's work product. We do bring in actuarial experts to do that analysis as well. Michelle, is there anything to add?
The only thing I'd add is in the individual market with the expanded subsidies under the ARPA, as well as our 1332 waiver from in 2020, we had about 45,000 in the individual market. As of March of this year, that's up to 76,000. So we've seen large growth in our individual market. And as the commissioner said, we have some of the lowest premiums in the individual market in the country, not just the Northeast. So I think there's a lot of different factors, he said, that can contribute to premium growth. But right now we have some of the lowest premiums in the country, and we have record enrollment in the individual market.
Thank you very much. Oh, we do have questions.
I have a question. Thank you, Commissioner. I don't know if it's a germane question or not. How many markets do we have? I have Medicare, Medicaid, small, large, and individual. Is that the market that we have? That's our insured people?
So in terms of how individuals get coverage, there are a number of different ways they can do that, as you've identified. So obviously you have your government-sponsored programs. So that's your Medicare, Medicaid. That's not something we oversee. That's done by the State Department of Health and Human Services and the federal government. You then have fully insured plans that are established under ERISA, which is a federal law. Most of your large employers are self-funded. Again, that's outside of our regulatory purview, although we do try to leverage our relationships with the carriers to address consumer issues in those plans. What we oversee are the fully insured individual, small group, and large group market. So that's kind of the full kaleidoscope of coverages that people can access in New Hampshire.
Okay, follow up just for a second.
Further question?
Thank you. Could you let us know approximately the percentages of each one of these?
We got that chart last week.
Oh, okay.
Yep, you've got the chart, but in terms of what we oversee, which is, again, is the fully insured individual, small group, large group market, that represents approximately 30%
Okay,
of health coverage in New Hampshire.
thank you.
I'd also refer you to our annual report that breaks down in a lot of detail all of the different markets, the numbers, ratios, and it also includes some stuff about the self-insured market as well.
Okay, it's in my stack of mail somewhere.
Okay. Representative McGinn.
Thank you, Mr. Chairman. I just want to ask a higher level question. If the department is supports, opposed, or is taking no position on the bill as part of your answer, but as a policy question, does the department in general support reducing prescription costs at the point of sale for healthcare consumers? And if so, do you think that might help people in their decision of whether they fill their prescription or don't fill their prescription, and in general help them take those medications they need if they have to make that tough decision to walk away when the pharmacist says it's $50, $100, $20 or whatever.
Sure.
And ultimately, would that drive better patient outcomes? So as a policy decision, do you support lowering prescription costs at the point of sale as a way to improve patient outcomes?
Well, as a fundamental matter, obviously we want to see healthy proposals that bring down the cost of medications that people need. How best to do that, as I've mentioned a couple of times at this point, as it pertains to this proposal, is a policy decision for you to make. Again, I don't know exactly how this plays out. So could you potentially see lower costs at point of sale? Perhaps. But is there a cost shift into premium that either negates the saving or causes the saving to be overwhelmed and ends up being a net negative to the consumer? Again, I don't know exactly how that plays out. Dr. Az is here, also works for our department, spends a great amount of his time looking at those very, very issues. And it's complicated. Michelle, Dr. Az, anything to add?
The only thing I would add is the whole purpose of insurance is to have a large number of individuals come together to share that risk. So by doing that, you're pooling, the risk that you get stuck with a high cost prescription drug and have to, someone has to cover that, is spread out among everyone. If you do point of sale, that risk is not necessarily being spread out among everyone. So just keep that in mind too, a big picture of how insurance works. But there's a lot of nuances here. There's a lot of, caveats.
But that's
to that.
dead on what the issue is, because let's face it, rebates are adverse selection. In the insurance market right now, the biggest problem is the high deductible plans, that an employer chooses that deductibility. So theoretically, you wouldn't need these rebates if someone chose a very low deductible, very high, coverage, and then you wouldn't need these rebates at all. But that if you choose, the problem is that by the rebate is you're now muddying the waters in terms of that choice that person made or their employer made in terms of what insurance plan they chose in terms of deductibles and co-pays. Yes, Representative McHugh.
Follow up, yeah. Thanks for the quick overview on risk pooling and insurance, which I think everybody on this committee understands risk pooling and the basics of insurance, whether it's car or health. But thanks for the quick overview. But I guess the opposite applies, right? When you have healthy patients and you pick off some of them least healthy or unhealthy, and you want to skew that risk pool, you could literally make the exact opposite argument and say, if you drive people away from taking their medications, you drive them closer to some of the most common and most expensive treatments, like, say, just for instance, dialysis, right? I mean, that's one of the biggest draws on healthcare, dialysis. And that's why there's the big efforts to, drive to home hemodialysis and keep people away from kidney transplants. And I mean, I could name 50 other disease states that are exactly the same. So the issue is keep them on the medications so that the other people in those pieces of the pie don't bear the high risk, and we don't do the exact opposite of what you're talking about. So, I mean, the same applies. And that is the problem with the high deductible and low deductible. I mean, because the health care system has shifted from HMO over the years from when I first joined your committee years ago, but it's shifted. So we have this constant balance.
Representative Spear.
I know that rebates don't apply to all drugs. I know typically they don't apply to generics. They don't apply for drugs that have no competition, that are still within their patent limits and patent times and whatever other exclusivity things they have. Do you have any idea what percentage of drugs, either volume, I guess that's really a question for you, either volume-wise, cost-wise, or whatever, that we're even
we'll have
talking
somebody
about here?
from the
I'm sorry?
pharma. We have someone from the PBMs who will help you.
No, I was talking to Dr. Aziz.
Oh, is he? Okay.
Could you repeat that? Yeah. So only a small proportion of drugs actually fetch robust rebates, and so that's important. I understand. It's a good question. It's constantly changing, and it's mostly branded drugs that fetch rebates. So, yeah.
Okay. Thank you very much. I think we're all set. Okay, so I have Rachel Latham from representing Pharma. Good morning.
Thank you. I appreciate that. Thank you for receiving my testimony. My name is Rachel Cottle Latham, representing Pharma, which represents a trade association of the leading innovative brand name biopharmaceutical manufacturers. And I'm here today on behalf of our members to express support for Senate Bill 555. As others have explained, negotiations between pharmaceutical manufacturers, health insurers, and pharmacy benefit managers result in significant rebates and discounts. And this bill would require at least 50% of the rebates that insurers and PBMs receive from pharmaceutical manufacturers to be applied to lower the cost of medicines for New Hampshire patients at the point of sale. This is a viable policy solution that many states are considering, and some have already enacted, to make medicines more affordable, because it would provide patients with direct, immediate savings to lower their out-of-pocket costs for prescription medicines, which in turn helps patients access and adhere to the medicines they need. Our industry is concerned that in 2023 alone, the approximately $344 billion in rebates and discounts paid by manufacturers, this is at national scale, are not making their way to offsetting patient costs at the pharmacy counter. And as it stands today in New Hampshire, insurers and PBMs are not required to share any portion of these negotiated discounts directly with patients. And to see how these price concessions are not currently benefiting most patients, it's very important to look at the growing gap between the undiscounted list price of medicines and a medicine's net price after rebates and discounts. On average, net prices for brand medicines are 50% lower than list prices as a result of these price concessions. And in fact, more than half of spending on brand medicines, on average, is retained by health insurers, PBMs, and others in the pharmaceutical supply chain, and not the manufacturer who researched and developed the medicine. But at the same time, and even while net price growth for brand medicines has been at or below inflation for the last 6 years, many patients are being forced to pay more out of pocket for their medicines. And this is because of an increase in deductibles and the use of coinsurance, the use of which has increased significantly over the last decade. The share of patient out-of-pocket drug spending attributable to coinsurance has more than doubled over the past 10 years, while the share attributable to deductibles has tripled. And yet, when patients facing their deductible are paying coinsurance, the amount they must pay for their medicine is often based on the full list price. And this is even while their insurer and PBM are only paying the discounted amount they negotiated with the manufacturer. And this means that the cost to patients is often much higher than the cost to their health plan. And that's for the same medicine on the same prescription. And it's important to note that this problem is unique to coverage of prescription medicines. Patients do receive the benefit of negotiated discounts when sharing in costs for doctor or hospital visits, but they often do not receive the same benefit for prescription drugs. And fixing this broken part of the system and sharing these savings not only has an impact for that patient at the pharmacy counter, but could have a broader positive impact on the healthcare system. Lowering patients' costs at the pharmacy can improve health outcomes and generate savings through improved adherence and the elimination of avoidable healthcare costs. Poor medication adherence is associated with increased hospitalizations, nursing home admissions, and physician visits. Yet in 2021, 61% of commercially insured patients did not fill their new prescription when out-of-pocket costs exceeded $250. When patients cannot afford the out-of-pocket costs for their medications, this can lead to patients rationing their medicines or not taking them, which can result in devastating consequences to their health. And as I start to conclude my comments, I just want to highlight that passing through rebates at the point of sale could save patients on their out-of-pocket costs without raising insurance premiums. 3 states, West Virginia, Arkansas, and Indiana, have already enacted rebate pass-through laws. And we heard testimony previously that in Arkansas, which requires insurers and PBMs to share 100% of the savings they negotiate on medicines directly with patients. A review of 2024 insurance rate filings indicates that plans are passing through drug rebates to patients at the pharmacy counter, and that there has been no material impact on premium rate increases for Arkansas. Still, New Hampshire's approach in Senate Bill 555, which would require 50% pass-through, is more measured than other approaches requiring full pass-through. So in conclusion, our industry feels strongly that Senate Bill 555 balances the goals of controlling premiums and helping patients where they need it most, which is at the pharmacy counter. So for all these reasons, we urge the committee to support Senate Bill 555. Thank you.
Representative Spear.
I noticed in the list of people that you say have some effect on the price, insurance companies, deductibles, PBMs, all these folks, drug companies that manufacture drugs are not listed in that list. So my question is, I looked, well, I've got to form this thing in a form of a question. So,
You sure you're asking the right person?
well, she represents the drug industry. That's who I'm talking about, the drug manufacturers. I see drug prices going up on average somewhere between 6 and 15% a year, based on analysis by a number of groups, including Medicare. How does that factor into why patients are having trouble affording their drugs? I mean, doesn't that count? And realizing that I do know what the profit rate is on drugs, so be careful how you answer that.
Certainly. No, I appreciate the question. And I think I'd start by saying that we certainly recognize that we have a role to play. And, I think if any one of us could go back to start and go back to a system that was much more simpler, we certainly would do that. I think that manufacturers, though, are, as you point out, representative one entity in a complex supply chain that takes a medication from the manufacturer that researches and develops the medicine to the patient at the point of sale. And there are many entities along the way that receive compensation for distributing that medication to a patient. And so I think that there are a lot of perverse incentives in the system as it's designed today. And I think that correcting some of these misaligned incentives is one way to start to help patients, not only in the longer term, but also in the more immediate term, as we feel strongly that this bill proposes to do.
Okay, Representative Herbert.
I've been listening to this conversation for.
You're going to ask a question, right?
Would you believe? But have you, as representing your group, have you ideas as to what the legislation should look like from your perspective? I mean, I believe the fact is a lot of the financing of R&D actually comes from the federal government. And so as a result of that, I think it's important to realize that the taxpayer and the federal government have been the major financer of R&D. And but
Okay,
I
that's your
would like to
question?
hear some ideas specifically that could be part of this legislation or in addition to this legislation that you think would be more effective than the legislation we have.
Thank you for the question. I think that first I would start by suggesting that the private investment in research and development, manufacturers on average invest around 3 times more than the total annual budget of the National Institute of Health in research and development. So the private industry is really crucial to not only the research and development phase, but also bringing a fully formed drug to market. However, to your question about ideas, I think that we really do view this approach as a very balanced and measured approach that balances controlling premiums with providing direct benefit to patients at the pharmacy counter. And in addition, concerning other ideas that our industry supports, in terms of misaligned incentives, which I've just mentioned, we feel strongly that breaking the link between pharmacy benefit manager compensation, which is currently tied to the list price of medication. I spoke a little bit about that gap between the list price and net price of medicine. That really creates some upward pressure on list price, and we feel strongly that breaking that link would create a lot of room in the system to bring prices down overall.
But that should be all drugs, not just your new latest, greatest one, shouldn't it?
I mean, I represent the brand biopharmaceutical manufacturers, and I think that a lot of patients who take brand medicines have chronic and complex conditions, and that's the reason we feel strongly that this bill would really benefit those patients.
Right.
Who
Why
shoulder
shouldn't we
the
just
higher
ban
costs.
these high deductible plans? Why don't we solve this problem for everybody? Just get rid of the high deductible plans and hope that the pharmaceutical companies will just lower their prices so that we don't have as big of an insurance increase?
Yeah, I think that we're willing to have conversations and be a partner with our other industry partners to continue the conversation about the best way to lower the cost of healthcare for consumers. And certainly we really think this bill is one way to do that.
That is. Okay. Thank you.
Oh, all right, I give up.
Thank you.
I want everybody to know I'm giving up.
Representative William.
Yeah. Thank you for taking my question. Why are pharmaceuticals so much more expensive in the U.S. than any other country in the world?
I think that when we compare, pharmaceutical prices in the United States and other countries, we're kind of making an apples and oranges comparison. Other countries have resorted to government price setting, and in those countries, we know that patients have access to fewer new medications, and it takes longer for patients to get the medications that they need. And I think that, that might not sound like such a big deal, but if you're a patient waiting for a breakthrough new cancer medication, for example, in a country in Europe that might not have the new medication on the market, and that's the life-saving treatment you need, I think that changes the conversation a lot. So I think there are a lot of variables there. Certainly, patients, who are in other countries that do have government price setting proposals are not subject to the same middlemen in the system that we are subject to here in the United States.
PBMs?
Yes, among others.
Okay. Thank Representative McGee. We're already past our time, and I got a pile of cards here. So go ahead, ask questions.
Thank you, Mr. Chairman. I'll keep it quick.
Skip lunch.
Some of your testimony was really interesting. You talked about the premiums not going down. I'm curious. I'm sorry if I missed it. Did the rebates start to get cut off? So do you understand what I mean? Did the manufacturers then, since they were forced to pass them on, did they just say, okay, we're not going to do rebates anymore?
No.
In those states?
The specific study, which was produced by Milliman, shows that rebates are in fact passing through to patients at the pharmacy counter, and we don't have evidence to date that rebates have decreased.
So they kept doing them anyways.
Yes, rebates were passing
Right.
through. Correct.
We found that some companies do the rebates and some do not.
But in the states they kept doing them, according to her testimony. Okay, thank you.
Okay. Thank you very much.
Thank you.
Chair will call on Sam Hallemeyer. Oh, hi.
Thank you, Chair Hunt. It's
Seen you
Hallemeyer.
before, Hallemeyer.
I would like to invite Curtis Berry up to testify along with me, if that's okay.
Sure, why
Thank you,
not?
I'll go first if that's okay. Good morning, Mr. Chair, members of the committee. My name is Curtis Barry here on behalf of PCMA, which is the Pharmaceutical Care Management Association, the National Trade Association for the PBM industry. Seems to be the target. First of all, I will say at the outset, and I'll probably repeat myself, this bill does nothing to lower the cost of prescription drugs. It cost shifts. I've left you, to illustrate that, I've left you a package. The front page looks like this, PCMA. The second and third sheets, I think, are most telling. Second one looks like this. Going from 2018 to 2023, in 2018, it took the top 7 brands of name brand, top 7 drugs of name brand pharmaceuticals to equal all the generic drug spending. In 2023, that's down to 2. Only 2 drugs equals the entire spend for generic drugs. The second page illustrates for you, and I won't walk you through it, but illustrates for you the top 10 selling drugs in their patent history. This is important because, as you can see, a number of them, most of them have, the lowest number of patents is 57. This is the game that pharma plays by extending their patents and keeping the name brand drugs expensive. So what are rebates? Rebates are a volume discount negotiated between a PBM and a manufacturer. It's effective because PBMs, typically, the larger ones or the smaller ones, have a lot more lives than their client companies. So a PBM can negotiate with a manufacturer on behalf of tens of millions of lives versus, for example, the state of New Hampshire negotiating on its own on behalf of tens of thousands of lives. There's leverage with volume. This is why health plans of all different types, self-insureds, governments, commercial insurers use PBMs. They negotiate steeper discounts. But as a couple of the discussions just alluded to recently, rebates only apply to a small fraction of the dispensed drugs. First of all, rebates don't apply to generics. Generics are inexpensive by nature. Rebates also don't apply in the case where a drug is the only choice. There are not competing drugs for a condition or a disease. If you're a manufacturer and you're the only game in town, you have no incentive to lower your price. The analysis shows that less than 3% of drugs dispensed have rebates, meaning if you use the figure that you heard from the insurance department, less than 30%, the commercial insurance to which this applies is less than 30% of the market. So we're talking about less than 3% of the drugs in less than 30% of the market. Those people will benefit, but the rest of us will see an impact. One of the logistical issues with the bill, rebates are typically applied in the rearview mirror. They're applied on a quarterly basis, looking at the volume in the previous quarter. So all this bill would ask is for an estimate to be made, and that's not going to be accurate. This bill has three impacts from our perspective. One, it drives utilization to higher price drugs, which then everybody else will pay. Two, and please, this is not a lower tier worry. I'm sorry for the pun, but it is a concern. It allows pharma a look into the proprietary and confidential information that is the negotiation between a PBM and a manufacturer on a particular drug. The U.S. Federal Trade Commission found in a report, quote, if manufacturers learn the exact amount of rebates offered by competitors, the required disclosures may lead to higher prices for PBM services and pharmaceuticals. In addition, at the federal level, the Congressional Budget Office looked at this issue and estimated, and this was specific to Medicare because that's obviously their purview, it estimated that while some Medicare beneficiaries would have lower drug costs, overall costs of the Medicare program would increase by $170 billion over 10 years, causing premiums to increase for all beneficiaries. CBA also estimated that Medicaid costs would increase by $7 billion over the same period. Continuing on to the impact of rates, you've heard examples from other states. I suggest a longer look at when those bills were effective. Most of them were 2023, with the exception of West Virginia. And what is the year in which they're citing the rate increase? Is it using the experience of that law being in effect? I'm not going to repeat the insurance department's data. I think they did a fine job of that. And lastly, I will, I think, address some of the assertions by the sponsor and others about the fiscal note. First of all, the sponsor cited a patient or someone they know with, a kitchen counter full of drugs. Given the previous data, I think it's fair to assume that a lot of those are generic drugs or the only game in town, and the rebates aren't going to apply anyway. But if we're cost shifting, does it help the system? Does it help all of us if we're shifting the cost to everybody else with the copays and increase the copay from $10 to $15? But more importantly, and also a point that I don't think should be lost, if this is great policy for the patients of the state of New Hampshire, why did the Senate specifically, explicitly exempt Medicaid? And I apologize, Mr. Chair, this sounds like a flip rhetorical question. It should be a serious question. Why also did the Senate explicitly exempt the state employees' health plan? If this is good policy, shouldn't the state employees and their families of the state of New Hampshire benefit from this policy? The reality is, as he alluded to, yes, there was an impact. And it doesn't seem to make sense logically to me, Mr. Chair, and members of the committee, that you can acknowledge that there's a cost to the state and the state employees plan by passing this policy, which the bill exempts, and that there's a cost to Medicaid. And the Medicaid director testified at the Senate hearing asking to be exempted. But there would be no cost increase to the commercial insurance. It just doesn't make sense. I'll ask Sam if I missed anything, and he's here to help answer questions if there are any. And I should be specific, I apologize. The objection that I'm talking to is the first page of the bill, section 2 of the bill, essentially lines 27 to 29. We have no issue with the increased reporting. In fact, I think you'll hear testimony later on that the second half of the bill, which was in a Senate amendment, was negotiated with the department, and we're perfectly fine with that. So,
Thanks, Curtis. The only thing that I would add is Maine did take a look at this policy proposal this year legislative session, and they did do a fiscal note for the state employee plan and found that for fiscal year 2024, 2025, it would be an increase in $2 million alone to the state employee plan if this policy were to pass. And that bill did die in committee due to that high fiscal note. So I would end with
So
that.
they didn't just pull it out of the bill like our Senate did. They just killed the whole thing.
Correct, yes. So we're happy to take any questions.
Representative Bolio first.
Thank you for taking my question. Do you think this is just a feel-good bill?
I think that asks to, the old issue that asks us to assess the motivations. I really can't answer that.
Curtis has been around a long time. Okay, Representative McVeigh.
Thank you, Mr. Chairman. If I'm understanding you correctly, you're really saying in the long run, this is going to have the actual opposite effect of what you think the bill is proposing to do. Is that correct?
Yes, that's correct. I mean, I don't
Thank
think
you.
there's any doubt that very few people will benefit, but you can't take the figure, whatever the figure is from the insurance department, $90 million. You can't just take it out of the system and have it go nowhere.
And the reality is the minimum loss ratio in terms of how rates are set is over a 3-year average. So you're not going to really see the effect for 3+ years before you start to see the premiums will increase. Representative Purcelli.
Thank you for your testimony and allowing my question. Drug pricing is a bit of a black box. So can you help me understand, you represent PBMs, about how many are there in the country and how are they compensated?
Thank you for the question, Representative. PCMAs has about 20 PBM members, but out in the rest of the United States, I believe there's about 60 other PBMs all competing for business. That's my understanding, yes. 60, sorry, 60.
That's just 60.
Yes.
Okay, and how are they compensated?
How are
How are they compensated?
they administer prescription drug benefits for payers through self-insured and fully insured plans.
Okay, but do they get a percentage of the drug? How are they compensated?
Thank you for the question. It's all dependent on how the plan wants to design their benefit and pay for those benefits. So
At the
PBM
end of the day, it's a contraction. And under statute, we are not allowed to know exactly what is the relationship between an insurance company and a healthcare provider. So it's actually the same thing is true for hospitals, doctors, anyone who is has a contract with an insurance company. It's secret, and the reason being is that the competitor, the other insurance company, they want to make sure that they don't know what they got in the contract. Representative Herbert.
What does break the link mean to you?
I'm sorry, Representative, could you repeat the question?
The representative of the manufacturers. I asked her a question is, if you were going to improve the legislation, what would you advise? And the advice came in the form of break the link, which doesn't mean much to me. So I'm trying to figure, what does break the link mean
Evidently
to
doesn't
you?
mean anything to him either. So.
I'm not familiar with that phrase.
So, no answer. We can. Okay. Anybody else? Seeing none. Thank you very much for your testimony. Okay, Holly Stevens from NAMI in support of the bill. Good morning.
Good morning, Chairman Hunt, members of the committee. My name is Holly Stevens. I'm the Director of Public Policy for NAMI, New Hampshire. the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. And I'm here today speaking in support of Senate Bill 555. At NAMI New Hampshire, we have heard from many Granite Staters who are not able to afford their medications. They resort to skipping doses, taking reduced doses, and delaying filling their medications due to their inability to afford their medications. Further, in June of 2023, the Center for Disease Control and Prevention, National Center for Health Statistics released a data brief, which I have included as a part of my testimony, regarding adults that did not take their medications as prescribed to reduce the out-of-pocket costs. They found that 8.2% of adults aged 18 to 64 did not take their medications as prescribed due to the cost. But what they also found was this jumped up to 20% for folks who had a disability. And it was 18% for folks that reported not feeling well or having medical conditions that impacted their health. We know that when folks don't take their medications as prescribed, it worsens their symptoms and could lead to costly hospitalizations that would be unnecessary if the medications were more affordable. There's been a lot of discussion about increase of premiums and this impact that this bill might have. Another thing that increases premiums is when people have to be hospitalized. Hospitalizations are extremely costly. And so if someone's not able to take a medication that could cost a few $100s, that results in them being in the hospital that costs thousands of dollars, that can also increase premiums. The sharing of these rebates will help some people be able to afford their medications that could end up preventing costly other interventions in the long run. And one of the things that's not in my testimony that I wanted to share with this committee is the fact that I myself out of pocket pay between $500 and $600 for my medications. Those are medications that I need in order to be able to come here and testify, because without them, I would not be able to work. I would not be able to function. So I just wanted to relate that it is a real issue, and it's an issue that impacts a lot of people, including people who come here and testify before you. We do urge this committee to seriously consider passing this bill, and I'm happy to answer any questions that you may have.
Representative Spears first, sorry.
I'm sorry I caved.
I thought you said
Question.
you were done.
I'm not done. I'm never done. I just take a break. Thank you for my allowing me to ask a question. I understand the point that you're making, and I appreciate that. But the drugs that we're talking about for which rebates are available are brand name drugs. And do you know that have no competition? Do you know if any of those?
They do have
If
competition.
this applies.
That's why they're joining the rebate, is
I
because they
understand
do
that,
have
but
competition.
of the drugs that people need that are covered by your organization that you deal with, do you know if that in fact is what is causing their copay problems?
I don't know that for sure, but I do know that there are a lot of brand name, brand new antipsychotic medications that are on the market, and I think the insurers would probably be better able to answer the exact psychiatric medications that are subject to rebates. But I'm also happy to talk with Ms. Kroll and Ms. Dunlap to find out and then provide you the information about medications that they have rebates for that are psychiatric medications.
Okay. Representative Burrows.
Thanks for taking my question. I thought it was an excellent point you raised about costs going up if these folks don't get their medications. Do you know if there's any studies been done about those costs versus, what the discussion we've had here about raising premiums?
I don't know, but I'm happy to look into that and
Yeah.
get back to you.
I think that'd be an interesting statistics to have.
I will absolutely
you.
look into that and
Okay.
get back to you.
Okay.
Representative McGee.
Thank you for taking my question. Thank you, Mr. Chairman. Are some of the medications that individuals you work with in the mental health community, are some of those medications long-term medications that then eventually need to be switched to newer brand name medications because when they're on them long-term, they develop cardiovascular or cardiac side effects like SSRI medications that cause cardiac issues, and then a newer one comes out and then the providers want to try them, and so they're very specifically subject to some of these rebates. Is that something that you encounter in the mental health
Thank you for the
community?
question. I haven't looked into that, again, because I don't prescribe medications. I'm a lawyer by trade, not a doctor by trade. So I don't know the exact treatment protocols that folks have. But again, it's one of those things that I'm happy to talk with some of the doctors at New Hampshire Hospital and get back to you on their experience with some of these psychiatric medications.
Okay, thanks.
Thank you very much.
Thank you.
Chair will call on Sabrina Dunlap from Anthem, who is opposition to the bill.
Thank you, Chairman Hunt and members of the committee. My name is Sabrina Dunlap. I'm Director of Government Relations for Anthem. We are opposed to SB 555. And I noted, I heard it was mentioned by the sponsor that Anthem does 100% at point of sale, and that did not come up during the Senate hearing. And I just want to note that I was actually here during the Senate hearing because you were discussing, I believe, HB 1081, one of the ambulance bills. So we were in fact opposed to this bill in the Senate, and we remain opposed to this bill. And I think the key issue is that this bill interferes with how carriers and PBMs make decisions that best serve their members with respect to point of sale rebates. Different carriers take different approaches to the amount of rebates to give at the point of sale, but that simply reflects the diversity of our members and approaches that we take in doing what is best for them in terms of access to medication and lowering costs. By forcing all carriers to give at least 50% of rebates at the point of sale, SB 555 takes away the flexibility to do what is best for our members, and it does nothing to address the high cost of drugs. The price of drugs are set by the drug companies. So if we want to tackle the high cost of drugs, this bill does not do that. So I think I will wrap up there, and I'm happy to take any questions. Thank you.
So if I understand your testimony correctly, you're saying is that we should pass enabling legislation to allow a pharmaceutical company, an insurance company, to choose what it wants to do with those rebates.
I believe that's the current state. So I think our current state of affairs gives carriers the choice to do what we think is best.
Right.
And make
so
business
that you
decisions
might
we
think
are
that some year that by advertising that you do rebates, that you might actually get more customers. You would use it as a marketing tool.
I don't know how to respond to that, but I appreciate that.
Okay. Thank you. Representative Brizelli.
Thank you. Quick question. So can you give us maybe some insight, if you know, as to why Anthem decided to, do the 100% rebate? What factors maybe went into that decision? Thank you.
That is a very good question. I am happy to chat more. I don't want to misstate anything. It goes above and beyond my understanding of math and actuary. I will say a lot of thought and different factors went into it, I'm sure. And I do believe it has not always been 100%. And so the simple answer is it's a business decision. Obviously, we think that's best for our members at this moment.
Representative Burrows.
Thanks for taking my question. This may be, and I don't know if you can answer this, but what do you think would be a better route to take rather than this bill to help somebody, for example, taking Humira, who's just got these outrageous costs and they can't do it? What would be a better solution?
Thank you for that question. I think it's a great question. I think I'll keep it simple and say I think the fundamental problem is the high cost of these specialty drugs. And I know that it is a complex system And so it's not just, pulling one thread or another. Everything is sort of woven together. So it's not necessarily that simple. But I do think at the end of the day, that's what we're all grappling with is the high cost of specialty drugs. And those prices are set by the drug companies.
Representative McVeigh.
Oh, thank you, Mr. Chairman. Would you say that keeping the current system would potentially allow a more competitive marketplace than what would be dictated in 555?
Thank you for the question. I think what we currently have is a system that allows carriers the flexibility to do what they think is best. So, yeah.
Well, would you say that would be more competitive and could in fact lead to more price breaks?
I don't know that. I don't know how to answer that question. I'm sorry.
Thank you very much.
Thank you.
Chair will call on Andy Lowe, who is in support of the bill.
Good morning, and thank you for letting me testify in support of Senate Bill 555. My name is Andy Lowe. I'm the Executive Director of the New England Rural Health Association. We are the Rural Health Association for all 6 of the New England states. We're the only regional health association recognized by the National Rural Health Association. We have over 450 members. We represent critical access hospitals, rural health clinics, rural FQHCs, human services, mental health providers, oral health providers, et cetera, around New England, work with leadership for all of those organizations. I'll make this really brief and summarize what was in my testimony. We know through the National Rural Health Association, the CDC, the Federal Office of Rural Health Policy, and others, that rural people are older, sicker, and poorer than their urban counterparts. There is a higher ratio of co-occurring chronic illness among rural residents than among the more urbanized population. So what I'm here to do is to ask you to think about this smaller group of people who could be left out of the equation when large numbers of people are used in a formula to calculate certain kinds of policies. Please just keep in mind that our rural residents are, in fact, with a higher volume of a higher percentage of chronic co-occurring conditions, which are costly to treat. They're costly for the people themselves. Let's keep in mind that, please, that these people are going to rely on methods of reducing their out-of-pocket costs for their medications. It's critical for them. We know that the downstream effects of people skimping on their medication, not taking their medication, is going to result in an overall cost of healthcare to the entire system. We know it's going to result in more ED visits, more hospitalizations, more rehospitalizations. So I'm asking you to think about that population, our rural populations around who may be somewhat underrepresented these days. I'll leave it there and thank you and take any questions.
Representative McHugh.
Thank you, Mr. Chairman. Thank you, Mr. Lowe, for coming in tonight. Do you think that in the rural communities that passing this bill might help improve outcomes from some of those chronic conditions that cost us the most?
I do.
Thank you.
So in New Hampshire, the premium set by an insurance company is flat all the way to the state, regardless of you're rural or not rural. So the only way I could say that, yes, if someone wants to pay a lower copay, is to choose a lower deductible plan, because the premium is flat to the whole state. It doesn't matter whether you're rural or not.
I'm accepting what you say. I don't see that there's a question there. I don't have any response. I'm merely pointing out that our patients are in need of some kind of relief.
Got it. Representative.
Thank you. My question is, you represent New England Rural Health Association? Yes?
The New England Rural Health Association.
Does the association deal with naturopaths or alternative medicines? Because what I've seen in my lifetime, so many people that take so many drugs that are unnecessary. One drug to replace the other drug for counteracting. Do you deal with any alternative, physicians?
I'm sure that we have some members who are in that organization. It's not probably a majority. It's not even close to a majority. We probably have some. I can't comment on that group in particular.
Okay, thanks.
Thank you very much.
Thank you.
Chair will call on Peter Bragdon from Harvard Pilgrim in opposition to the bill.
Thank you, Mr. Chairman, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's not-for-profit health insurance plan, serving about 50,000 of our state's residents, our friends and neighbors, with their health insurance needs. Here in opposition to the bill, as noted by the chair, I will start, though, by there are a number of areas where I agree with Senator Avard. Certainly, Harvard Pilgrim Healthcare supports the initiative to make the reporting more transparent. Section 1 of the bill, which is lines 1 through 21 on the first page. A few years ago, we passed a law that said, or you passed a law to require some attestation by the insurance companies that they are passing the rebate values on to members through the premiums, but there was no details. And so what the department is receiving is information that's not really helpful. So section 1 of the bill actually calls for more data to be brought, so then people can look and see, okay, does this benefit? We believe improving the transparency in the reporting would demonstrate how using pharmaceutical rebates to lower premiums benefits our policyholders. So I agree with Senator Avard on that. I also agree with Senator Avard that drugs are expensive. I think nobody disagrees with that. Unfortunately, I don't think this bill deals with and will address the situations he brought up. One of the people he talked about was a veteran. This doesn't apply to TRICARE, a federal health insurance program for veterans. Another one was retired. This doesn't affect Medicaid, Medicare, Social Security, people on retirement. And so that's something we see a lot of time is people using anecdotes that don't really apply. So I agree, though, with Senator Avard that drugs are expensive. And as a previous speaker said, we don't set the drug prices. The drug companies set the drug prices. So if the problem is the drug prices are too expensive, then the problem is with the drug companies themselves. And the third thing I agree with Senator Avard on is what he said about West Virginia. He said the 2023 rate filings show the same increases in rates in West Virginia as other states. And that's very true. Unfortunately, the law requiring the rebates to go back to the members at point of sale came in 2022. And I passed along out to you an analysis of West Virginia from ACAsignups.net that shows right in the middle there in the yellow column, 12.83% increase in insurance premiums in the individual market in 2022. The law was passed in 21. Insurance companies factored it into their rates for 2022, a 12% increase. Oh, and by the way, New Hampshire's increase at the time, depending on how you count it, was between 1% and 3%. I will agree with Senator Avard that since then, the increases have been the same because that first year of implementation increased the rates 13%. So we believe that, and I think the data shows that the passage of a bill like Senate Bill 555 will certainly increase costs. You know, we have very few tools available to help decrease insurance premiums. Everything else is pushing premiums up. We have very few tools that help us reduce premiums. Pharmaceutical rebates are one of those very small number of tools that we have. And we believe that Senate Bill 555 erodes the usefulness of that tool. Certainly, remitting the rebates at the point of sale will benefit some people. As was said, about 3% of drugs. So let's just assume for a second 3% of individuals may benefit from that, but it will significantly raise the cost of premiums or cost share for everybody else. And that's not just an issue of, oh no, I have to pay more money. I pay, I don't know, close to $600 a month. So I'd have to pay more. It's not really that. It's what happens, and I've talked about this before, on the insurance premiums, on the insurance cost sharing. When you squeeze one end of the balloon, right, if you take the cost away somewhere else, the insurance fairy is not going to show up and take that away. That has to be recovered somewhere else. It's going to be either higher premiums or increased cost shares, deductibles, copays, which will have the effect of people no longer getting insurance or getting insurance policies that they themselves end up in the situation where they can't afford to pay for the drugs or the doctor's visits or everything else. So it's not just the pure dollar issue, it's what it does to people and causes more people or companies. A company with 50 individuals, multiply all these effects by 50. And so they're going to reduce what they have. And so our goal is to see as many people as possible have health insurance, especially in the small group market, which we see as eroding over time. How significant would those increases to consumers be? Well, we saw in West Virginia, certainly it was 13%. Currently, and by the way, a number of insurance carriers in New Hampshire do this differently. So Harvard Pilgrim takes all the rebates we receive and apply that to premiums. Other companies, as we discussed, Anthem, sometimes reduces premiums via those rebates. Other times, they return the rebates to at the point of sale. For us, the value of the rebates we currently use reduce the premiums by about 7%. The value of the rebates is about 7% of the premiums. It's logical to assume that a bill that requires 50% of the rebates to go back to the consumer at the point of sale, that's probably roughly a 3.5%. If our total value is 7%, half of that is 3.5%. That remaining 3.5% has to go somewhere. And like I said, it's not the insurance fairy. I don't know enough about Harvard Pilgrim's rates. I know my rate, like I said, about $600 a month. So 3.5, that's another $20 a month for this member per month. So it's a significant increase in the insurance rates that people have to pay. In addition to the effect on the premiums that way, there's going to be administrative cost. We don't own our own PBM. One of the questions was, well, why does Anthem do it this way? And I don't know why Anthem does it that way. Sabrina doesn't know either, but there's a lot of factors involved, and I don't expect that she would. And hopefully no one asks me why Harvard does it the way they do it. But I do know this, that Harvard Pilgrim Healthcare is a regional, not-for-profit health insurance company. The others in this market are national for-profit health insurance companies who own their own PBMs. They're big enough, they're profitable enough, they can own the PBM. You get a ton of cost savings when you have PBM, and you get to charge people like us a percentage of the fees in order to do the work for you. So in addition to the money that's going to go back to the consumer at the point of sale, that's going to affect the premiums, there's an administrative cost that we have to pay for somebody else to do all this work to get the point of sale to work. And then finally, we have to build a cushion in there because there's a line in the bill, and I don't know what line it is, I'll look while I'm talking, $10,000, there it is on page 2, line 36. A fine not to exceed, well, fortunately, it's not to exceed. That makes me feel better. $10,000 per violation. So if we make an error with our point, and as was mentioned earlier, these are estimates. We don't know until halfway through the next year what those rebates were. We have an estimate of what they're going to be based on our contracts, but a lot of it is based on volume. We don't know what those rebates are going to be. If we give the wrong rebate to somebody, it's $10,000. It's $10,000 per violation. So we're going to make a big cushion on what we give back to the person at the point of sale in order just to cover our ass, if you pardon the expression, to make sure. I know, I'm sure you're
YouTube, remember YouTube.
It's the former senator in me had to throw that out. So there's to compensate for the fees, we're gonna have to add more money to that. So there's a significant increase to the cost, both in terms of the money taken away from the rebate pool that we use to reduce premiums, the administrative costs, and then this extra cushion that we have. In addition to that, Again, it's been pointed out, some carriers already do this. Anthem already does it sometimes. We don't. I mentioned, they can own their own PBMs. They're not non-for-profit. They're national. So there's a lot of things. Basically, what this bill does is it favors national for-profit insurance companies at the expense of regional not-for-profit healthcare companies. We believe it should be a free market. Let the companies decide what they're going to do. Let the companies decide, have some plans that do it this way and some that do it that way. Let some companies do it one way, let others do it another way, and let the market sift out what works out the best. I'll point out, that has already been pointed out, that the original bill apparently included the state health insurance plan for employees as well as Medicaid. And based on testimony at the Senate hearing, oh no, that will cost the state too much money. For those who say this won't cost the state any money, why did they exclude self-insured plans like the state's plan and Medicaid? Because it's going to cost a lot of money. And then finally, it's just the philosophy of insurance, right? We estimate what our costs are going to be each year, and we build our premiums based on that. And by spreading those costs across the entire base of our clients and our members. But in the same way, we should be able to do that with our revenues as well. We spread our costs across all the members. We spread revenues across all our members, and that results in lower premiums for everybody. So those are my main points. I appreciate your time. I'd be happy to answer any questions.
Thank you very much.
Thank you.
Okay, Heidi Kroll, you have the last word.
Good morning, Mr. Chairman and members of the committee. For the record, my name is Heidi Kroll. I represent AHIP, America's Health Insurance Plans, and I work at Gallagher, Callahan, and Gartrell. We are opposed to SB 555. We object to the proposed mandate in Section 2 of the bill that would require at least 50% of the drug manufacturer's rebates to be used to lower the patient's out-of-pocket cost at the point of sale. As you've heard, this only would apply in the fully insured market. It would not apply to Medicaid, Medicare, the VA, TRICARE, self-funded, obviously not the state employee plan. And we do also object to the provision in Section 2 that would increase the fines on carriers for each violation from $2,500, which is a standard throughout the New Hampshire's health insurance laws, so a fourfold increase up to $10,000. That seems excessive and unnecessary. The insurance department already has the statutory authority and the tools, should it need to take enforcement action against a carrier, including suspending or even revoking a carrier's license to do business in New Hampshire. Similarly to the comments that Peter Bragdon made, I would note that carriers don't object to the enhanced reporting requirements to the insurance department. Those changes were proposed by the department, and they are changes we are happy to live with. And I would also note that carriers do not object to the current law, which says that carriers must use the drug manufacturer's rebates to either lower the premiums at the point of sale or some combination thereof. So taking a step back, as you've heard, from some of the other speakers, health insurance carriers, in our opinion, are Americans' bargaining power, negotiating lower cost of care and lower drug prices for plan enrollees. And that includes negotiating discounts off the list price of drugs and being able to maximize the impact of those discounts for all plan enrollees by passing those savings through as reductions in premiums and other improvements to benefits. And I would say that I think carriers are getting 100% of the rebates from the PBMs. I think those contracts now are clear in terms of what's coming through. As you've also heard, these rebates are just on a select brand name drugs that have competition. So if there's no competition or if it's a generic, there's no rebate. And the reason that the manufacturers are willing to offer these discounts is so their drugs can get better placement on the carrier's formularies and be prescribed to more patients. And being placed on the getting better placement on the formulary means being on lower tiers, and lower tiers are associated with lower cost sharing. I'm going to skip over some of this because I don't want to repeat what other people have said. Most insurers in New Hampshire are using the rebates to help lower premiums and lower cost sharing for all enrollees in fully insured plans. And as you know, SB 555 would mandate that they would have to divert 50% of the rebates away from reducing premiums and over to the point of sale. And as you've heard from Harvard Pilgrim, for carriers that are currently using rebates to reduce premiums, this bill will increase the premiums for members. That's just plain and simple. When you redirect money away from one pot toward another pot, the premiums will have to go up. And as you've heard, Anthem is one carrier that is, has recently chosen to apply the rebates at the point of sale. And certain folks have pointed to this as a reason why the mandate in 555 should apply to all carriers. And I find that argument a little bit puzzling. And our current law promotes consumer choice, where the carriers have the opportunity in the fully insured marketplace to differentiate themselves from one another and offer different products that apply the rebates in different ways. The individual or the employer, whoever is purchasing the insurance plan, gets to choose whether they want a plan that uses the rebates to lower premiums or whether they want a plan that applies the rebates at point of sale. And so the fact is that the New Hampshire marketplace is functioning just as the current law intended. Consumers want and frankly deserve this choice. A national survey that came out in October of last year found that 91% of employers say it is important to have flexibility and choice in how their organization uses rebate dollars. Our current law allows for that choice, and our current marketplace is offering that choice. SB 555 would have the government intervene in this market and take away that choice for New Hampshire consumers. AHIP does not support that. And I think you have correspondence from the BIA, the Business and Industry Association, that indicates that they don't support that either. I also want to address the question of how patients who use rebated drugs benefit when carriers are using the rebates to lower premiums and improve the benefit design for all of the enrollees. So first, these patients benefit from lower copays or lower coinsurance because the rebated drug is on a lower tier. And in some cases, could mean that the tier actually brought them down from a coinsurance to a copay, which is also means savings for the patient. Secondly, they would benefit just like everybody else would from lower premiums. And the third point, which hasn't been mentioned here today, is that patients will see lower cost sharing overall when rebates are applied to premiums due to actuarial value requirements. So actuarial value of a plan is based on net expenses after rebates. So cost sharing across all medical and all drug benefits is reduced by rebates. So it's not just the premiums that are lower, but the total cost sharing is lower as well. You've been pointed to the New Hampshire Insurance Department's annual report, slide 49. Again, as you've heard, the rebates in 2022 lowered the per member per month cost of prescription drug expenses by $38, down from $147 per member per month down to $109. That is a 26% reduction. And as you've heard also at the bottom of slide 49, it talks about how the total rebate dollars in 2022 was $90 million. And so we're talking about redirecting as much as 45 million, half of that, away from premium reductions. We've also talked about the fiscal note on SB 555 as introduced, and how the Department of Administrative Services estimated that this bill would have cost them $20 million. Medicaid director estimated that it would have cost them at least $30 million. And so, as you've heard, the Senate was quick to carve out Medicaid and the state employee plan, but for reasons I cannot explain, was still happy to impose this mandate on businesses, New Hampshire's employers, and the individuals in the fully insured market. If this is a good policy, it's not clear to me why the state would be so quick to exempt itself, except that there's the cost associated with it. There's other costs. When the Trump administration adopted a similar point of sale rebate mandate in the Medicare Part D program, CMS's own actuaries estimated that it would increase premiums by 25%. It would have cost taxpayers between 200 and 400 billion dollars, and would have led to a $137 billion windfall for pharmaceutical manufacturers. Congress has continuously disallowed this federal rebate rule to take effect. I'll close and would be happy to answer questions. In closing, nothing in SB 555 addresses the root cause of high drug costs for consumers, which is high list prices set by manufacturers and their profit-driven motives. A recent AARP report looked at 217 drugs that were on the market from 2006 to 2020. For these drugs, the cumulative price increase over that time was nearly 280%, while the increase in general inflation over that same period was only 32%. When considering a bill like SB 555, please consider New Hampshire's individuals and small employers who are doing their best to keep up with rising healthcare costs and rising drug prices in the form of higher premiums and higher cost sharing. Those are the people who would ultimately pay for this proposed mandate, with numbers in the tens of millions of dollars per year ranged. So we support the new reporting requirements. We would be happy to live with the current mandate, and I'm happy to answer any questions.
Representative
Just a
Purcelli.
quick one. So, thank you for allowing me the question. What is, you talked about the formulary placement. I'm not sure we really talked about that a lot. So is that going to have we allow this 50% rebate, what impact would it have on the formulary placement, so that, will these drugs remain at a point where they're more expensive without the rebate changing where they are placed on the formulary list?
It's a great question. I think I want to get back to you on that question. I don't want to give you the wrong answer.
Representative McGill.
Thank you, Mr. Chairman. Thank you for taking my question. Since your client AHIP opposes sharing the savings with the patients at the point of sale, any suggestions on how we can improve outcomes and reduce those prescription costs? How do you suggest we do it?
Yeah, carriers have a lot of programs around medication to, working with their PBMs to try to ensure, to really work with patients to ensure medication adherence. But I think at the end of the day, we're trying to make sure that so those patients still would get the benefits as I described. They would have the benefits of lower premiums. They would have the benefit of overall lower cost sharing, and they're going to have the benefit of lower copays and lower coinsurance. But again, at the end of the day, if drug manufacturers really want to make their drugs more affordable for patients, then the solution is very easy. They should lower their drug prices for everyone. So we would put the question to them.
And thank you very much for your testimony. And with that, we'll close the public hearing on Senate Bill 555 and start 557 as quickly as possible. Do we have a system to let Senator Prentice know we're ready? Is anybody? Here she is. I see another card heading its way. Yeah, keep passing it along.
Feel good.
Okay, why don't we get started? Sorry about the delay, Senator.
Not a problem. Thank you very much. And I appreciate the opportunity once again to be before our House Commerce and Consumer Affairs Committee to introduce legislation. This is Senate Bill 557. This prohibits discriminatory actions against entities that are participating in the 340B drug pricing program. And so starting off with just talking a little bit about the 340B program, and I know I have one, maybe two folks here with me that have direct experience with this in New Hampshire and can talk why putting these protections in place is important. But according to the American Hospital Association, for more than 30 years, the 340B drug pricing program has provided financial help to hospitals serving vulnerable communities to manage rising prescription drug costs. So Section 340B of the Public Health Services Act requires pharmaceutical manufacturers participating in Medicaid to sell outpatient drugs at discounted prices to healthcare organizations that care for many uninsured and low-income patients. These organizations include federal grantee organizations such as certain types of hospitals, our critical access hospitals, our federally qualified rural health centers, sole community hospitals, rural referral centers. Really here in New Hampshire, we're talking mostly about critical access hospitals and the federally qualified health centers. But they serve this disproportionate share of low income and I know, I'm so sorry. I had a late flight and have not had enough coffee, so please excuse me, indigent populations. So this program allows 340B hospitals to stretch their limited federal resources to reduce the price of pharmaceuticals for patients and expand services to the patients and communities that they serve. Hospitals under 340B, the savings that can provide for other programs that also serve the uninsured or indigent population in terms of free vaccines, care, services in mental health clinics, and implement medication management and community health programs. So the money they save by participating in 340B, they can transfer it to other efforts that support this particular population. So according to HRSA, our Health Resources and Services Administration, which is the federal entity which is responsible for administering the 340B program, enrolled hospitals and other covered entities can achieve an average savings of 25 to 50% in pharmaceutical purchases. Despite significant oversight from HRSA, this program's proven record of decreasing governmental spending and expanding access to patient care, some want to limit that by scaling this back, getting in the middle of it, or drastically reducing the benefits that eligible hospitals and their patients receive from the program. So that is why a number of states, one of the states I was recently reading about was Nevada, have adopted laws that don't allow for any discriminatory practices to get in the middle of this particular program. So I am, as always, happy to take questions that you have. If I don't have the answer, I can either get it for you or have somebody behind me who has more experience actually administering this program speak to you. And I was just saying to someone that I feel like I'm here more than I'm at Health and Human Services. So this is a good year. All right. Thank
Yes,
you.
we do things a little differently on the Senate, it's from the Senate. in
No, I'm
terms of
talking
the-
about, like, I've been before your committee lately.
Yes,
Like,
'cause-
3 times in the last 2 weeks. It's all good.
So, who's doing the discrimination? What a problem are we solving here?
Well,
Who?
so one of the, and respectfully, thank you for the question, Chair Hunt, pharmacy, there's, pharmacy benefit managers who can be in the middle of the pharmaceutical companies. Pharmaceutical companies, manufacturers, and insurers, they can get in the middle of this and actually implement a policy that might, say, limit where somebody can actually access these particular medications.
So do you know if that's true here in New Hampshire, that some insurance company or
I
some
do not know
PBM
that if it's true, but we're trying to prevent it from happening based on what's happening in other states. And I would look to, I know that this has happened in other states, and that's why states are adopting this. This is a proactive measure, and folks from Dartmouth Health that are here, that actually run a program, can speak more specifically
see
to
my
their
good friend
experience.
Matt Wood here. So, okay,
The
all right,
friends to
great.
my left.
Thank you very much. I think we're all set.
Thank you.
It's
I do have to, I'm going to return to a committee hearing that I'm in, but you know how to find me if you have any questions. Thanks so much.
okay. So Matt, former member of the House Commerce Committee. and Kristen Chupka.
Thank you, Mr. Chairman. For the record, Matthew Hood, representing Dartmouth Health. I'm here with Kristen Chupka, who manages the 340B program for Dartmouth Health. We will try to help you catch up some of your time from your last hearing and be brief, which is just to say that Dartmouth Health does have members, critical access hospitals, disproportionate share hospitals, et cetera, in the Dartmouth Health team that benefit from the 340B patients for its patients. And then I will hand the microphone over to Kristen to talk about the program and the benefits.
Thank you, Mr. Chair, members of the committee. I'm very grateful for the opportunity to speak in support of this anti-discriminatory bill on the 340B program. As Matthew mentioned, I am the director of the 340B program for the Dartmouth Health System. But most importantly, I'm a pharmacist. I've been a pharmacist for 20 years, and this program that I've been involved in, not only at Dartmouth, but at another health system since 2013 has been one of the most rewarding experiences in my entire career. And that's why I'm here today to speak about why it's so important and get your support. As you are probably aware, the 340B program is a federal program designed to stretch scarce federal resources as far as possible, reaching more eligible patients and to provide more comprehensive services. So under this program, drug manufacturers offer their products to covered entities at a discounted price if they wish to have their products reimbursed by Medicare and Medicaid. And so that's really at the heart, right? And so as consumers of healthcare, I imagine that you go to your local pharmacy, you pick up your prescriptions. At Dartmouth Health and other 340B programs across the state of New Hampshire, they enter in with contracts with these local pharmacies to help procure medications through this program with the involvement of the covered entity so that these medications can get in patients' hands. This contractual arrangement allows patients to pick up their prescriptions at these local pharmacies so that the eligible entity may capture savings. And these savings are not additional, right? The number of prescriptions a covered entity can write is finite. And so these contract relationships allow us to capture where our patients are being served. Manufacturers started to prohibit the use of contract pharmacies for 340B discounts in 2020. It has rapidly and aggressively gotten very worse for us to be able to capture those savings due to almost 30 manufacturers now with different policies, and they continue to become less inclusive as the years have gone on. Patients do have the right to choose where they receive their medical care, and so where we're able to really benefit the 340B program is through our retail specialty and mail order pharmacies. We can't solely just use that, though, because of our rural environment and expect a patient to drive to our pharmacy when they may be already coming to our services that are an hour or 2 hours away. So that's why we want to embark on these contracts with our local pharmacies across the state. Some patients do opt for mail order if the distance is too great. And then furthermore, they may be required by the PBM to use mail order pharmacies across the US. And in Arizona and even in California, Dartmouth Health has patients getting care and pharmaceuticals shipped to New Hampshire from all the way across the country. Some of these pharma manufacturers are stating we can't embark on contract pharmacies out of a 40-mile radius of our covered entity. And in our rural environment, that's just not feasible. So there is a need to continue to maintain contract pharmacies to enable our covered entity to capture those savings for those patients who are mandated to choose other services or who have the right to choose where they want to go within our great state. So we talked about 340B savings. And so I wanted to share what Dartmouth Health does beyond charity care with the use of the 340B savings that we're able to realize. So I did mention that we have our system of retail pharmacies, and so patients who are underinsured or discharged may get readmitted due to the costs of these newer drug therapies. This shouldn't be news to anyone in this room. Many patients who are insured have those large deductibles and can't afford those medications. And so they return to the hospital for complications due to not being able to afford those therapies. Our pharmacies offer a full medication discount list, and this does include discounted medications to all. So my father from the state of New York, if he was admitted, he can go into that pharmacy and get that medication at that lower discounted rate. So it's not just for patients that are members or patients of our health system. And I think that's really the most important point of how we use that at our own pharmacies. Another thing that we do with the 340B savings is we support the treatment of over 200 hemophilia and other bleeding disorder patients with life-saving and critical therapies. Benefits there include nurse management care coordination, community-based education, and support for youth and adolescent with self-management skills and mental health support with this disease. Patients are living longer and longer with hemophilia, and so the better they can treat themselves, the better they'll be. We also support treatment of over 1,000 patients living with HIV, and we are the only Ryan White grantee holder in the state of New Hampshire. Benefits including in that Ryan White group are multiple care service locations throughout the state with continued expansion of PrEP support. We have a community health worker participating in the care of patients suffering from drug addiction and emergency funding for patients under the grant for needed medical services and supplies. We have developed and funded the Dartmouth Cancer Center Food Bank with 340B savings. We also support local businesses with grants direct to support housing growth for those who are homeless, adults with developmental disabilities, and access to transitional homes. We operate the Mary Hitchcock Memorial Hospital Addiction Treatment Program for those with opioid use disorder. And we are constantly opening new service lines. Especially notable is an express care clinic at New London Hospital that was filling a gap in that community. And so just to close, contract pharmacy is incredibly vital, and we need to maintain the HRSA allowance of letting us have those relationships with whatever pharmacies need to be able to care for our patients. And our system pharmacies are just not able to care for them all. And so by contracting where our patients are going or located where they live, we can bring that savings back and continue to fund initiatives as mentioned, like the medication discount lists, the opioid treatment, mental health, all the things that are forefront in our minds. And we want to continue to support community initiatives in the state of New Hampshire. And welcome
Excellent.
any questions.
Thank you very much. Representative Herbert.
Is there anybody, any entity or political entity, the 30 manufacturers who exited this program, I'm assuming, I'm pretty sure, a lot of their patents were funded by the federal government.
What is exactly your question?
Has anybody thought of bringing litigation to these people that are leaving the system?
Thank you for the question, Representative. There is litigation on both the federal and state levels pertaining to the 340B program. 25 states have initiated legislation on the state level to navigate the contract pharmacy space, 5 of which have enacted legislation to date.
Thank you.
Great. Thank you very much. Oh, do we have a Representative Spear?
You went very quickly. And even though I'm from New York, I couldn't keep up.
That's probably why I talk so quickly.
You said pharma has been instrumental in trying to shut these programs down. Can you elaborate on that a little bit?
Yeah, so in 2020, Eli Lilly started with the restriction by saying that covered entities couldn't access the 340B drug pricing point on their drug Cialis. From that point, other manufacturers jumped in and said contract pharmacy price points would not be available to covered entities. Mostly this is due to, I think, some language in the actual statute that they are leveraging to use this as a way to not allow to provide that 340B price point. There's a long pathway of the restrictions and how they have become tighter, but basically it's gone from one drug to the scope of drugs to no contract pharmacies. Then they asked us to report data. We did report data, and as soon as we did that after a year,
a good hunk of them, I would say about 9 or 10 of those manufacturers decided that we didn't need to submit data anymore and that they were not going to extend pricing anymore. So it's just progressively gotten worse since 2020.
So that's the kind of interference that you want this bill to try and fix.
Correct.
Thank you.
Mr. Chairman, may I just add very briefly for the committee, this is a fairly narrow response to the scope of issues that covered entities and pharmaceutical manufacturers and PBMs are navigating. This purely pertains to the contract pharmacy eligibility for the program.
Right, but the reality is it's a federal program, so technically it doesn't have too much force of law, but we want to send the message that we do not want them to continue to discriminate when it comes to this wonderful federal program, that it's a marvel that Congress ever passed it in the first place.
And yes, and in New Hampshire, we would want to send that message and be clear about what can and cannot be included.
Exactly. Okay, seeing none, thank you very much. Chair will call on Chris McCracken from AMSK Health in support of the bill. Good morning or afternoon now. You have to push the button on.
Sorry.
There you go.
Is that better? Thank you very much, Chairman Hunt and members of the House Commerce and Consumer Affairs Committee. I'm going to try and skip over a lot of things because you've already heard them. So I'm going to
Good.
just jump to a
Hit the
little bit more,
highlights.
a little more practical application. So I work at Amoskeag Health. We're a federally qualified health center. We have about 16,000 active patients in the greater Manchester area, and we're a 340B covered entity. Right? So this impacts us in a big way, and we're able to do the same thing that Dartmouth talked about, using the savings from that program to benefit our patients. And I'm going to tell you a story about a real patient, right? So we have an individual who lost her permanent employment, took a position as a consultant for a period of time, didn't have insurance, and had regular medications that she needed to take. She was a little more than the federal poverty level, so she didn't qualify to get any covered benefits, but she needed regularly to take her medication. So she used our 340B program to buy the medicines at a significantly reduced cost that she never would have been able to buy on her own. So some of the medications might cost $200 or $300 for a 1 month supply. And if any of you have individuals in your home who are aging and are taking medication regularly, you know how those costs can add up. But we're able to provide a formulary for this individual and buy these medications for them with a very discounted price. So we have a $4 formulary and a $12 formulary, and that's very affordable. So there's really great things that this program does, but when they try and limit where you can offer this service and how many pharmacies can cover this service for you, it makes it exceedingly difficult to do the right thing by the patients that you're trying to serve. So I am very much in support of this. It's no cost to anybody in New Hampshire, no cost to taxpayers. The discounts are provided by the pharmaceutical companies themselves. So as she noted to you, this has been under attack since 2020. And I think one of my colleagues from another federally qualified health center is going to talk to you about the real impact for us over the period of the time that this has happened. We've gone from a significant level, maybe $1 million down to less than $500,000 in savings. That's part of how we support the care that we provide to people who are indigent. So this is a huge impact, and who's going to cover that? Who's going to close that gap? Taxpayers aren't going to close that gap. We need to take advantage of something that was designed specifically for this purpose to help the people that are most in need. And the predatory aspect of what was kicked off by Eli Lilly is having a really deleterious effect on a lot of your safety net providers. So we sincerely hope that you'll consider supporting this and helping us do what we can to protect this program and the people that it serves. Thank you.
Thank you very much.
Thanks.
Got one card left. Ed Shinshala?
That was very good.
From Amoskeag Community Health Services.
Thank you. I want to thank Chris as a colleague, and the patients she speaks of are in a Manchester area and have uniquely urban challenges. I'm the CEO of Amanuensis Community Health Services in the North Country. We have 26 towns in our service area. There are 30,000 residents, and we see roughly 1 in 3 of our friends, family, and neighbors. To do that, we've strategically located 5 care delivery sites from the north of Whitefield down through Littleton, Franconia, come down 302 to Woodsville, and then cut across 25 to our Mount Musalaki Health Center, which has actually been a health center since 1957. So we're proud to continue that heritage. So when we think about the restrictions we've had, economically, it represents a 70-some% reduction in the savings. Over in the chart that I've given you, you can track that since 2017, most significantly, as was mentioned with Eli Lilly, with a restriction in the pharmacies we can use. And I think one of the things I've enjoyed about New Hampshire is we try to be regulatorily light. And if I would like to do business with Representative Hunt, that's free market. We can have a conversation, come to terms of what that looks like, depending on services and monies rendered. So I take exception that someone from not in New Hampshire is infringed on my ability to care for our patients and have free trade amongst the pharmacies to which I would like to do business with. When we look at the access, which one pharmacy am I going to pick for my patients? If I pick the Walmarts, there's one in Littleton, there's one in Woodsville, and there's one in Plymouth. Which patients do I tell? Do I tell Whitefield, well, if you want meds, you got to go to Plymouth? Do I tell Warren, you have to go to Littleton? So it's created an access issue independent of the economics. And when we think about taking our medications, that we look at taking our blood pressure medications, those are important to prevent stroke and to prevent heart attacks. And if we start heading down a stroke and heart attack road, it's not a good experience. The outcomes are not guaranteed, and we're in an emergency department, $750 to $1,500. A hospital day is $2,000. ICU is $10,000, and our primary care is $200. And blood pressure medications are pretty affordable, and especially with our sliding fee scale that we fund with the 340B, they're even more affordable. So there's a significant downstream economic impact. Bad experience, can't guarantee you're going to survive this, which is tragic, and it's not inexpensive, and it was completely avoidable as long as people from out of state don't tell us how to do business in New Hampshire. So when we look at our savings, in addition to the 340B investment into affordable medications, the healthcare system is complex. Anybody I work in it, and I still am challenged to sit down and figure out when I'm a patient how to do it. So we have patient navigators that help people address food security, transportation so they can get to appointments, sit down and sort through the myriad of insurance possibilities so they can make smart, intelligent decisions. And then we also put it into oral health. And currently we collaborate with Midstate. We provide the physical plant, they provide the staff. And we've matched our voucher to the $1,500 state Medicaid to make it easy. So Midstate has a sliding fee scale for dental. We have a voucher, and New Hampshire Medicaid. So I think we've done a nice job collectively wrapping around people to make sure they have good dentition. More than willing to field any questions on this, but just the ability to increase access to patients, going back to being able to choose which pharmacies we want to do business with. And it's really based, we follow the patient. You know, if a patient doesn't go there, we don't contract with them. So I thank you for your time and your interest in this area. We try to keep your friends, family, and neighbors as healthy as we can. Thank you.
Thank you for your service. Representative William.
Thank you, Mr. Chair. Thank you for taking my question. What was the question? Do you deal with the PBMs?
We do. And in the testimony, I believe that I documented, we had an in-house pharmacy, and due to what I would consider I'll take the adjective, due to the contract we were provided because we were a 340B covered entity, we got a contract different than if we had not been. And what that means is we're an open pharmacy. So if you're our patient, we behave within 340B. If we not, we still get you your medication, but we have to purchase it at 80% of average wholesale price. The contract was taking a piece of the savings. So we lost savings on our patient, but they took so much savings that if you're not our patient, we actually lost money. We couldn't even break even on that. I was taught that you can re-engineer and not hurt people's lives. So I worked with Littleton Regional Hospital. When we closed our pharmacy, they opened a retail, and they have a wonderful meds to beds program. If your hospital doesn't, please have them contact me. You leave with your medications. So when I had my hip done, I left with a blood thinner and an antibiotic, and I went home with a bag of ice. My wife didn't have to leave me in the parking lot, or God forbid, leave me home alone, which is never a good idea. So that was very frustrating. We now have a pharmacy on site. It's Genoa. It's a strategic partner. So I didn't give up. Patients have access. It's just not my pharmacy. But that was predatory contracting. Very frustrating.
Thank you.
Seeing no more questions, we thank you very much for your testimony.
Thank you.
And having no more cards, I will close the public hearing on Senate Bill 557 and see you all back here at 1:15. Okay, we'll open up the public hearing on Senate Bill 196. And I assume we have a pink card.
Oh, you do not. I will get you a pink card.
Okay. No, don't do it now. Don't do it now. No, please do not do it. Okay.
All right. Good afternoon.
Oh,
Mr.
yeah, this bill's dead, right?
Indeed, it is actually. So let me introduce this bill. This is Senate Bill 196, and this bill was brought forward because there were some issues initially regarding the interpretation of statute by the Department of Insurance as it applies to rideshare companies like Uber and Lyft. However, the companies and the department have agreed on an interpretation of statute, and at this point, the bill is no longer necessary. Therefore, I ask the committee for an ITL vote.
Perfect.
All right.
Thank
you, Mr. Chair, committee members.
You're on a roll. Hope you'll do that again later today.
I'll see you in an hour and a half. Thank you.
Okay. So, James, you're here for the next one too? You're all set with that one, right? Okay. I see you. You're all hiding back in the corner, right? Okay. All right. And yeah, so I opened the hearing and I closed the public hearing on Senate Bill 196 at 1:20. Boy, we're right on schedule now. Senator Fenton.
Thank you for having me, folks. Happy to be in front of you. Good afternoon, Mr. Chair, members of the committee. For the record, I am Senator Donovan Fenton. I represent District 10, and I'll be very brief. I'm here before you today to introduce Senate Bill 325, which would establish a committee to study the issue of insurance appraiser licensing. The reason for this bill is that we are seeing a disconnect between the damage appraisal of vehicles and what is actually going to cost to fix the car. Auto damage cost analysis has become highly skilled, and because cars are far more complicated now. The cars also have to be rebuilt to spec and meet manufacturer guidelines. You don't want your car to be rebuilt missing things. In some cases, we are seeing underpayment of the actual loss. What that means is the auto body shop does the work to make the car new, but the payment for the damage said, you don't need to adhere to certain specifications. So who is right? It's a good question. One way to fix this is to look at licensed insurance appraisers. This way, the appraisers are not potentially influenced by who the insureds are who hire them. And this is a study committee. I'm happy to take any more questions you have.
We do have a question.
Sure.
Representative Burrows.
Thanks for taking my question, Senator. Why a committee, which a lot of us don't feel go anywhere a lot of times, versus a bill?
Well, studying committees are, thank you for the question. Study committees are important. I think it's a complex issue. There's a lot of stakeholders involved, and I think we want to hear everyone's side of things before you make this bill. You're going to hear a lot from the auto bodies. Auto body shops are small, independent owned. Oftentimes, they're small family businesses, generational businesses, and I think we should do everything in our power to help them. And this bill was written with the Department of Insurance. We wrote it together. A lot of parts of this, and auto body work has changed drastically. I'm not sure if any of you have gotten work done on your vehicle before, but now you use specialized tools and equipment and software. So it's a very intricate profession now. Yeah.
So I have to admit, I was reading this bill and I did not realize it's about auto body because it doesn't say auto body. So we have a licensing of insurance appraisers. We have a license for this.
Are you asking if we have it now?
Yeah.
Not independently. That's not what I understand. No.
Oh, so we have no licensure of appraisers.
Independent appraisers.
But
correct.
and then A and B is because this is kind of open ended, but you wanted to be only for auto body.
No, I mean, well, first of all, Mr. Chair, thank you for the questions. Not necessarily only auto body. That's the impetus of the bill. This is strictly dealing with independent appraisers appraising auto body damage.
Independent, so that means they're not working for an insurance company?
They are, but they're not employed by the insurance company. Think of it as like a 1099. That's the way I understand it.
Okay, so they're hired by the insurance company to do the okay. Oh boy! All right. Well, I
Thus the study committee.
I did not get that when I read this study committee, but now I get it. All right. Any other questions from the committee members? Representative McAleer.
Thank you. Would you believe in November?
Is your mic on?
Thank you. Would you believe in November I hit a deer with my car? Oh dear. And the initial appraisal came in for it was $8,000. I got my car back 8 weeks later and the final bill was $28,000. So a big difference. Thank you.
I would believe it's kind of a rite of passage if you hit a deer in New Hampshire, it seems like. And I will say this, there's no reason to be opposed to a study committee to look at this disconnect. Just like what you said, this stuff is happening. You just heard testimony, or a question, I should say, about, the disconnect between an appraisal, what someone else says. So I think looking a little further into this wouldn't hurt anybody.
Yes.
So the way I'm understanding is this is a study committee. So, and what you're looking at is having independent appraisers. This wouldn't, the committee could find that companies could have their own appraisers. This would just be an independent appraiser.
Correct.
I think that's a great idea. Thank you.
Representative Spear.
I'm not exactly sure who to address this to. How would this study committee get started? I mean, is it looking for volunteers? I don't know how they work.
Oh, okay, yes. We'll talk about how a study committee
Okay.
works.
If you'd like to volunteer, that'd be great. Yeah. Put her
Ignorance
on
is
it.
bliss. Yeah, right. You want her. Right. Okay. All right. Representative Petrusek, and then.
Thank you, Mr. Chairman. Senator, I have a question relative to the makeup of the committee. I was wondering why the insurance commissioner or the commissioner's designee was not on the study committee. Thank you.
Great question, Representative. If the House feels so inclined to amend it to add him, that's a great thing to do. I think we all love study committees, especially during the summer.
Evidently not, because you only have one senator.
Well, it's if I could convince some colleagues, I would. And it's a very bipartisan bill. I will add that. No, I've talked with Commissioner Betancourt on this bill. We wrote it together essentially. So he's very aware of it. Yeah, if you wanna throw him on there, feel free to.
Follow-ups?
Further question may inquire?
As the first name member, would you be have any issues with you being the
I plead the
senator?
fifth. No, I'd be happy to serve on it. It's I work a lot in my daytime job with auto body, so I know the industry very well.
Thank you.
Absolutely.
Yeah. Would you believe that I had a Toyota that I bought from?
I know that I would believe that, sir.
And don't you know that auto dealer who I bought it from said, yeah, mice eat the cables of Toyotas all the time, and you should just call your insurance company and have them pay for it.
Well, you buy a new car, you get a mouse with it. That's what you do. You send them home with it.
I have a quick question.
Okay. Oh, Representative Priscelli. Yes.
Thank you. Thank you for taking my question. I just help me understand why you think licensing insurance appraisers might help this issue. What is your thinking of?
Sure. Appreciate the question, Representative. So, we're looking at just studying the issue because there's clearly a disconnect. I've heard from a lot of auto body shops, and there's actually some auto body shops behind me that you're going to hear from as well. And I think they can describe the issues and problems they're facing a little better than I can because they live this day to day. After, they spend time with the insurance companies, these appraisers. That's part of their job because they're valuing the damage on the vehicle, how much it costs to fix, labor costs, things like that. So I think, a way, and having these conversations with the auto body shops and individuals in the insurance companies that, perhaps these individual appraisers, maybe there's a disconnect there, and maybe that's why we need licensing for these individual appraisers. I don't know if that answered your question, kind of.
Okay. Well, there's always John Hunt's rule of licensure. We create licensure so that we can take it away from you when you're bad. Okay. Thank you very much.
Thank you
Senator.
all so much. I got to zip back to my committee, so thank you.
We understand. All right, Steve. How do you pronounce Prisker?
I know. That's what I mean. On the committee.
And welcome back to the House Commerce Committee.
So I'm here right now as a consumer mainly. I've had numerous vehicles be damaged over the years. The appraisers that the insurance companies hire are not impartial.
Turn your mic on.
Yeah, turn your mic on. And you push that button down below.
Right there.
And can you state your name, please?
Yep, Steve Peaceman. Over the years, I've had numerous claims, insurance claims, and the insurance appraisers come out that the insurance companies hire, and they all tell me that they are writing appraisals according to what their insurance customers tell them to do. Appraisers need to be disinterested, impartial, and independent. There is a New Hampshire law already on the books. It's underneath the fraud section. I have brought that to the attention of the insurance department in New Hampshire here.
They wrote me a letter back in February 2nd of 2023 that we have already, what they stated was, we have already told you we do not regulate insurance appraisers. So I went to the Attorney General's office for help. They told me that they do not interfere with the insurance department. That goes underneath the insurance regulations. I decided to take it upon myself and sue an insurance appraiser. The judicial court in Keene told me it all falls back to the Attorney General's office. So I went full circuit with this whole damn thing already. I have a car rental business. I probably have half a dozen different claims a year. I have one outgoing right now with Progressive. Progressive came out, I think they've up to 6 appraisals on my vehicle. This is one of their staff appraisers. They cannot name a shop that is willing to repair my vehicle for any of the insurance appraisal prices. But then again, they're withholding the money that's owed to me on my claim. They tell me that I have to get my car repaired, which my car, I don't want it repaired, so I'm going to go trade it, probably to Fenton's family, and get a new vehicle. I have a couple of appraisals here for my body shop business. Now, I'll go put my body shop hat on. This independent appraiser says he follows a code of ethics on their website, that he's going to be impartial, independent, yada, yada, yada. He was hired by Vermont Mutual to appraise a vehicle, my shop lot. Okay? He appraised it at $53 an hour, straight across the board for labor. No calibrations, no pre and post scans, no safety components checks, nothing. Then my customer filed a claim for the same accident. Concord Group came up, got involved. Same appraiser, same vehicle, same damages. He comes out, writes an appraisal for quite a bit more money at $60 an hour and $65, but then includes for all the pre and post scans, calibrations and whatnot right up front. Why is this appraisal, the same vehicle, have 2 different appraisals, 2 different prices, 2 different insurance companies involved? What is going on? In the insurance department, lets this go on daily. If the insurance department did their job, we wouldn't be here today. Got another appraisal here that involves Geico. This was a fairly new Toyota 4Runner. This one involves a brand new GMC 1500. Customer told me their truck is over at the GM dealer. I went over and looked at it last week. Geico will fight tooth and nail not to pay the shop's body labor rates or the repair procedures that GM requires. The GM dealer can just write a one-line, or Geico can put on their appraisal a one-line estimate. They'll pay $115 for labor, but when it comes to the body shop labor, $60. What is funny is some of this labor that they included in here from the dealership, my shop completed for the dealership because the dealership couldn't do it. But since the dealership billed it out, the insurance company will include it on their appraisal. But when it comes to a body shop, they won't. The repair procedures, all the appraisers have access to them. If they don't have access to the repair procedures from the vehicle manufacturers, then they shouldn't be doing appraisals. These cars are computers, rolling computers. They're got so much technology built into them, and the insurance appraisers, either A, they're stupid, or they're just taking upon themselves, taking directions from their insurance companies to underwrite the value of the damages. Insurance appraisers should be appraising vehicles. That is it. They should not be adjusting losses for the insurance companies. Insurance appraisers appraise vehicles, according to Assistant Commissioner Nyhan, that's what he told me on a phone conversation, and adjusters adjust claims. What is happening nowadays is the insurance customers of these independent appraisers are being provided guidelines, pricing structures of how to value these damaged vehicles. So basically, they're adjusting the appraisals to the terms and conditions of the insurance contract. That's not the job of an insurance appraiser. A few years back, I applied for a part-time position for extra pocket money for one of these third-party appraisal companies, an independent appraisal company. This company was mainly doing handling appraisals and claims for USAA. And I got my hands on a copy of the paperwork from that appraisal company, and it made me sick what they wanted me to do and how to value people's, damaged vehicles. It's fraud, what is happening out there. It is plain fraud. And the New Hampshire law supports that, what I say here. The problem is no one wants to enforce the laws out there on the books. I mean, I hate to be up here asking to start licensing independent appraisers, but something's got to be done. Either A, the Attorney General's got to do their job. B, the insurance department's got to start doing something. But we shouldn't be up here. We shouldn't be seeing the New Hampshire insurance consumers, vehicle owners. I heard a fellow up here saying his initial estimate was $8,000. Then it goes to 28. Yep, I see it every day. These insurance appraisers, they'll come out, they'll write 5, 6, 10, 8 different appraisals. They'll start off at $1,000. Next thing you know, at the end of the day, they're up to 10,000, and they still short pay the insurance consumer another $3 or $4 grand. I got a couple of appraisals here from Liberty Mutual. They're famous for it. They don't want to send anybody out to look at their car. They don't want any appraisers, and they call their paperwork appraisals, and the insurance department considers them appraisals. And it's not uncommon for them to have 5, 6, 7, 8 appraisals go from $1,000 to $8,000 to $10,000. It's ridiculous what is going on in the world. Very frustrating as a consumer, seeing myself yearly, monthly, take money out of my pocket to pay and get my cars fixed. And then to see my body shop customers do the same thing. Any questions?
Oh, we do have a question.
So, you've been around Keene your whole life.
Yep.
And we all have long memories. And so my question to you is, would you liken this situation to the good old days, bad old days, maybe when you went to Keene Co-op and they gave you a loan and made the appraisal fit the amount of money you needed before real estate appraisers were licensed? Is this that same situation, except they're doing it in reverse, where they're underpricing the cost because they're trying to save the entity money? Is it similar to that? And should these appraisers be licensed like real estate appraisers, or is this a different scenario?
Pretty much the same thing. I had a loss on one of my homes 3 years ago. Foundation collapsed into the lake. Insurance company sent their appraiser out. They determined it was not a claim that I could collect on. But at least the appraiser had some ethics, that came out. And these appraisers that come out here to look at vehicles, there's no ethics or anything. And you're talking about them undervaluing claims. We have this appraiser here that for Vermont Mutual and Concord Group, he'll inflate claims too, to punish the consumer, the vehicle owner, and the body shop. For instance, we repaired a fairly new Hyundai in the last couple months, probably 2 months ago. Quoted roughly $9 grand to fix it. But since we and my customer wouldn't agree to their labor rates, that he wrote up an estimate 27 grand just to make the car go away. So we fixed it, had it sitting out front, for the customer to pick up. He was going to make up the difference, but the insurance company says, no, don't want to set precedents with that. Then the guy writes an appraisal and overflates it just so the car goes to the auction. Another case, State Farm. That was one of the local insurance companies based right here in Concord. Another one, largest company in the country, State Farm. Yep, 22 Honda Accord. Since we refused to put a used steering rack, salvage steering rack, salvage tie rods on the car, and my customer wouldn't agree to the labor rates, my customer says, no, you're rebuilding it the way Honda says. We ordered all the parts, getting into the repairs. State Farm comes down, totals the vehicle, overinflates an appraisal, makes it go away. So it goes both ways. Goes both ways. Shop doesn't want, customer says, well, we want it fixed right. Insurance company's going to push back and they're going to punish you for it. Insurance fraud works both ways. Yeah.
Okay. Thank you very much for your testimony. Did you have written testimony? Here we go. Okay. Okay, I have one card left. George Russo's representing the New Hampshire Domestic Insurers and APCIA. I didn't know you were involved with the CIA.
I need a bigger card to put their name down. So thank you, Mr. Chairman, members of the committee. George Russo, I'm a lawyer with Orrin, Reno, and Concord. And as the chairman said, I represent the New Hampshire Association of Domestic Insurance Companies, which is a group of some local companies, smaller companies, and a few larger companies as well that write a lot of insurance business in New Hampshire. And APCIA is the American Property Casualty Insurance Association, which is a national trade association. I think the prior speaker has given you a good taste of what a study committee would be like on the issue of licensing appraisers. And if you want to hear more of the same, then you can go ahead and serve on the committee, and I won't interrupt my short summer to be present to listen to some of the testimony and offer another view. But let me just say that a few things about what appraisers do, what insurance adjusters do, and what insurance companies do with respect to adjusting losses. And then you can decide whether you think it's worth, studying the possibility of licensing appraisers. First of all, appraisers are hired by insurance companies to put a value on property. And there's appraisers that work with personal property, artwork or jewelry or equipment or other things that are insured and that are the subject of loss, as well as real property, damage to roofs or anything else with respect to the property. And also, again, and that's what we're here today, I think, to talk about, although the bill is broader than that, automobile insurance losses. And so they are not licensed, but claims adjusters are licensed. They are the persons who, by statute, it's RSA 402B, investigate, negotiate, or settle property casualty claims. That's what a claims adjuster does. Insurance appraisers work for claims adjusters, and their job is to obtain facts surrounding a claim or to furnish technical assistance to a licensed adjuster. So that's how the system works. And appraisers under the claims adjuster statute are not required to be licensed. So what happens if a claims appraiser does a poor job, let's say unethical, as the prior speaker suggests they all are, or incompetent, as they apparently all are as well? Well, then that appraiser is responsible to the adjuster who adjusted the loss. The adjuster is licensed. The adjuster is the one who will be called upon to make that claim right. And furthermore, the insurance company that employs the claims adjuster is licensed by the department and subject to the laws of insurance, as is the public adjuster, including the Unfair Trade Practices Act that governs the conduct of adjustment of these claims, and a rule that goes into great detail about what the responsibilities are of the company and the adjuster to treat consumers fairly when they have claims. So I know this is familiar to some of you, Mr. Chairman, you've been through, and you've also been through this sort of issue before, where when you strip it all down, there are some auto body shops who believe they should be paid more for the work that they do. That has really nothing to do with this. What this bill is about, licensing appraisers, isn't going to have any effect on what the adjustment of the loss is, which is, again, the insurance adjuster that does that under the authority granted to the adjuster by the insurance company. But just to briefly go over what this law is well developed as and has been around since the invention of the automobile, because automobiles have been involved in accidents, and people have dealt with the issue of how to respond to those accidents and the responsibilities of insurance companies to do so. So, under the law, if an automobile is damaged, it is the insurer is required to bring it to its pre-accident condition. They are required to use parts that are of like kind or quality. The insured has the ability to pick whatever repair facility the insured wants to go to. If there's hidden damage that's not disclosed at the first estimate, but later disclosed, that's an obligation of the insurance company to pay for the hidden damage. The law sets forth what the time frames are for the adjustment of claims, 10 days to respond to a claim, and then thereafter time periods to conduct the repair. A lot of times now, these repairs, and it's no fault of an insurance company or of the repair shop, but these supply chain issues still exist, and there's plenty of stories now where the parts just aren't available, or the body shop is backed up, and there's a lot of delays still in repair of vehicles. But again, that's beyond the scope of what I read this bill to attempt to address. So if you want to have a study, I think that's, I'm not delighted to spend the summer here, but or even any part of it, but I'm willing to. The bill calls for a committee to meet within 45 days of the effective date, and then to report ultimately by its recommendations by November 1 of 2024. So my only suggestion to you is that this ground has been covered and covered in a great deal of detail. I'm not optimistic that a study of this issue is likely to bring about any change in policy, but again, if you want to study it, so be it. Thank you.
Okay, Representative Burrows has a question.
This is a would you believe that the previous speaker did not disparage all appraisers and say they were all crooked? He was giving examples from his own experience.
I'll accept that.
Seeing none, thank you very much.
Thank you.
I thought we were all done, but we do have another card here. Dan Bennett from the New Hampshire Auto Dealers Association, who would like to speak in support of the bill.
Good afternoon, Mr. Chairman, members of the committee. Dan Bennett. Sorry for the late submission. I was tied up downstairs. New Hampshire Auto Dealers Association is a trade association representing the motor vehicle industry. About 500 businesses in New Hampshire, about 14,000 employees. We make up about 24% of the state's retail sales. We also represent about 60 collision repairers in the state. Some are associated with franchised automobile dealers, but many are independents. I'm proud to say that actually more of our body shop constituency are independent shops. So we're here in support of the bill. See no harm in a study committee, and actually some practical solutions probably could result that would benefit not only the shops, but also the carriers, and most importantly the consumers, if efficiencies were to be found and gained in the repair and appraisal process. Obviously, vehicles are really complex. You can't do an accurate estimate just by snapping an iPhone picture and emailing it to someone. You have to tear the vehicle down, get into it, and find out what's broken, hidden structural stuff. So photo estimating is problematic for the industry, and it significantly slows down the process by injecting this supplemental repair and delaying the cost. So you submit for reimbursement, and then another one, and another one, and it significantly slows down the process for the repairer, but more importantly for the consumer too. And you know, if y'all are familiar with your automobile insurance policies, your rentals only have so many days, right? So the longer the process goes, the more likely you're getting closer to that, you know, rental window where it's no longer available, and then the consumer has to go to the hip and pay out of their own pocket. So if there's a way to speed up the process, speed up the appraisal and estimating thing, that's a win-win-win. So it's our opinion that this bill is well intended, and again could yield some positive results for you know, the three-legged stool, which is the carrier, the consumer, and the repairer. So with that being said, we hope you support the bill, and I'll take any questions if there are any.
Guess we're all questioned out.
Thank you, sir.
Thank you. Having no more cards, I will close the public hearing on Senate Bill 325. And since we're a little bit behind schedule, we'll move forward to Senate Bill 137. And Daley is going to introduce the bill for Senator Lang.
Good afternoon, Chairman Hunt and members of the committee. My name is Daley Frenette, and I am the Senate Majority Caucus Director. I'm here to introduce Senate Bill 137 FN on behalf of Senator Lang. Senate Bill 137 FN is a request of the New Hampshire Craft Brewers Association, and the bill would repeal the nano brewery license, and it would create a 4-tier licensing and fee structure. So domestic sales under 500 barrels per year would be $240. Domestic sales of 501 to 2,500 barrels per year would be $480. Domestic sales of 2,501 to 15,000 barrels per year would be $1,200. And domestic sales of more than 15,000 per year would be $1,692. So transitioning to an introductory beverage manufacturing tier would likely generate revenue because licensees would have an option to pay an additional restaurant or satellite fee. From an enforcement perspective, this bill would help to simplify RSAs and allow for better communication between brewers and the New Hampshire Liquor Commission. The new license structure would allow for small businesses to operate under a standard set of rules and regulations while having them pay a larger fee as they grow and increase their sales. This legislation would help bring greater parity to the licensing structure, as well as provide a consistent experience for customers going from one location to another. The Senate amended the bill to make a small change of the effective date from July 1st, 2023 to July 1st of 2024. So thank you for allowing me the opportunity to speak this afternoon. I believe there are some folks here from the Craft Brewers Association who should be able to answer any questions you have much better than I can.
Great. Thank you very much. So we'll have Andrew Provencher, who is going to represent the New Hampshire Brewers Association.
Thank you, Chairman Hunt. For the record, my name is Andrew Provencher. I'm here on behalf of the New Hampshire Brewers Association. We have a number of breweries that are here today to speak in favor of this legislation. Wanted to just kind of highlight a couple items. CJ Hayes, who's our executive director, is not in the state today, but certainly will be available soon if there are some additional technical information or questions that folks would have. The NHBA represents 86 independent craft breweries in New Hampshire, many of which are small and family owned. We have a number of nanos, brew pubs, and beverage manufacturers, and everyone agrees that this legislation is a great step forward and the next step in New Hampshire's simplification of our license fee structure. The nano designation has been very popular and successful and has served the industry extremely well. And we don't see this as much as a elimination of the nano as a reclassification of the nano into this tiered structure. The fees that were just mentioned are the same fees that are in place now. There are some circumstances where you could have a current nano who will end up having to pay a little bit more money after this. There's some scenarios where you have a beverage manufacturer who will pay a little bit less money. But as you see in the fiscal note, we don't believe that there'll be much of a major change in regards to income. We do think that this will help simplify this process a lot. It also allows a brewer to get into the business at a tier 1 level and then kind of level up as they maybe get more popular or they're selling more beer and move their way up through the structure, as opposed to starting as a nano, having to get a new license type and switch over to a beverage manufacturer. One thing we did want to mention when reading it is that we do think there's a small clerical error that we would ask the committee to potentially fix for us. And this would be on line 23 and 24 of page 6. It mentions, it puts a annual production limit, and we believe that that probably should be struck. So it currently reads, no unopened container sold by a beverage manufacturer license with an annual production under 2,500 barrels annually shall be opened or consumed on the licensed premises. We believe it actually should read, no unopened container sold by a beverage manufacturer licensee shall be opened or consumed on the licensed premises. And I believe the New Hampshire Liquor Commission will be able to speak to this as well. Otherwise, we hope to earn the committee's support, and we feel like this would be a great step in the right direction for what is a growing industry and a strong part of the New Hampshire economy. Happy to answer any questions, and like I said, we have a few brewers who will be speaking shortly. Awesome.
All set. Thank you. If you have written testimony, the clerk would appreciate it. Okay, Drew, I let you hang in too long last week, so we'll call you up sooner this time. Yes, come on up. Drew Klein, representing Josiah Bartlett, is talking about how important we need to be efficient.
Mr. Chairman, I see I've testified a lot before this committee. Thank you for the opportunity, and members of the committee, and I'll try to be pretty brief. I want to give you guys the Josiah Bartlett Center with the New Hampshire's Free Market think tank, and our take on this bill. I mean, our mission is to promote economic opportunity and prosperity for all Granite Staters, and we see this as hitting both of those from the opportunity standpoint and the prosperity standpoint. So, as some of you know, you've been doing this brewery legislation for a while. Vermont and Maine really got way out ahead of New Hampshire on craft breweries for decades. And we fell way behind. And the reason for that was their regulations were better. And it was easier to start small breweries and grow them in those two states. The creation of the Nano Brewery, Nano Plus, and microbrewery licenses back in the day were really, really helpful for New Hampshire. And it really grew New Hampshire's craft brewery industry. But now we're seeing that those rigid categories are creating problems for the industry because unlike the other states in northern New England, our Nano and Nano Plus hold brewers in those license categories. So if you're a startup, you want to start small, you're locked into that rigid category. That's not the case in Maine and Vermont. So we went and looked at those statutes in Maine and Vermont, and it's much, much easier to start and grow a beverage manufacturing business there. So in Maine, for example, you get a brewery license, which allows the manufacturer of more than 50,000 gallons of beer, and they do it by gallon there, and a license fee of $1,000, or a small brewer license, which allows you to make up to 50,000 gallons with a license fee of just $50. That's it. That's their two categories. Very easy. In Vermont, they have slightly different. You obtain a beverage manufacturer license for $285 annual fee. If you want to then sell beer that you make on premises, that's a separate license. It's a retail license for $70. Then they have other retail licenses for wine and spirits, but you're not locked into that startup category. Whereas in New Hampshire, you're at a big competitive disadvantage. If you want to start as a Nano or Nano Plus and grow, unlike in our neighboring states in Northern New England, you have to go back and apply for a separate license. So it's very burdensome. So our breweries are again at a disadvantage to the competitors in Northern New England. And it's one of the reasons why among craft beer aficionados, Vermont is actually a pretty legendary state. People will travel from Massachusetts through New Hampshire to get to Vermont breweries. Now, thankfully, over the last 20 years, we've been able to add a lot more craft breweries here, but the way we regulate them is hindering the growth of the industry. So as we look at this, we look at this particular bill creating the 4-tier system. Boy, is it much smoother. It's much easier. So you can start a business in New Hampshire, and instead of being locked into that rigid category where you have to go back and apply for a separate license, you want to grow, great, you just go back, you pay a bigger fee. And this is one of the really, I think, genius parts of SB 137, it's not just about the barrels. It's not just about growth. It's about what you can offer your consumers, right? So the consumers don't care. And I know some of you have heard this from brewers before, and you'll probably hear it today. They don't care if you're a craft brewery, a nano brewery, a brew pub. They don't even know these categories. All they know is my neighborhood bar, my small town, craft brewery. I want to go and get a good beer and some food. They have to tell their customers all the time, sorry, we can't sell you wine. Sorry, we can't sell you a beer from another brewery. Sorry, we only have these limited options. And the customers don't understand because they're not locked into that rigid categorization in other states as much as we are here in New Hampshire. What this bill does, it allows you to pay different fees for different tiers and offer a much different variety. So it's so much more flexible for the entrepreneur and the business. When we look at this from the Bartlett Center point of view, just from a regulatory standpoint, it just makes much more sense. It's more intuitive for the business owner. It's more intuitive for the customer. It creates a lot more flexibility, and the market changes. The craft beer market, like everything else, changes rapidly. So it gives those business owners the opportunity to say, you know what, maybe we want to add some seltzer, maybe we want to add some different options. We can do that. We go to the state, we apply, we pay a fee, we can do it quickly. It's just much more flexible. So our overall take on this is it would be a big boon for economic opportunity and entrepreneurship in New Hampshire, but also for economic growth. Once you get this change in place, I think you're going to see a lot more people try and experiment and do startups. And if we get a more robust industry here that's more flexible and more customer friendly, it's a small effect, but it will help. And I know you guys have heard this before when it comes to recruiting young people, recruiting talent. People from out of state, they want a vibrant nightlife. They want a vibrant restaurant industry. They want variety. And this will, I think, do a little bit to help keep people here. So I think it's a good bill overall.
Great. Thank you very much for your testimony.
Thank you.
I have a question.
Oh, we do have a question. Representative Herbert.
Sorry, slow with the trigger. I'm not sure you know the answer, but do we get,
Mike?
It's a little far from your face.
Does the state get a % of sales?
That I think I'll leave to a more of an expert on the actual.
They do. So we were getting revenue from this.
So yeah. So the way I look at the licensing here, our take on it is revenue shouldn't be your primary concern about this, right? You want to grow the economy, right? But when you're creating more flexibility and ease of growth for businesses, I think you're going to end up getting a lot more revenue in the long term over this, even if some businesses change their classification. Because under this, some brew pubs, for example, might want to go to a small tier 1 or tier 2 manufacturing license. But because you're creating that flexibility, you're easing entry into the market. I think you're going to see a lot more businesses come into the market. It's going to create more competition. It's going to create more economic activity. So I think in the long run, the revenues are going to go up, not just from the fees, but from the taxes, from the sales, from the rooms and meals tax. I think this is an economic winner, not just for the economy as a whole, but for state revenue.
Thank you.
For the record, a licensing fee it should never be perceived as a revenue generator. It should only be the cost for the department to enforce the statute. However, in the state of New Hampshire, we do have a rooms and meals tax. And that was an original issue with the nanos because some of them thought they might be exempt from the rooms and meals, and we had to clarify that. Yes, they absolutely pay the rooms and meals tax when they sell their beer, unless they give it away for free, which technically they're allowed to do. and then, of course, they make business profits tax and BET tax and all those good things that help the state revenue. Thank you very much. Okay, next up is we'll have Kirsten Nevis from Tuckerman's. Good afternoon.
Hi, how are you? My name is Kirsten Neves. I'm a co-founder and owner of Tuckerman Brewing Company and also president of the New Hampshire Brewers Association. And referring back to your question about taxes, yes, we do pay rooms and meals tax. We also pay an excise tax to the state, and we pay a federal excise tax as well. So sorry. So I am here testifying in support of SB 137. This legislation will simplify brewery licensing in New Hampshire, and it will put all brewers on an even playing field. This will eliminate confusion for brewers and their customers when different brewery license types have different rules of operation. Right now, we're a beverage manufacturer. We started in '98, so we've been a beverage manufacturer in the state for 26 years, but the industry has changed dramatically in that time. But since then, the nano brewery was added. The brew pub has been around for a long time, but we all have different abilities as to what we can do in terms of selling beer and whether or not we have food requirements required. So it gets very confusing as to who can do what. SB 137 would put us all as beverage manufacturers, and then it would be sort of a la carte. Like if we wanted to start a restaurant attached to the brewery and serve more beer, then we would add a restaurant license to that for beer and wine. Or if we wanted to sell cocktails, we could add a liquor license to that as well. But it would be more of an a la carte system, but it would put us all sort of on an even playing field. And we have found over the years that there's been a lot of confusion when a customer can go a couple miles down the road to a nano brewery and they're able to order food from a food truck and also order as many pints as they want. But if they come to our place, before we added our restaurant license, we were restricted to order selling 1 or 2 pints at a time. And it just gets confusing for customers. And I think it puts New Hampshire breweries at a disadvantage because when they come from neighboring states and they have a much easier time visiting local breweries and their experience there, it sort of puts us at a disadvantage when they can't do that in New Hampshire. And I'm happy to answer any questions.
Representative Burrows.
Hi, this is a Would You Believe. I live in your area. You know, I'm in the Mount Washington Valley. I just want to say what an amazing addition Tuckerman has been to the valley. It's a place where young people go. I guess I don't qualify in that description anymore. But, you know, a great place where people come for events and you have great food. And I was very disappointed how tough trivia night was last week.
That can be tough. But no, thank you very much.
Okay. Thank you very much.
Okay. All right. Thank you, guys.
Damon Lewis from Vulgar Brewing.
So I'm sorry, I'm a little nervous first time doing this sort of thing, but I'm Damon Lewis from Vulgar Brewing. I appreciate everybody's time and chairman's time. It's funny because literally what is described is my exact situation. We have opened in 2019 in Franklin, New Hampshire. We were licensed as a nano brewery. As of tomorrow, we will be licensed as a beverage manufacturer And the only reason for that change for us is we wanted to carry cider. We don't want to up production. We're not looking to do any of those things, but under our nano license, we cannot bring in any product that we don't make, and we are not allowed to make cider. Because we want to provide more options for the people that come into our place. And some are gluten-free. Obviously, a brewery is not a good place for that, so we want to provide those options. So for us, it's kind of does bring everybody on the same playing field. We'll now be buying cider from a distributor, so they actually have a revenue stream they didn't have before because we were not even able to do it if we wanted to. So I'm really just testifying in support for that reason. I mean, it affects us drastically. And of course, the licensing fee, until this goes into effect, hopefully, we had to pay an extra $1,200 just to have that right. With no plan changes to really use any of the other benefits that currently the beverage manufacturer tier provides. So being able to scale up and add that would be a huge deal for us. And we're a small brewery compared to a lot of places. So $1,200 does matter to us. You know, I mean, it matters to everybody, but that's somebody's paycheck, you know, 1 week when we're slow in the winter or those sort of things. So just want to raise my support. And if anybody has any questions about that process, because it did take about 4 months to change that as well. I'm happy to answer them, you know, at any time. So
Guess we're all set.
Thank
you. Chair will call on Erica Rosenfeld from Post and Bean Brewery. In Peterborough. You hit the button.
There we go. Thank you, Chairman Hunt and the rest of the committee for hearing this. Most of my points have been touched on, so I will not waste too much of your time. But this is a bill that we've been working on for a few years, as most of you know. We think it's incredibly significant for the brewing industry, not just to simplify the licensing process and help with that streamlining communication with the Liquor Commission, reduce costs, offer more growth opportunities in an easier way. But we genuinely believe that it will help all aspects, all stakeholders in this industry, you know, from the breweries with the ability to do something with an a la carte license for a retail outlet, for example. A lot of us really like finding those open spots in possibly rundown Main Street communities where we can't produce beer there. It's not big enough, but we could bring some vitality back to some small towns if we can just set up our retail space there. Currently not an option for nano breweries, but it is for beverage manufacturers. I think we'd see a lot of benefit in some of these smaller towns. I'm in Peterborough. We are now just a local hub for neighbors to meet, sit around, have a beer. Like Damon, I would love to have a cider for many of the people that come and just drink non-alcoholic seltzers to hang out. So it benefits all of the breweries. I think it could really benefit some of our smaller Main Street communities. It also will increase our relationship with distributors. On day one, as soon as I can, I'll sign on with somebody to get ciders in my tap room. And we do think it'll encourage more people to add that restaurant license or food service license to their beverage manufacturer now that it'll be an easier process. So I think everything else I plan on saying has already been said. But if you have any questions, I'm happy to answer.
Have a question, Representative Ammon?
Thank you, Mr. Chair. Thank you for your testimony. You did a great job. This question may be for you or maybe the Liquor Commission. So if you don't know the answer, this act takes effect July 1st, 2024. How does the transition, how do you imagine the transition would work from the old licensing scheme to the new licensing scheme? Does everybody have to apply July 1st?
I think that how I imagine it is probably not how the Liquor Commission will answer that. So that's definitely a better question for them.
Yeah, the bill will go to a subcommittee, so we'll be reviewing the process. So, thank you very much. Anybody want to speak on it? Seeing none, they will close the public hearing. And moving right ahead. Not too far behind now. Senate Bill 433, establishing a commission to study the marketing of e-cigarettes and e-liquid in the state, including the legality of available products, appropriate wholesale, retail compliance, and tax collection system of the same. I didn't know that. Oh, this was last. Yeah, we'll just go to the subcommittee. Okay, yes, you're on, Daly. Daly for that. We'll introduce it for Senator Lang. Good afternoon again.
Good afternoon. Good afternoon, Chairman Hunt, members of the committee. My name is Daly Frenette. I'm the Senate Majority Caucus Director. I'm here to introduce Senate Bill 433 on behalf of Senator Lang. Senator Lang originally brought this bill forward due to concerns regarding perceived unequal enforcement of the cigarette tax, as well as how it is applied. The bill, as introduced, would have created a commission to study enforcement and collection of the vape tax imposed by RSA 78:2, Section 2B1 and 2, enacted in 2020. However, as amended by the Senate, the charge of the commission was broadened to include studying the marketing of e-cigarettes and e-liquid in New Hampshire, including the legality of the available products, appropriate wholesale and retail compliance, along with the tax collection system. The commission would include members of the House, the Senate, the Liquor Commission, the DRA, and members of the public who are engaged in wholesale or retail sale of tobacco products. Thank you very much for allowing me the opportunity to speak again today. There are some members from the New Hampshire Vapors Association who are here and will be able to answer any questions that you have.
Oh, Representative
I'll make it
Burrows
quick.
has a
Thanks for
question.
taking my question. Can you explain, like, I'm just looking up here about e-liquid. Does that mean you actually drink nicotine?
No,
Oh.
to my understanding, when you have a electronic cigarette, you can add what is called vape liquid that it contains. It's a liquid form of nicotine that is combusted within the device in order to smoke it. That's how I understand
Do
it.
not drink it.
Can you put in Diet
doubt it'd be
Coke or
very good to
something?
drink. What was that?
Can you use Diet Coke instead?
No comment.
Magic. Okay. Thank you very much.
Thank you.
Okay, Allison Preston, who's going to New Hampshire Vapors Association in support. Yeah. And Bree, you guys are tag teaming on this? Yeah. Okay.
Thank you, Mr. Chairman, members of the committee. My name is Alicia Preston. I represent the New Hampshire Vapors Association. We are in support of this bill. Brett, who owns 11 vape stores in New Hampshire, can explain a little more in detail why. But in general, since the tax, which is relatively new, I believe just 3 years, went into place, there's been some discussion as to whether all the taxes are actually being collected, how they're being collected, and is there potentially a better way to do so to make sure that they are. Our understanding is there's probably literally several $1 million worth of taxes that are not being collected out there. And representing the Vapors Association, we want it to be done properly. It undercuts, obviously, if people aren't paying their taxes, it undercuts those that are doing it properly. And I think Brett can speak to a little more detail.
Awesome. Thank you all for your time. My name is Brett Scott. And again, kind of building off from that. So specifically here in New Hampshire, I own 11 stores, and I pulled some information from the Department of Revenue to better understand what percentage of the vape tax we're paying. And we are paying, at that time when I did that, we were paying 26% of the vape taxes being collected by the state of New Hampshire. That's out of 11 stores. And though I would love to tell myself that we're 26% of the market share, I know that's not reality. These products are sold in convenience stores. I mean, if you drive Salem alone, there's a lot of stores, and there's a lot of these stores throughout the state. So there's a major problem with this. When you look at the cigarette market, there's an actual tax stamp on those products. That market, it's a level playing field because there's an identifier that the tax has been paid. It's very closely tracked. So there's good control of that market. This vape market, there is not any identifier on here that's been paid, and the auditing that's currently done is very generic. And therefore, it makes it very easy for people to evade paying the taxes on these products, and it's a major problem. And I truly believe that the amount that is not being collected is substantial and would absolutely be worth the time to revisit, to take a look at this and see if there's a better way to make sure that the tax is being paid. And that's ultimately what I'm here for, is seeking a level playing field, and would be happy to be a part of those discussions.
Representative McAleer.
Thank you, and thank you for taking my question. Your 26%, what is that in dollars? How much does that amount in dollars?
We're paying over $200,000 a month in tax. That's just out of the 11. I mean, I own stores in other states, but that's specific to New Hampshire, just out of those 11 stores.
Okay, thank you. So the amendment you had sent me, we do have a copy of it, so if you want to grab it over here. Kristen, yeah, that amendment, make sure she get that amendment. Yeah. Secret. Okay, and anybody else who's also interested in an amendment to deal with this 433 issue, but fundamentally is that we're dealing with a fly-by-night kind of in business. It's not big tobacco, and big tobacco is highly regulated, and I don't think they put stamps on it anymore per se, right?
On cigarettes, they do.
They still have that stamp on it.
Absolutely.
Some reason I thought we got rid of. Oh, okay. We got rid of the real stamp. There used to be a stamp that used to be the tag stamp. But
I'm familiar with
that I was around for when we repealed that. But so, okay. Thank you very much.
Thank you.
All right. Is there anybody else who would like to testify on Senate Bill 433? Seeing none, we will close Senate Bill 43. It's absolutely a very lucrative business. Okay. So
You got 15 minutes.
now we're behind schedule. I mean, ahead of schedule.
Mr. Chairman, quick question about tomorrow.
Yes.
Are we changing the schedule at all tomorrow, or deleting one, or changing
So
subcommittee
so
or
what
anything?
happened was Senate Bill 354, which we're hearing today, because Senator Innes was not going to be able to make it tomorrow. And so I moved it today. So evidently, if you have a calendar that still has 354 tomorrow, you can ignore it. Otherwise, tomorrow, I believe we'll have then, after the morning, we'll have then heard all our Senate bills. And so tomorrow afternoon is free. And then starting the following week, we have 2 weeks in which we have to do subcommittees, get through all the bills, and we have to have everything out by the 15th of May.
So we're going to do 2 days next week?
We'll do 2 days next week. And I'll try to divide it up by the subcommittees. And we'll try to just trot through those. It used to be, we'd always say, well, it's almost easier when you have Senate bills because they've already been through the grinder on the Senate side. But this year it feels a little different about the vigilance the Senate had on their legislation. Yes, Representative Spear.
Since we have a few minutes before the next start, could you explain about the study committees? Because we have 2 bills now.
Oh, okay. Chapter study committees. Yeah, so chapter study committees is after the bill has been signed by the governor. Then it goes to, and you can see in terms of whether they're appointments, House and Senate. And traditionally, it's always been senators never show up on the second year. So that's why there's only 1 senator on these study committees. And it's chock full of 3 or 4 House members, because evidently House members are more than willing to show up for a study committee. I generally, myself personally, the study committee should be really well focused on getting something accomplished or what they're doing. When you have a study committee that's going to be a little general and just overall, it's going to feel like, if you get appointed, it's going to feel like a waste of time. So otherwise, they are appointed by the speaker. So if there's a study committee you see that you really want to get on, I do urge you to let the speaker you want to do it. The one that's not get crazy. The interesting thing is they can waive the rule about how we don't meet in July and August. So that if the chairman of the committee is interested in actually spending more time and delving into it, they could actually meet in the summer. And I would have to say that's number 1 reason why I avoid being appointed to a study committee, because I don't want to drive up from Rhode Island.
June 15th.
Yeah, I got it on the calendar.
June 15th. Okay.
You have to volunteer for this. I mean, it's not like you can.
No,
just
you'll
go-
be, I would say that often the speaker will call me up and ask me who I think should be appointed. And since you asked, right, so yeah, no, it should be, you really want to, interested in doing it.
There's a committee and a commission, right? This next goes commission.
So, okay, so yeah, difference between a committee and a commission. A committee is only going to have House members appointed to it. A commission is, it's a free-for-all. So, for instance, the marijuana bill was a commission, so that had all kinds of interested parties who had some skin in the game would then get appointed to the commission. And then you have limited amount of legislators per se who are on a commission. So, anything else you want to think I should add on that?
Well, the interesting thing is who calls the first meeting? It usually says,
It's based on the bill.
Yeah.
Who with the bill number? It was a Senate bill.
so these say the first named Senate member will call the first meeting. Sometimes the Senate never calls the first meeting, and so the thing just kind of evaporates. So I've seen that happen.
Probably we should not have passed it in the first place. So, okay, we have one bill left here. I was going to come over and get your card for you. Thank you. No problem.
I got my, the nuclear commission had a report that had legislation that got
Ready? We'll open up the public hearing on Senate Bill 354 and hear from the prime sponsor, Senator Innes. Good afternoon, Senator.
Good afternoon, Mr. Chair, members of the committee. Dan Innes from District 7, Bradford, New Hampshire. Happy to be here this afternoon to introduce to you Senate Bill 354. And this is an interesting bill, and I'm sure there'll be a lot of discussion in testimony that follows me. And many of the folks behind me will be able to answer some of the technical questions that I might not be quite so precise in answering, but I can generally present what we're doing here and why we're doing it. So imagine you went out to dinner and you've got a gift certificate and you've enjoyed your meal. Waiter comes over, leaves the check. You put down your gift certificate and a credit card. When the server returns with your payment, you notice you've been charged the full amount, in spite of having a gift certificate, which doesn't much make sense. And it doesn't seem right to you. Well, that's essentially what we're dealing with in this particular bill, is a situation where you have assistance in paying for a medication, and the insurance company says, that's great, and we're not applying that to your deductible. So if you put yourself in a medical position instead of dinner, my sister-in-law, for example, has just wrapped up chemotherapy, $10,000 a month. Insurance pays about $8,000 of that, 80%. The other $2,000 comes from the pharmaceutical company. And in this situation, like many others, the insurance company says, thank you very much, but we're not applying that to your deductible. So you as a patient still have to cover that deductible to get to the place where you don't have to worry about it anymore. So effectively, the companies are double dipping at the expense of the patients. And in my view, and the view of many others, it shouldn't really matter to the insurance company who's paying for the medication if the insurance company isn't paying for it themselves. So it's a fairly logical bill, I think, that we're bringing forward here. And I'll read to you an excerpt from an article that appeared regarding a similar bill in the state of Rhode Island. So we had a patient who was being treated, very expensive treatment, and this patient had gone through 2 treatments and was ready for the third. And when they placed the order, the representative on the phone said that he would owe $2,400 in payment. He said, that can't be right because I should have met my deductible already. So he contacted the insurance company, and after many hours on the phone, was told that because the plan included a copay accumulator adjustment program, which is what this bill tried to eliminate, any support for his prescriptions that didn't come out of pocket would not be counted against the deductible. So again, why should it matter to the insurance company who's paying for the medication, just so it's being paid? And shouldn't that apply to the patient's deductible? There are an awful lot of organizations that support this, those organizations that work with patients with hemophilia who take medication all the time. The American Cancer Society is supportive, among others. Some people say, well, if this goes through, we're going to see a big increase in health insurance costs. That's simply not true. In the 19 states where similar legislation has been passed, the Global Healthy Living Foundation has found no significant change to health insurance premiums in those 19 states. And I think that speaks for itself. So let's make sure that copays count, regardless of their source, whether it's big pharma, someone helping a patient out through a GoFundMe or some other source, or the patient themselves. Let's just let it all apply to the deductible as it should. And I'm happy to take any questions.
Okay, let me start first because I like stories and you told us a story.
Yes, I did.
Okay. So when I have a gift card, somebody paid for that gift card.
Correct.
There was cash paid somewhere along the line. So when I'm applying it, I'm taking advantage of the fact that that piece was prepaid.
Yes.
So in your example, who paid for that coupon?
I see where you're going with this, and it's essentially a credit from the pharmaceutical company.
So the pharmaceutical company is when you turn in that card, that discount card,
Yes.
to the pharmacy,
Yes.
the pharmacy is expected to turn it in just like a coupon, like it gets gift card or coupons.
Yes.
And it's going to turn it in,
To
and
Pfizer or
and
whomever.
Pfizer will pay it.
They will pay it. That's the understanding that I have.
That they really would pay it.
Well, the pharmacy where you're fulfilling the prescription is getting paid, right? Why do we
Like
care?
I'm saying, I don't care. It's I'm not, at the end of the day, the issue is that this coupon is going to get paid. The pharmacy is going to get its pay.
Correct.
And therefore, the pharmacy would then notify the insurance company.
That's correct.
That the sum of actually they wouldn't notify. As far as they're concerned, they're saying is they're going to be paid, and so therefore it's really now a cash flow problem for the pharmacy.
Okay.
Because the pharmacy is going to take that coupon.
Correct.
They're going to tell the insurance company that they paid it.
That's right.
That it got paid.
Yes.
And it's up to them, the pharmacy, to go get the money from the pharmaceutical company.
Correct.
Okay.
And it does.
That's a different story, isn't it now?
I don't know if it is or not.
Okay, well, that was a different story that I was told.
I would
But
encourage you, Mr. Chair, ask that question
I
of some
will,
of the folks
we
behind
will
me as
make
well.
sure that's exactly the way the bill is supposed to be handled.
I knew I could count on you.
Okay,
Thank you.
now we have questions. Representative Spear.
Insurance companies have set up formularies with the PBMs.
Yes.
When a coupon is made available, it's usually made available for a specific branded drug.
That's correct.
That bypasses the formulary. It bypasses all of the insurance companies' accounting for how they're going to bill on their premiums.
Okay.
And now the patient is essentially kind of guided towards a drug rather than being able to have an analysis that says there's a perfectly good other drug that costs half the price, but you're not going to get it because you've gone onto this coupon thing and you don't want it and you don't want to change.
Yeah.
So instead of the formulary being used as a guidance to find all the drugs that are available at a specific tier, now we're having drug companies market directly to the insurance, market directly to the patients, bypassing all the efforts that are made. And I saw that Medicare considers this a kickback scheme and that they won't even allow it. So my question to you is, how is this going to solve or maintain prices, maintain premium prices and the cost of premiums when we can't even control what drugs are being sold to the patients when there are perfectly good drugs available?
I'm not sure I understand the question.
Let's say we amend this bill to say it can only be for generic drugs.
Only for generic.
Correct.
Well, there was an amendment that it shall not apply in the case of prescription drug for which there's a generic alternative. So we're kind of
I'm doing the opposite.
I see that you are. Yeah. I
In
mean,
other words, the assumption is we don't want someone to to get a drug because they have that coupon.
Right.
That they're going to take the one that is more expensive than the generic one, and therefore that's where you're going to see the increase in premiums because now, like a heroin dealer, you've given them that cheap price because you gave them a couple of coupons and got them hooked, and now they're going to want that name brand product, and when those coupons run out...
But Mr. Chair, respectfully, I think you're treating this as if it's a coupon for something in the grocery store where the consumer makes a full choice of what they're going to be taking. In this case, you have a doctor offering a prescription and a specific medication for a particular patient with a specific problem. That to me is a different scenario. If there is a generic alternative that's effective, then I would agree with you. That should be the first choice of care, assuming it works. If it doesn't, and there are cases where it may not, biosimilars and whatnot, then I think this situation still applies. I understand your argument, but it's not really a free choice market for most patients with cancer. There are specific drugs treat specific cancers in specific ways, and that's what the doctors
So
prescribe.
in this bill, it says it cannot have a generic or any other more affordable drug.
Well, as it's written now, it says the requirement shall not apply in the case of a prescription drug for which there's a generic alternative. So effectively, we're saying start with the generic, right?
Okay. But
Yeah.
the key element, is my remember was my mother-in-law that the doctor wanted to put her on Eliquis.
Okay.
And this is years ago.
Yeah.
Eliquis just came out.
Mhm.
And it was like, the hugely expensive, but she was Medicare anyways.
Yeah.
So I don't even know whether Medicare, how Medicare treats it back then. But the issue was that yeah, he gave her a coupon, but the coupon, it was only limited, there was only that first visit.
Yeah.
And then after that, now she's on the more expensive, the Eliquis, and never was really offered the opportunity to get on something that might have been less expensive in going forward.
Yeah. I think, the desire all the time is to try to keep costs down and get patients the treatment they deserve. And if a generic does that, then I'm fully supportive of that.
Right.
If
So-
not, and there is an more expensive alternative that works better, fewer side effects, more effective, and this comes into play, then we'd like to see that count toward the deductible. But I appreciate your point.
So basically, the end of the day is that because that patient got what that doctor referred, because they were taking the coupon, the fact that there is a consequence for everyone else who doesn't have that opportunity, that the overall pharmaceutical costs are going up because of the more expensive drug was the one that got the name, the name brand. It's not that to you. It's that fairness of that we're all paying. We should all be happy that patient was able to get that name brand drug.
Wow.
That's what we really should be happy about.
I think one of the concerns I hear as an undercurrent in your comments is that insurance rates will go up, because if those drug costs are going up,
Well, I'm assuming the drug's more expensive.
in fact, insurance costs should go up too. But analysis of the 19 states that have passed similar legislation hasn't proven that to be the case.
And the only thing I would educate and make sure everybody knows is about the MLR, the minimum loss ratio.
Yep.
And
Yes.
that minimum loss ratio takes a while for you to see it because it's on a rolling 3-year average.
Understood.
So you really don't know how much impact those coupons had until, you're out
3 years out.
3 years out.
Understood.
Okay, Representative McGee.
Thank you, Mr. Chairman. I also like a good story, and I even further like a good analogy, if I can combine the two. So what I'd like to ask you about is, are these coupons at all like restaurant gift certificates? If
Well,
you
Probably not, but it is a good analogy that helps people to understand the concept.
well, if you had
Just so you know, there are two kinds of gift certificate. There's one that you actually paid for.
Right. I mean,
Somebody
what I'm
actually
gonna talk
bought the
about is
Then there's
the-
another
like-
one that is they do a sale, they're doing a discount, trying to entice you in. Now, the reason I say this is because I wrote the law, and that is if someone underlying pays for that gift certificate, it cannot expire in New Hampshire. In many states, they were expiring them in 2 years. But if it's a gift certificate that had no underlying dollar value, then yes, they can expire it.
And I remember well our floor fight, Mr. Chairman, when we discussed that many years ago on behalf of the Restaurant and Lodging Association, and I lost. So the question is this at all like do the pharmas carry this credit as a liability on the books, and should the consumer expect to get value for that coupon, and they have it as a liability, much like the restaurants would or do, and that's why they wanted to expire them, and we had that discussion many years ago.
Having been
And
in the
I
hotel
lost.
business, Representative, I know exactly what you're talking about. In selling the place, you've got that liability that you've got to credit the buyer with, right? I can't answer for the pharmaceutical companies on how they handle the accounting on this. Perhaps someone who's yet to testify can address that for you. Thank you for the question.
No, I was thinking the banking credit, debit, and, erases the transaction out. That's all I wanted to know. When you said credit,
Yeah.
I said, oh, okay, well,
Okay.
the pharmacy's got a.
Representative Spear.
Yeah, that's what I'm.
The House Oversight Committee did a study over 5 years on Medicare.
Uh-huh.
They found that once a coupon expired, a person was now in favor of that drug that they've gotten used to. The drug price went up an average of 12 to 13%,
Okay.
versus the situation where they don't allow coupons, which they don't allow anymore. They did not see that increase.
Okay.
So when you say that it will not cause an increase in drug prices, that's not what Medicare found.
I understand.
And other states have found the same thing. California did an incredibly extensive study on this, and it showed a very similar kind of an increase, that once a person got moved into that drug, you know, that is, it's marketed directly from the drug company to the patient, going beyond the, even in some cases, the doctor, usually beyond the doctor and beyond the insurance company's recommendations. They're now got somebody locked in, and prices are going up. So where are you getting, I mean, I'm not clear on why you say this goes against everything that the formulary does, which is to encourage competition, if you will. And this takes that away, right? Because we're marketing directly from from a drug company to a patient. Even the doctor doesn't get involved in some of those cases. So I'm not clear on why
So
you say
Representative
this.
Spear, are you saying that Medicare does no longer allow this?
No, they do not. They consider it. Medicare considers coupons, I want to use the right words, an illegal kickback. That's what they write. It's an illegal kickback.
If we were to write this bill to say that the coupon can never expire, once a consumer has been given a coupon, that coupon will have to last as long as that patient needs that drug.
Representatives, I think you're trying to bring this down to a consumer level. A coupon for Pop-Tarts, right? Versus toaster strudel. As a medical consumer, I don't get those choices. I work with the doctor. The coupon is for a specific purpose, for a specific drug at a specific time. It's not for a hotel room 3 years from now, or for a discount on Pop-Tarts next week, which I think would be a great thing. I love Pop-Tarts.
You've seen the movie.
But I understand the reasoning and the logic. I don't disagree with that logic. I'm just not sure it neatly fits this situation.
We are the Commerce Committee, you know that.
Yes, I understand.
Consumer Affairs.
Okay. I'm a bit of a commerce professor
Okay.
myself.
Representative Ammon has a question.
Thank you, Mr. Chair. Thank you for giving your testimony. Curious about precedent in other states. Has this been done elsewhere, and how recently, and to what effect?
It's been done in 19 states, and it's been successful in all of those, to the best of my knowledge. Yes.
Okay.
All right.
Any other questions? Seeing none?
Thank you, Mr.
Thank
Chair.
you.
Thank you, committee. This was a great discussion. I really appreciate the thought you put into it. I do hope we can get to a place where we can do something with this. And I thank
have
you
one
very
more
much for
question.
your time.
I do have one more question.
Oh, you have one more question. Go ahead.
I always do.
I'll try to answer,
Well,
Representative.
it's your bill.
Yes, I'm
Section
aware.
3.
Section 3, yes.
This is a program of maximizers and efforts by the insurance companies to help patients with very expensive specialty drugs.
Correct.
And this bill specifically wants to take that away. If on one hand, we're talking about wanting to support drug access to individuals, why do we have this in here to try to take it away?
How is it taking it away? I'm not sure I follow.
Oh, I have a paper on it.
Okay.
I will give you the paper.
I would like to see it.
Stay tuned.
All right. Thank you very much. Once again, thank
Okay.
you, committee.
Next, we'll have the Insurance Department. And we got Jason Aziz and Michelle Eaton.
Oh, he just wants exercise. I wanted it.
Good afternoon. For the record, I'm Jason Azes, Director of Health Economics at the Insurance Department.
And I'm Michelle Heaton. I'm the Director of Life and Health.
Yeah, I thank you for your time. So the Insurance Department has some real concerns for Senate Bill 354, as its passage will contribute to increased premiums. However, this is a policy decision that the board faces. Insurer plan design accounts for payment of covered benefits and patient cost sharing to pay claims. If an outside stream of payment, such as a manufacturer's coupon, is used to offset total cost sharing responsibility, then reactively, insurers will have no other choice but to increase premiums in subsequent years. This passage of the bill will inhibit generic efficiency, which refers to the market's rate of uptake of newer, lower-cost drugs. This also applies to biosimilars, which is sometimes referred to as generics. I would suggest a language change on Section 2 of the bill to also include biosimilars in addition to the word generics there, because most of the drugs that fetch rebates are actually not classified as generics, rather biosimilars.
Okay.
Where is that?
We've all learned about biosimilars and previously.
So that's all we have, and we're happy to answer any questions you might have.
Okay.
Thank you.
We do have questions. Representative Sullivan has a question.
Can you explain? I mean, I think the previous speaker was going, and
A little closer to the mic.
when the the sponsor was speaking, I was going to ask the questions that both the chairman and Representative Spear were asking with regards to the Sonia, with regards to the idea that we're sort of subsidizing, or the pharmaceutical companies subsidizing a premium name brand drug, which is going to be more expensive, right? But it seems the language in here sort of addresses that in terms of the generics, and maybe we make a change about biosimilars. So what is your thinking that this is going to drive the costs now, to the extent that there's somebody who's getting a name brand drug and that's the only choice there is? Is it because somebody who needs it simply won't buy it because he can't afford it without this? Like, what's the thinking there that you want us to think about? Because you said it's going to drive up premiums.
I heard the sponsor talk about rational choice. That's an economic theory, that consumers in perfect markets, perfect competition have choices. Pop-Tarts, he mentioned. I love them, Pop-Tarts. But delivery of medical services might be a little bit different. With prescription drugs, the market could benefit by competition. And so we've seen that clearly in the small molecule drugs to generics. Generics can be as much as 85% cheaper compared to the branded small molecule drugs. However, in the biologics market, we don't see any type of cost savings like that. One of the main reasons is because there's not a lot of competition. So, and any kind of policy that inhibits the uptake of new lower cost biosimilars or generics will by nature be a cost driving policy. So any way that you could introduce competition to that market would be by the same definition and by the same token, exert downward pressure on prices for these expensive
Further
drugs.
question? Further question?
But it's different.
Yeah. Okay. All right. So I get what you're saying, and I agree with you completely. What I'm struggling with is if there's a generic available, and I know we want to add language in about biosimilars, then is that a moot point? Or explain to me rather how the name brand drug, if that's the only thing there and it's being subsidized, what's the channel through which it's costing? I agree we shouldn't be subsidizing name brand if there's a cheaper generic out there, and it sounds like the language in here doesn't allow for that. So I'm still not following. You just cited biosimilars, which we need to add in, and generics as something that we want people to use if it's available. But if it's not available, what are we supposed to do? And it seems like this is only addressing when it's not available.
Yeah, I think with regards to that part of it, Section 1, it shows that this has to do with whether or not the value of the coupon can apply to the cost-sharing responsibility of the patient. And so what that does is it shifts, plan design for insurers depends upon a combination of covered benefits and patient cost sharing responsibilities, which varies widely across the health insurance plans that we regulate. By now allowing an extraneous force to apply for cost sharing that the insurer doesn't include in their subsidies for payment for covered benefits, the next year that will almost force the insurers to increase premiums, because now there's some other outlet for that, the value of those coupons leaving the cost sharing pool.
So, another question.
Further question, inquiry.
I understand what you're saying. What I'm trying to get at is what alternative does that person have if it's only the name brand drug? And if there's only the name brand drug and that name brand producer gives them a subsidy to buy it, and that's the only option, there's no biosimilar, there's no generic, then what is so are we saying we just don't want those people to take those drugs? I mean, that, like, I'm not following the logic how this drives price. I get the whole market idea. Like, trust me, I'm on board with that. I wouldn't be even having this discussion or debating this if it were not, didn't have this language already in here about the generics and the need, as you said, to add in the biosimilars. But it sounds to me like this is only addressing when this only applies when there is no generic and there is no biosimilar once we change the language. So how does that drive costs short of keeping somebody from getting the drug that they need?
That the money that would have been paid to the cost sharing now doesn't apply to the patient's deductible.
I understand that, but if
He's saying this is if there really is no other choice.
if there is no other choice, I mean,
There really is no other choice, and that this is the right drug, and so there is no really cost shifting going on. It's just more expensive because it is the only choice.
I think the concern is that if there's only one available, the drug manufacturer can, and this is a concern, I'm not saying this is necessarily done, they can be increasing the price that the carrier is going to pay, but then they're going to funnel savings directly to the patient. So the overall cost of prescription drugs may go up, but the consumer isn't necessarily seeing that because they're getting the advantage of the coupon. So I think there is a potential that there could be some manipulation with the prices there, and that's what could lead to overall drug spend going up.
because they're not the one internalizing the cost. So I get that, but so the alternative might be then that person just doesn't get the drug. Like if they truly can't afford that deductible, that seems like that might. I mean, if it's a $2,000, I don't know what the deductible
Yeah, I
would be.
think
Because I mean, I've
that
had
is the most extreme case. There, if you're talking about commercial health insurance plans, there are a variety of options available. Some of them with very low cost sharing, very low deductible, but you end up paying more in premium. If someone were to be on this high cost drug, one of those other plans may be a better fit for them because overall their out of pocket costs are going to be minimal. So they do have access to these drugs. I think there's a combination of a lot of factors there, but the drug is going to be available to them if it's the only drug available, and they would have to pay whatever that plan design dictates they would have to, regardless of whether there's a coupon or not. And that's kind of what they have agreed to when they've purchased the plan. So if they have, a lot of medical costs and a lot of prescription drug costs, they may want to get a plan that has, those lower cost sharing amounts.
final question or
Further question.
So this is probably more of a would you believe? Would you believe? I do actually agree with what you said about the biosimilars we should add in there. And I do agree that we should not be in any way subsidizing people to use name brand drugs when there's something similar, generic, biosimilar, whatever. That all makes sense to me. And to the extent that there are different insurance plans, that might be great when it comes to renewing time or whatever. But I think at some level we want to make sure that people aren't somehow priced out. And if the only way they can get access to one of these name brand drugs when there are no alternatives and the only way they can afford their portion of it is by getting some sort of coupon, for lack of a better word, then I think we don't want to like discount that or try to dissuade that practice. And it seems like a potential unintended consequence would be drug companies stop doing it because they don't count anymore, and now people maybe don't lose access to drugs, and that's just a concern. I don't know if it's a valid concern, but it's one that pops in my head real quick when I'm thinking about this after this discussion. Thank you for coming in and sharing.
Okay, Representative Spear.
outside of the deductible slash coupon market, or maybe taking advantage of the coupon market, insurance companies do offer plans called maximizer plans. And what these plans will do, they will pay the whole price of the drug if a person needs it. But it's outside of the deductible. Like any other drug that they may have to take, they may have to pay a deductible for that drug. But if they're taking a drug of which there is no competition, it's a very expensive drug, you know, cancer drugs, hemophiliac drugs, those kind of things. There are maximizer plans, and I know that Anthem has a very big one that's very popular that patients like, and they're not paying anything out of pocket for some of those drugs once they get into those plans, and those plans don't cost hardly anything. So there are other avenues for these kinds of things. On top of that, the drug companies
Is this a
provide
question?
grants. What was it?
What's your question?
No, I'm answering him. All right, and would you believe? And would you believe? They're not going to go without the drug.
Okay, so the interesting point here, we heard in the previous bill that generally they don't give coupon rebate with these things for drugs that have no competition, because there is no choice. The patient's going to have, the doctor is going to give them that Eliquis, because the Eliquis was the only one on the market at that time, and that's the right, that's what we're going to do. So the only adverse selection that's occurring here with that is that theoretically that person really, if they weren't for that coupon, and it's a very expensive medication, then really what that person would have done if the market was the perfect market would be not to choose a high deductible plan. Because if they had a very low deductible, then it wouldn't seem so bad. The expense wouldn't be there. But that's adverse selection because they were enticed away from that to say, oh, don't worry, we're going to give you a subsidy for that deductible. And that's where it's impossible to really calculate what exactly is occurring when you choose that drug that had that coupon. Or your doctor prescribed it and said, this is the only one you can have. Okay, Representative McHugh.
Thank you, Mr. Chairman. Thank you for taking my question. Do you think that these third-party co-payment programs help people who otherwise wouldn't have access get access to these most critical drugs, the life-saving drugs, where otherwise they might not get access to them?
It's important, I think, for everyone to know that everybody's exposed to high-cost drugs. 93% of our state is insured, so we all, by sharing the same risk pool, we all pay the cost of prescription drugs. It's tempting and easy to look at anecdotal situations. One person's, I lived the life that you talk about, but we don't have the luxury in our roles of having a myopic view of individual situations. Rather, we try to look at the entire insured population, and we try to make difficult decisions that help better most people's situation. And so I just want the committee to remember that's an important priority that we always have to balance in our roles. And so I think by and large, our society does a really good job ensuring access to these expensive drugs for life-saving therapies for people. And when we see situations like this, we try to evaluate the betterment of one individual situation compared to the betterment of society. And we see every year in our annual hearing report that gets much maligned, but we hold much credence in it. We see that prescription drug expenditures are the primary drivers of healthcare costs, which right now and in the past 5 years, we've seen this increase at an untenable trajectory. So we'd be remiss to not talk about that. And it's pretty ubiquitous across the insured population that high-cost prescription drugs are driving that. So that's generally an important underlying theme that I want all the members of the committee to be aware about.
So is that a yes or a no?
Well, that's a difficult question to answer. And
It is. I
think
agree, and that's a
there's a
great
lot of-
political answer you gave. But I just am
Well,
curious.
he's non-political.
No,
He's in the
I know,
department.
but maybe you should be.
not.
I mean, I just asked, do you think these programs provide
No,
access
I do
to these
not.
drugs for people who wouldn't otherwise get them?
I do
Just
not.
like a crowdfunding or a church fundraiser provides access to them.
I do not. I think in the intermediate and then the long run, they actually inhibit more access to better life-saving innovations that lie in the near frontier for people. in the
So
future.
by that logic, if we got rid of them and banned these programs, then more people would actually get access, right? So the converse is true in your thought. So if you don't think they provide more access, if we got rid of them, then more people would get access. It's one way or the other.
I didn't summarize it that way, but I think that these types of mechanisms are cost drivers for prescription drugs, and they impede this concept of generic efficiency that is an important market mechanism to ensure the control and the stabilization of high-cost prescription drugs, which empirically our annual report has clearly shown is the #1 cost driver, and we have to constantly evaluate that. So I appreciate you summarizing it that way. I'm just not in accord with the way that you did that.
Okay.
Thank you very much for your testimony. No, they take no position. Okay, Donald Chris.
Thank you, Mr. Chairman, and good afternoon.
Good afternoon.
My name is Donald Crease. I live at 292 Pleasant Street here in Concord. I am a state official who fights on behalf of consumers for a living, but today I'm here in my personal capacity, or more particularly, I'm here as the dad of a young woman who is about to graduate from college despite having been born 22 years ago with cystic fibrosis. And because I'm here in that capacity, I'm not here with analogies or with anything like that. I'm here with stories from the real world of life with expensive prescription drugs. Like all of the other patient and family advocates that you're likely to hear from today, I urge you to pass what Senator Prentice has called the All Copays Count Act. But my family's perspective might be somewhat different than those of others. Like most CF patients, my daughter takes a drug called Trikafta. It's a miracle drug that costs in excess of $300,000 a year. When I heard about $10,000 a month cancer treatments and maybe a $2,000 a month copay, I thought, oh, how quaint. Fortunately, Rose is on the New Hampshire State Employees Health Plan. Trikafta costs her next to nothing. But in 4 short years, she will be on her own, health coverage-wise. And if she ends up with a high-deductible health plan, she will need to beg Trikafta's manufacturer, Vertex Pharmaceuticals, for copay assistance. No way would my daughter be able to afford $60,000 a year out of pocket for one drug. It is worth remembering, and I think you all know this already from what you've already been saying, why insurance companies impose copayment requirements. The idea is to turn patients into savvy, non-wasteful consumers. And to be honest, Rose could respond to that kind of incentive by going off Trikafta. Her death would not be imminent. But no other drug does what Trikafta does, and some patients are far more dependent on Trikafta than my daughter is. And it is, in my opinion, outrageous and unfair to expect any CF patient to make a choice like that. Insurance companies should not be allowed to force such choices on patients via copay accumulator programs. But neither should patients like Rose have to depend on the kindness of strangers, by which I mean copay assistance programs offered by pharmaceutical companies like Vertex. The highly respected Institute for Clinical and Economic Review in Boston has investigated the incremental benefits of Trikafta and has determined that the drug is overpriced by roughly a factor of 3. So know what that means. It's a $300,000 a year drug that should cost $100,000 a year. So there's $200,000 of free money lining the pockets of Vertex Pharmaceuticals. At $100,000 a year, it would still be a very expensive drug to compensate that company's shareholders for the cost of having developed it. So, in other words, insurers like Anthem have a point here. Copay assistance programs exist because drugs are overpriced, and the whole situation puts patients in the middle in a manner that is absolutely unconscionable. So yes, please report Senate Bill 354 to the floor with an ought to pass recommendation, but do not let Big Pharma off the hook. This state has a prescription drug affordability board, which is just getting off the ground and which the pharmaceutical industry is constantly trying to thwart or abolish altogether. I urge you to strengthen the PDAB by giving it authority to set upper price limits so copay assistance programs become unnecessary. Every single year, my daughter's pharmaceutical bill is a multiple of my annual salary as a state employee. That is unsustainable, certainly in the context of state employment. My daughter is about to graduate from Bowdoin College over in Maine with an honors degree in government. She hopes to pursue a public policy career, and I would like her to do that right here in Concord. But she can't do that if she can't afford to live here as a cystic fibrosis patient. So yes to Senate Bill 354, but please don't stop there. Thanks for listening. I'd be delighted to answer any questions that the chair might be willing to allow anybody to ask.
Any questions from the member? So you're the consumer protection for the PUC?
Yes, that's right. I'm the
I
consumer
knew you
advocate.
looked familiar.
Yes, I do utility rates for a living. That is how I know when prices are ridiculously
Yeah, right, over marked up.
from monopolists.
Okay. Representative Herbert has a question.
All these companies, research and otherwise, are certified by the federal government. They have the rights to do what they're doing, correct?
Yes.
Okay. Now, the federal government also is the one that issues or agrees to issue patents.
Yes.
Is that correct? So from my perspective, wouldn't it be an interesting experiment if the federal government said to this company, we're going to take your patent away, and if you don't like that, we're going to take your certification away too, and you can go work in France. But I don't see where the government is actually making a difference here, where I can see where it obviously can.
Well, I would say that the ability to protect one's intellectual property, including innovative medicines, are what give shareholders the incentive that they need to make the investments that they need to make in order to make drugs like Trikafta possible to begin with. So I think as a matter of, I guess, American history, patents have had an enormously positive effect on innovation and therefore our wealth as Americans. So I would personally be very careful about reining in the U.S. Patent and Trademark Office's ability to grant patents to manufacturers like Vertex. But more to your point, what happens with a drug like Trikafta is, in addition to the patent, they acquire an exclusivity period from the Food and Drug Administration when the FDA approves and reviews their drug. And there are legitimate questions about whether those exclusivity periods are too long, and there are issues about patent thickets and other tricks that drug manufacturers play in an effort to take what I consider to be undue advantage of the protections that they enjoy under the patent statute. So I guess my answer to you, Representative Herbert, is that this is a very complicated and difficult area. Patents and drug exclusivity are matters of federal law, and we're kind of stuck with what Congress has given all of us by way of encouraging and promoting drug innovation. We lead the world. I'm very proud of the fact that Trikafta is an American invention. That drug was largely paid for by the nickel and dime donations that people like me have been raising from our friends and neighbors for decades via the Cystic Fibrosis Foundation. I don't want to get into, I don't want to interfere in that. I just want a drug that is vital to the survival of CF patients, and it really is a breakthrough and a miracle to be available to everybody who needs it at a price that they can afford.
Thank you very much.
Thank you.
Chair will call on Suzanne Livin Giddage. Okay.
afternoon, Chairman Hunt and members of the committee. My name is Susanna von Eddingen. I'm a resident of Warner. I'm the state lead for the New England Bleeding Disorders Advocacy Coalition, a member of the New England Hemophilia Association. But most importantly, I'm the mother of a 26-year-old son with severe hemophilia A, a rare genetic bleeding disorder that impairs the ability of the blood to clot properly. I'm testifying in support of SB 354 to ban the practice of copay assistance or a copay accumulator adjustment programs implemented by the health insurance companies fairly recently, I may say, since about 2016. Prior to that, these programs were not in existence. First, let me state, I was listening to the previous conversation that nowhere in this bill do I see the word coupon. It is copay assistance. We do not receive coupons. In fact, right now, we are not taking copay assistance from a manufacturer or a third party, be that a grandparent, a charitable organization, primarily because my son is now on his own insurance policy. Prior to that, he was on mine. Our copays were very low. I worked for the federal government. That's a big insurance pool, so my insurance policy was really good. But my son, with his bleeding disorder, needs, which is, by the way, genetic, lifelong, extremely complex because of his severity of the hemophilia. He needs expensive medication in order to have a normal life and a career, pay taxes, have a family, and work. He's a timber framer. He's his own company of one. So he had to go on the marketplace when he aged out, of my insurance policy. It took us a few months to find one that would meet his medical needs. Did you know that 2/3 of New Hampshire open market policies have accumulator adjustment programs? I didn't. That's from the AIDS International report from 2023. Not only that, but when we talked to healthcare.gov with an experienced broker, and we asked them which policies in New Hampshire have accumulator adjustment programs, that person had never heard of them, yet 2/3 have these programs. So then my husband narrowed it down to 2 policies that would address most of my son's medical needs, not just prescriptions, but periodic doctor's visits. He goes to the Dartmouth Hemophilia Treatment Center in Hanover, New Hampshire. He contacted the 2 agents and asked if they had accumulator adjustment programs. One agent never responded. The other one emailed us, did not say yes, but this is, and I'm quoting, I need to read this. As you can tell, I'm very passionate about this subject. Only amounts that the member is paying would contribute. No discounts or co-payments from the drug company will apply towards the deductible. It's only the out-of-pocket expenses from the member. So if I give my son the money, then he can pay his deductible. If I pay the deductible directly, the copay, it will not count to the maximum out-of-pocket or the deductible if I pay it. That is what an accumulator adjustment program is. 19 states have prohibited this because it's really double dipping. It's not a coupon. My son, by the way, cannot switch medications. They're all expensive, every single one for hemophilia. There is no generic alternative, and there are few alternatives. And if he does, he may get an inhibitor, which now means he needs even more of the factor to stop those bleeding incidents, those clots. So we're in this situation where we could use copay assistance, but it's useless because it will not contribute to his out-of-pocket maximum or his deductible, and it's not a coupon. The drug manufacturer would pay for a copay up to a point. And oh, by the way, there is a financial limit for copay assistance for these drugs, at least for hemophilia, 400% above the poverty level. If you add up the maximum out-of-pocket deductible, if you add up the copays and his premiums, it's about $10,000 a year. That's a quarter of what he earns. I don't know who can survive on that. So my son, who's 26, might choose, he has to take this medication regularly in order to keep those factors normal so that, if he has an incident, he bruises like us, as opposed to having an internal bleed and going to the ER. But he might say, I got to pay rent. I have to pay utilities. And copay assistance isn't going to help me because it doesn't count towards my maximum out of pocket or my deductible. So I think I'll just skip taking my medicine. He's done that. It wasn't good. Yeah, I guess I've covered a lot of my points. I was not lobbying, but I was talking to our federal representatives a number of years ago about hemophilia and supporting the CDC and bills such as the copay assistance, the all copays count bill. And the representative we talked to asked the young woman who was with me, why should we pay for these really expensive bills? I'm a taxpayer, I'm an insurance payer, my insurance premiums are covering your costs. And the young woman looked at him and she said, I want to go to college. I want to be a productive member of society. I want to pay my taxes. I want to live. But I want to be productive. And so does my son. And he can be with his medication. But he needs help until he makes enough money to cover it. So my understanding from this bill, I have some notes here. Copay assistance is limited, at least for the products that we use through the manufacturer, it's limited by the household income. When he was on my policy, we didn't need it. He now needs it because he's of low to moderate income right now. There are no coupons, no words in the bill about coupons. It's copay assistance. So if somebody gets it, the insurance company gets paid twice. Yes, because it doesn't count to the maximum amount deductible. So whatever other medical bills, pharmacies, a patient still has to pay that until they've reached their maximum. They would reach their maximum quicker if they had copay assistance. If I pay my son's copays and give him the money, he'll reach it faster. I won't. But there's no word of coupons. It's just copay assistance. And by the way, at least from my understanding and the words from the insurance company, it could be a third party. It doesn't have to be a manufacturer as long as they pay it directly. So this bill, I am so in support of because it will help low to moderate New Hampshire residents with chronic illnesses, non-generic drugs. There are no options. They're going to be expensive no matter which brand they pick. It will help them get their medication and live healthy, productive lives. Without it, I don't know what would happen to many of these patients, including my son, if they have to make tough decisions, financial decisions. So I ask you to support the bill. Thank you for hearing my testimony. I'll be happy to answer any questions.
Okay, I guess I was wondering, how is the insurance company paid twice?
The insurance company is paid twice because the copay, which would go directly to the insurance company, correct?
No, the copay is
to the
going
pharmacy,
to the
right.
pharmacy.
But it doesn't count to the maximum out-of-pocket deductible. If I pay it, if my son pays it to the pharmacy, it goes towards his deductible, right?
Okay.
But if a manufacturer pays it to the pharmacy, it does not go to the deductible. So he still has, and I think it's thousands of dollars deductible. He still has to meet that deductible before the insurance company will pay 100% for his medication. So you see,
Well, I don't see the double pay. No, I still don't understand how they're getting paid twice. They're
If
they're
he-
looking for the copay, and they get something from, and the insurer is
let's
getting the
put it
premium,
in
but-
dollars and cents.
Okay.
And it's going to be low because my math isn't great. If he has a copay, he has a deductible of $500, right? Out of pocket, maximum deductible. And he pays the copay, $100 goes towards the maximum out of pocket, right? Now he only has $400 he has to pay, right?
Okay.
If he pays the next medication round $100, now it's $200 or
Right.
$300,
Right.
and so forth.
Right.
However, if a third party, be it a manufacturer, be it a grandparent, be it a charitable organization, and they have helped people before, I know, and certainly in the hemophilia community they are, if they pay that copay, his maximum out of pocket stays at $500, but the company's been paid.
Oh, you're saying they're accepting the money, but then they're saying, but we will not apply it. And so what do they say they're doing with the money?
I don't know. Ask an insurance company. Which reminds me, Senator Innes mentioned 19 states have passed this. We are working on a federal bill as well with many other organizations. I would ask, because my math, I'm not a statistician, I saw that insurance premiums would rise if this bill passed. The rate of increase over the years for those 19 states has not exceeded the norm for those states that have banned it. So the rate of increase, insurance premiums are going to rise every year. The rate of increase did not change. If the rate of increase changes, I'd like to know how the insurance company can attribute it only to this copay assistance bill, and at what percent. There are not that, how many patients in New Hampshire do not have the option of generic drugs, have expensive drugs, and need copay assistance? And if there are a lot, then I would think this is a significant problem for the state. If there are not a lot, I have to question why premiums would rise. And now I'm not speaking from my notes because I heard the previous conversation. So does that answer your question? And then some.
Like you said, I got to find out from the insurance company what they do with that money if they're not allowing, allocating it. So what are what's happening to that money?
Yeah, thank you.
You got to follow the bouncing ball.
Thanks.
Okay.
All right.
Seeing
Thank you
no-
very much for your
Thank
time.
you. Donovan Guerrero.
Hi, Representative Hunt and members of the committee. My name's Donovan. I live in Hudson, and I grew up there my whole life. Today, I'm representing the New England Hemophilia Association and the National Bleeding Disorders Foundation. Me personally, I have severe hemophilia type A. I was diagnosed at birth, and when I was 2 years old, I developed something called an inhibitor. And I know Susie mentioned this before I came up here, but what an inhibitor is an antibody that pretty much inhibits the body to absorb the factor that many hemophiliacs take. So what I kind of like relate it to people who don't know, are not very involved in hemophilia and don't really have much knowledge about it, is like a game of Pac-Man. So you have Pac-Man eating all these ghosts, which are the factor. So for me, I take actually the same medication as Susie's son. It's called Hemlibra, and I've been on that for 7 years now, and it's worked well for me. But you know, I've had still very severe bleeds to the point where I've had to, you know, take leave of absences from college. I've been fired from a job in 2022 because of my bleeding disorder. So the drug has worked well for me by and large, but still overall, it's a tough diagnosis to live with, especially when you consider my choices for treatment. Like I said, I've been on this factor for 7 years, and you know, the pool of factor products is small as it is. When we talk about, you know, generic drugs, it's a very small pool. And then for me, I have an inhibitor, like I said, so the pool only goes down smaller with my choice of factors that I can take. So this is, you know, a really hard thing for me if my factor isn't really working, or if I'm having insurance issues like I was, you know, in 2021, then I'm not really left with many options. Yeah, I'm here, you know, just again, just to support Bill SB 354. You know, I really believe that this bill will help patients with chronic illnesses, not only hemophilia alone, but with cystic fibrosis, like the man behind me was mentioning earlier, with cancer patients, with diabetics, any patient that needs, you know, medication that has to be provided by a specialty pharmacy, not a regular pharmacy, that is a serious chronic illness. You know, I believe that this bill will provide support to them. So I ask that you support this bill as well. And like Susie said, you know, 19 states have already, you know, supported this bill. You know, especially when I get into costs, I paid 20%, since I'm a college student still, I paid 20% of my income last year was due to medical expenses. So I have had to face situations where I'm choosing to take my factor, or pay my rent for college, pay my housing, or pay for my textbooks or other educational expenses. I've had to face that decision before, and sometimes I've chosen to not take my factor because of that, or some, you know, very hard decisions about not even going to the hospital if I need to, or taking ambulances in emergencies like I had in 2022, where I had to go to the ER 4 times for different bleeds, and I couldn't afford to take an ambulance. I couldn't afford to stay in the hospital as an inpatient long. And as I'm 23 years old right now, I look to the future, and, you know, in a couple years, I'll have to get my own health insurance, and I'll have to get a plan that will be stable enough to cover my factor. And that's a big priority of mine right now, looking ahead to the future as I, you know, transition out of my father's insurance. Similar to Susie, I pay just as much as she said, because I'm on the same medication called Hemlibra. And I mean, that's all I can really say about the expense side of it. But yeah, I just want to reiterate the fact of the coupon that I've been hearing. once again, it's just not a coupon. It's a whole process of how it works. And, I can explain the process again if nobody understands it or needs some clarification on it. Because I'm aware of how it works, and so is Susie as well. So if nobody has a solid understanding of that, I can explain it. But yeah, if anybody has any questions, I'm happy to answer. But just thank you for letting me speak today.
Thank you for coming. Do you have a question? Representative Post.
Thank you. And thank you for coming and giving this testimony. My question revolves around, you said you need a special pharmacy to go to. Are they all over the state? Are they far away?
Yeah. So, we have regular pharmacies like Walgreens and CVS that you can get regular prescriptions for common medications. My medication is not common. It's not generic. It's produced in, limited quantities. So, I am on a specialty pharmacy called Credo, and they've been around for many years. They're older than me, and I've used them for about 2 years now, since the beginning of 2022, and they're all the way, I think they're based out of Ohio. I may be incorrect on that, but they're definitely not based around here, but they have locations around here where I'm fortunate enough to, they can ship factor to me the next day or 2 days later. So yeah, I hope that answers your questions about where they're at.
Yes, it did. I was concerned because I know that if you have issues and you can't get your drugs, that would be an issue. So I wanted to make sure that you have the ability to get those drugs. So thank you.
You're welcome.
Thank you very much.
Thank you.
Chair O'Connor, Carrie Boucher.
Hello, everyone. Thank you for having me. My name is Carrie Boucher. I am an adult living with cystic fibrosis, and I'm also a lifelong New Hampshire resident. Cystic fibrosis is a rare genetic disease that affects many areas of the body. One of the primary areas is the lungs, where it creates thick, sticky mucus, which makes it difficult for the individual to breathe. This also causes issues with chronic lung infections and frequent hospitalizations, and even the need for lung transplant in some individuals. When I was 5 years old, testing confirmed that I had CF as well as my younger sister, Mallory. At that time, my parents were told that most likely we would not live long enough to graduate high school, since there were no treatments that could help correct the underlying cause of cystic fibrosis. Despite this, my parents did everything that they could to keep me and my sister healthy. They would stress to us the importance of doing treatments that we did have at the time, such as antibiotics and airway clearance, in the hopes that we would be healthy enough someday if there was a cure. So far, there has not been a cure found, but there are treatments for cystic fibrosis that have improved tremendously over the past 35 years. In 2010, I was able to participate in a clinical trial for Kalydeco, which was the first medication to address the cause of cystic fibrosis. This medication made a difference for me almost immediately, and it has helped me stay healthy for nearly 8 years. Even though it was not the medication's fault, I became very sick in 2018 and 2019, to the point where my lung functions were starting to deteriorate, bringing the need for a lung transplant closer to my reality. I also thought I was going to need to stop working full time, and things as simple as sleeping were difficult because the mucus in my lungs made it difficult to breathe. Simple everyday activities were no longer easy, and I wasn't able to enjoy my life or being with my family and friends. In late 2019, a miracle for most of the CF community was approved by the FDA. Trikafta gave me and so many others a chance at a normal life. My health has improved drastically since then, even to the point where I ran the Boston Marathon in 2022.
Wow,
I truly believe this medication saved my life. However, one of the downsides to Trikafta is the cost. This life-changing medication costs over $300,000 a year, which is impossible for the majority of people in the CF community, to afford. Personally, copay accumulators will impact me once my time in my current clinical trial ends. My employer has told me, and I've been at my employer for 20 years, so I am on their plan. I don't have a large choice in the plans that they select. But they have told me my out-of-pocket maximum will be $8,000 for Trikafta, even though I have copay assistance to cover this amount. This is a huge cost and burden that causes great uncertainty and anxiety about finding a new way to cover this bill. With the ability to access copay assistance, it has helped to ease the anxieties of financial burdens for many in the CF community so that they can continue to access life-changing medications. I ask that you please stand with those in the chronic illness community and consider the impact that copay accumulators have on those fighting for a chance to simply live a healthier life. Thank you.
Well, we thank you very much for coming
Thank you.
in.
I appreciate your time. I also can say that copay, they're not coupons, just from my experience over my life. You have to go through a process with the pharmaceutical company, submitting like your wage data and your earnings for them to decide if you're eligible for one of their copay assistance programs. And when I go to the pharmacy, I don't have a card that looks like a coupon. It looks like an insurance card that I give to my pharmacy, and they send that out as like a bill. And that's how they get paid. I don't see any money from that. People who have copay assistance don't have any other benefit other than the company, the pharmaceutical company, third party, whoever they are, paying for that portion of the med for them. So if I have an $8,000 deductible and I receive copay assistance, they're paying for that for me to cover the cost of this medication. But my insurance company is not going to apply that to what I owe. So they're receiving this money from the pharmaceutical company, but still asking me to pay the $8,000. So what are they doing with the $8,000 that they've already received from the pharmaceutical company? That's my...
We will try to find out,
Yes.
get to the bottom of that.
Yeah, so that is the main point, like just from listening to everybody in the room, that, you know, they are getting the money, they're getting paid, but then they're expecting the patients to pay it also. So that is a huge burden for anybody who's trying to deal with that. So, thank you all.
Thank you. Okay, Curtis Berry, I call you because you're going to take 1 minute. Okay. Mike Rollo from the American Cancer Society in support of the bill.
We'll try to be even quicker than I put it on my card, Mr. Chairman, because a lot of what I wanted to say has already been said. But for the record, I'm Mike Rollo, Government Relations Director with the American Cancer Society here in New Hampshire. And we are in full support of Senate Bill 354, and we are actually leading a coalition of 19 other public health organizations. If you see the second page on your packet, on the back of it, there's a list of all the different organizations. Some of the volunteers of those organizations have already testified this afternoon as to their experiences with these so-called benefit of a copay accumulator program as part of their insurance. But for many cancer patients having difficulty affording the cost of their prescription drugs, even if they have insurance, it's especially true for newer drugs, including, as I said, for cancer drugs, even if there's especially because there may not have been yet a generic equivalent. And to help temper the high cost of these prescription drugs, many individuals are turning to copay assistance, oftentimes offered through manufacturer programs and other charitable assistance programs. And as you've heard, the crux of the problem is these folks will get assistance, they'll go to the pharmacy they'll get the assistance paid for them, whatever the dollar amount is. Susie used nice round numbers. Let's say it's $500. The $500 is paid on their behalf, apparently through a card, as we just heard. But at the end of the year, these folks are still on the hook for that $500. It doesn't count towards their max amount of pocket. And that's what this bill is aiming to try to stop, that practice. I think at the very beginning of this hearing, we kind of went a little sideways, I think, and maybe I know 100%. I understand that's part of the process. I think we're trying to get back to really the crux here. I think that's really the problem, why this bill has been brought forward and what we're trying to solve. However, with the implementation of Senate Bill 354, these barriers to copay assistance would be removed, and it would require all payments made on behalf of patients, either directly on their behalf or whether directly on their behalf or by some other organization, be counted towards the overall out-of-pocket maximum or the deductible. And requiring health insurance carriers to do so will protect cancer patients from surprise bills and treatment delays, as well as allowing individuals to utilize the full benefit of copay assistance programs. And just to be clear, SB 354 is not a coverage mandate, and does not require that insurance companies cover any particular drug or class of drugs. Nothing in this legislation prevents insurers from using their existing utilization management tools, such as step therapy or prior authorization. We're only addressing copay assistance that is being used by patients for drugs that their insurance company has already made the decision to cover and that their doctor has determined that they need. Patients still have plenty of skin in the game in the sense that they're still paying their premiums, and that patients living with chronic illnesses don't always have the luxury of foregoing their treatment. And I can't always just easily switch insurance plans as were suggested previously by the insurance department. So with that, Mr. Chairman, I will stop testifying. Although I will just mention, last evening I did send to the full committee, just so you all have it, in case you might have missed it in your email, some information. They're very large files. I didn't want to print them all out. There's about several hundred pages worth of information. There's a study by the AIDS Institute, the Pioneer Institute, and the Global Healthy Living Foundation, which actually does an analysis of all the 19 states that have already passed this policy, which does show, as has been previously mentioned, that there has not been an increase in premiums other than a normal, what you would see as a normal rate of increase that you would see anyways for insurance increases in premiums, but it was not based on this policy being enacted. So with that, I'd be happy to answer any questions or try to, Mr. Chairman.
Okay, any questions? See, I think we're all questioned out.
I would love to talk about maximizers, though, if you really wanted to,
No.
because there are quite the process.
We're all have this in the subcommittee, and I'm sure you'll attend this.
But I do
I
have a
would
question.
happy to talk about subcommittee.
I do have a question.
Okay, here you go.
It's a nothing question. Well, it's, yeah. We have insurance companies on one hand who are desperately trying to keep premiums down. We have patients that are in need. I've done a little bit of looking into what drug companies make on drugs, and especially some of these drugs, and no one has mentioned that maybe the drug company should take some responsibility for this. What do you think of that? Yes, Don Kreese did mention it. There should be some responsibility there. It can't be all on the ratepayers.
I have said in other hearings, and I will say it here again, that I have no problem whatsoever laying blame at the feet of pharmaceutical companies. I have no problem laying the blame at the feet of the insurance industry. I think there's lots of blame to go around. I do not represent the pharmaceutical industry. I do not represent, Lord knows they will tell you, I do not represent the insurance industry. I represent cancer patients and their families. And I will tell you that with the system that we're living in right now, that SB 354 is a solution to help people right now. Now, if you're looking for other solutions to help solve the high cost of drugs, that's a much larger conversation. Sorry, let's talk with my hands. Much larger conversation, Representative. That this bill is not going to solve all the problems with the high cost of drugs. This is to help consumers. So I can stop talking with my hands. I'm sorry. This will help consumers in real time right now that are getting help to pay for the high cost of drugs, and Lord knows they are way too high. But the help they're getting needs to count towards their deductible and their maximum out of pocket cost per year. That's what this is addressing right now, and that's really, I think, what we need to focus on right now. And what you're talking about, I'd love to talk to you about that offline. We could talk about that for hours, trust me, because it's the larger problem. But you're not going to solve it right now, I don't think.
Thank you very much.
Of course.
Okay, this time I'll do Heidi first. Heidi Kroll from AHIP. Excuse me.
Good afternoon, Mr. Chairman and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm representing AHIP, America's Health Insurance Plans. So we are opposed to SB 354. I had lots of notes written out, and I think I'm going to try to jump around to address some of the questions that have come up. Our concern is that this bill will increase the cost of health insurance for New Hampshire citizens and employers who are in the fully insured market. The bill does nothing, as you've heard, to control the soaring prices of prescription drugs for patients, and instead rewards drug makers for steering patients toward more expensive brand name drugs. Patients' access to affordable health care in New Hampshire's fully insured market, which is the sole target of this bill, we do believe will be negatively impacted by this legislation. Trying to decide where to begin. I think.
Well, tell us why how this money, how
Yeah, so I
someone
think-
can
I
hand the
think
money
there's-
and you don't count it to the thing. Can you
so-
help us out with that one?
So first of all, I would say that carriers are concerned about the patient assistance, coupons, discounts, cash cards, whatever you want to call them. Carriers are focused on what is coming from pharma. We do not track, we don't have an interest in tracking, as far as I've been told, assistance that's coming from your Aunt Sally, your local church, your GoFundMe page. And the reason is that the source of the assistance matters. And it matters because when you get assistance from your Aunt Sally or your GoFundMe page or your local church, they are just trying to help. They don't care necessarily what drug you're on. They're not using coupons, and I'll use that in a very generic way. They're not using assistance to try to corner market share and drive people to a particular, more expensive brand name drug when there are lower cost alternatives. That is not what your family and friends are doing when they are offering you assistance. When the assistance comes from pharma, that is exactly the purpose of the assistance. It is a market.
But frankly, that's not what we've heard in this testimony today. What we've heard in this testimony is very unique drugs for a very unique ailments that there is no other drug. Because we always thought about, in terms of the other bill, it was, if there was some other drug that you can choose.
Right.
But if you're talking about cystic fibrosis, and there's only one medication you can take, and it has this outrageous cost.
Right.
And so why would the insurance company take money if offer assistance In other words, if the pharmaceutical company is offering assistance, and we'll forget about what form it's in, but there's some money coming down because the pharmacy's happy that he got the money. They got whatever they were looking for, what the computer told them they needed to get. They got it. They could apply it to whoever going to pay it. So what I'm asking is if we're really narrowing it down to just these unique medical conditions that only have one drug that can solve, why would we turn down? Why would you not respect the fact that that pharmaceutical company is giving they're calling assistance, a subsidy, they're doing something that made that pharmacy happy, okay, that they're doing that. Why would you be opposed to that if there is no other medicine to take?
So my understanding, based on one analysis I saw, is that 88% of brand name drugs with manufacturer coupons were medications for which lower cost alternatives were available. So under that math, that would leave the 12% of what you're talking about.
That goes back to 555.
Well,
this bill it talks about that's from the testimony we heard. Now maybe we're getting limited testimony. Maybe we're not getting as focused the way this bill is written. And certainly I think this committee is more than motivated to narrow it to what we heard in today's testimony, which is to solve these people who I would assume I would assume a hemophiliac is on Medicaid. I mean, I would assume like Social Security or, Social Security, but maybe not. I don't know. I mean, the fact that they're still in the market, in the insurance, the open market, obviously the employer is going to set the copay or the high, the deductible at what they think is right and has nothing to do with the individual employee. But what I'm saying is if we can narrow this to those drugs which really don't have anything else, and that if the drug company is willing to help that deductible for that employee, knowing full well that you could say is, well, they're just raising the price at the back end, that they're going to get whatever they just donated, they're going to get back from you, okay? But that, from the insurance company. But if if we were to narrow it to these unique medical conditions that these are the only drugs available that are, but you're saying is, that what is that it's 80% or they do have competitor products.
Yes, that's my understanding. And the bill talks about any amounts paid by the enrollee or paid on behalf of the enrollee.
Right.
So I think the bill, whether intentionally or not intentionally, muddies the waters about the source of the assistance.
We want to make sure that yes, if grandma wants to make the payment, we will be more than willing to take that money and apply it to the
right. And I think again, this bill is not about whether or not people can use the assistance. It's whether or not the assistance gets counted toward their deductible.
Right.
In terms of whether what's coming out of their pocket versus what's coming
right,
out
because
of somebody
what we
else's
heard
pocket.
today is pretty outrageous that there is this assistance, that money is coming in, that the pharmacy's collecting that money, and yet at the end of the day you're not showing it on their what is the benefits? What do we call the?
And again, I think it depends on whether it's coming from the pharma or not. Because if it's coming from pharma, it's a whatever you want to call it, a coupon, patient assistance, discount, whatever. It's coming from pharma to the pharmacy and then back up to pharma.
So do you have the pharmacy refund the money that the person gave when you disallowed it? I mean, what we just heard is that there's double payments. So maybe the person who's taking the double payments is the pharmacy. Maybe the pharmacy is holding on to this money. Who's holding on to this extra payment?
I can tell you carriers are not holding on to the extra payment. The issue is
the PBM must be. PBM must be holding on to that money. Who's holding on to that money?
I mean,
If you're not allowing
the,
it,
the fact
it
of
was
the
paid.
fact of the matter is, if the pharmaceutical manufacturer is essentially discounting the price of their drug, right, and the patient is simply paying their share.
Okay, so
let me
you're
give- let me
holding
give
out
you-
that
let me-
maybe what's happening is that assistance money is then reducing what the insurance company has to reimburse the pharmacy. The PBM has to reimburse the pharmacy for that medication. You're saying it's coming off at a different end. It's not coming off on the consumer end on their copay. It's coming off to how much is billed.
I'm saying basically that pharma is paying itself with some of these.
So that when they come time to bill you, to bill the pharmacy or bill the insurance company or the PBM, that there is a discount on that billing that reflects this assistance dollars.
I don't know if it's showing up as a discount, but it's effectively a discount. Let me see if I can give
Okay.
you an example, and maybe this will help. So in the example that I had come up with, let's take someone who has not yet met their $5,000 deductible.
Right.
They have the option of taking either $1,000, and I guess here I'm more focusing on where there's a competitive alternative. But I just want to illustrate why carriers are honed in on this issue. So the patient has an option of taking a $1,000 drug that offers a $900 coupon, which means they would pay $100 out of pocket. Or the option of taking a lower cost alternative that comes with a $125 out of pocket cost. Okay, they're going to choose the drug with the coupon because it means a lower out of pocket cost for themselves, $100 instead of $125. Under SB 354, instead of just the patient's $100 expense counting toward the deductible, the value of the coupon, and I'm using coupon very generically, the $900 manufacturer discount would be counted too, meaning $1,000 would get counted toward the patient's deductible, not just the patient's $100 that they took out of their pocket.
Right.
So
And you do understand that's not
the
the testimony we've gotten today. The testimony we've gotten today is they don't see that that extra $900 showed up, and that they see that they still have not met their personal deductible other than paying that $100.
So they're getting the benefit, in my example, they're getting the benefit of the $900. They're paying $100 out of pocket, and the $100 is getting counted toward their deductible. So from pharma's perspective, what they're trying to do is put patients on an accelerated path toward meeting their deductible, because once the deductible is met, in the cases, as far as I understand, pharma withdraws the assistance. Okay, once the deductible has been met, pharma withdraws the assistance. And the cost of these high-cost drugs, whether there's competition or not, is then shifted to the premium payers. And our concern is that when there are lower-cost alternatives, we want people to be looking at those. We understand that there's not always going to be lower-cost alternatives, but when there are, we think people should be looking at those first.
Okay.
The problem gets worse. In my example, and the problem is that our concern is that 354 adds an incentive for drug manufacturers to increase their drug prices. So in the example I use where the patient has the $5,000 deductible, a manufacturer would have the incentive to raise their price, in the extreme case, to $5,000 for the month. They give the patient a $4,900 discount, coupon, assistance, whatever you want to call it. The patient pays their $100 out of pocket, and now the patient has met their deductible in 1 month, and pharma's scheme, it has premium payers paying for $5,000 per month drug for the remaining 11 months of the year, even though there may be lower cost alternatives out there. So that is our concern with this bill.
Got it. So we have
And-
twofold. We have the issue of where does this money go? How's it credited? Okay. But I have to admit, I always thought the purpose of a PBM was that they're negotiating a price over a year that they're getting, and that the pharma can't just go raising prices willy-nilly because they have a contract with the PBM formulary that they're locked in for a year. But maybe I'm wrong.
Well, in these cases, these drugs may or may not be on the formulary, and they may be
They'd
placed
be off the
on a high
formulary
tier or
anyways,
something
and they're
like that.
just paying the rack price.
I was trying to illustrate the incentive, the lack of an incentive.
Right.
For a pharma to kind of try to keep a lid on prices. I mean, we do see there's a lot of shortfalls with the bill. We've talked some about, there's more types of lower cost alternatives than just generics. There's biosimilars, there's therapeutic equivalents, and in some cases, there's even just over-the-counter medications that in combination essentially amount to prescription drug. So that's not addressed in the bill. We would like to see more consumer protections. For example, if some form of assistance, whatever you want to call it, is made available to a patient, it should be made available by pharma for the entire plan year. They shouldn't do this bait and switch where once the deductible has
we
been
agree
met,
with that.
they withdraw it. And they should also be allowing consumers to make informed choices by letting them know when the patient is in their open enrollment period, or the business, the employer offering the assistance is in the open enrollment, informing those consumers if there's going to be any changes in the value of the assistance. Is it going away? Is it being decreased, increased, so that people can be making informed choices? We also we don't agree that maximizer programs should be banned. They are very beneficial to patients and premium payers, and we should not be passing laws that harm New Hampshire's healthcare consumers. And I think Ms. Dunlap will talk more about this, but there are programs that are essentially capturing the full value of coupons that are available from manufacturers, spreading that out over the course of a year, and allowing these patients to get those very expensive drugs for $0, $5, very low cost sharing. And finally, we think that this bill, there should be notification requirements from the pharmaceutical manufacturers to the carriers when these types of assistance are being made available. Disclose the name of the enrollee, the name of the drug, the amount of the coupon, any other sort of terms and conditions. As you heard from one of the prior speakers, they essentially have something that looks like an insurance card at the same time that they're at the counter, maybe with their normal insurance card, and making a payment out of their pocket. Sometimes the pharmacy systems will allow the insurance company to see that some sort of assistance has also been playing a role. Other times those systems do not. And so if we are being asked in any circumstances to apply assistance to the deductible, the first step is we need to know about the assistance. And right now we don't always know. So I'm happy to try to answer any questions. And
Okay, Representative Spear. Did I see a hand over here?
If we were to kind of amend this bill to cover many of the things you talked about, and also what you talked about, Chairman, one of the things I would also add to that is that in the case where we would have just limit this to some of the kinds of situations that people are talking about here, where there is no competition for the drug, I think they're usually typically tier 5 drugs in the formulary, where there's no competition and there's only the one drug and it's very expensive, which I hate to begin with, but that's what it is. That doesn't mean next year there won't be. In other words, so if we ever did such an amendment, there has to be some time considered that if competition does get in there, that gets taken into account so that we're not supporting a drug for which there now is a lower alternative that has come on the market, and they're coming on quicker and quicker. So I think that has to be added to your list of.
sure, I would agree with that. Yep.
Thank you. So, do you know why the woman that spoke earlier, she made a payment for her son, and they didn't use that towards the deductible? Why would that be an issue?
So my understanding is that, again, if a family member, a friend, a church, a GoFundMe, if a patient is getting money from a source like that, and they're going to the either the pharmacy counter or the virtual pharmacy counter, the pharmacist and the carrier are not really going to ask where they got the money to be making their cost share, their out of pocket payment. So I don't have a good answer for it unless she was directly trying to make a payment to the carrier toward a deductible. I don't know. I don't have a good answer for the question, but what I'm saying, and the reason that, again, carriers are not concerned about those sources of assistance because, again, those people are making contributions to that patient because they just want to help. They're not trying to corner market share. They're not trying to game the system. And I have all kinds of information, which I won't get into today. There's plenty of evidence that coupons, or I used coupons very generically. That is exactly what that pharma tries to do with the assistance. It's a marketing ploy. But with respect to your question, I guess if she had simply given her son the money directly and then he had gone to the pharmacy to make his payment, I don't see that there would have been any problem
We
with
we
that.
will certainly, if we're going to pass anything, we're going to specifically identify that and clarify that in a bill that would say that it's this is only about assistance from the pharmaceutical manufacturer. That's the only one we care about. Representative Ammon.
Thank you, Mr. Chair. Thank you for taking our questions. I guess help me validate my understanding and tell me if I'm wrong. There's two issues with this, right? So the deductible that the patient pays, let's say a patient has $1,000 deductible and they get $1,000 in copay assistance, that doesn't count towards it. If it did count, the insurance company would get $1,000 fewer and would have to eat that cost somehow, right? So that cost would have to get spread out to other ratepayers. That's the first half of it that I see. Is that correct?
So the issue is, yes, the assistance coming from pharma is designed to accelerate the patient to meet their deductible, at which point they withdraw the assistance. And now in the cases where there are competitive, lower cost alternatives, the patient is now taking a more expensive drug because they were, kind of lured into taking it. And,
So
I don't blame.
the other half is the disincentive or the misincentives for the pharma company. So there's the one half is the insurance company is getting less money because the deductible is met sooner and they're not getting the patient's money as they would normally.
But they shouldn't care.
And well, they'll be getting fewer dollars than they normally do.
No, the assumption was that they were getting double paid. That's what we heard today, was they were getting double paid. They were getting the assistance and not crediting that, and still making the patient pay the full
Under this
deductible.
bill, the requirement would be that the value of the coupon has to be counted toward the deductible in addition to any out-of-pocket expense.
So
the
putting
carrier
aside the disincentives or the misincentives that this would create for the pharma company, in the normal course, you're not getting additional money from the patient through their deductible, right? Ignore the disincentives. If you had to include the copay assistance towards the patient's deductible, now you're not. So you'd be getting less dollars.
Right.
on that end.
I don't know if this is what you're getting at or not, but for the patient who's on one of these drugs where they're getting assistance from pharma. So in the example I used, they pay $100 and pharma has picked up the rest. And now they've automatically met their deductible. For the consumer who's not on a drug that has a coupon or any sort of assistance, they are meeting their deductible,
So that
in
would be
the
a cost
usual course
shifting.
of business, where
Right.
they don't have that advantage. They didn't, win that lottery, so to speak. And they're just paying their deductible as they go.
And then the other half is the pharmaceutical companies, is this correct? The pharmaceutical companies could be disincentivized to play with their pricing structure so that they can maximize and they can take advantage of the insurance company having to count the copay assistance.
That is our concern.
Okay.
Yes.
Thank you.
Okay. Yes, Representative Rafter.
Thank you, and thanks for your fortitude in taking all our questions. You read a sentence out of the bill, but the sentence after the one you read said that this requirement that coupons count towards deductibles shall not apply in the case of a prescription drug for which there is a generic alternative. And I think that was one of your concerns, that, patients would be steered toward a higher price drug when there is a generic available. But it seems like this bill tries to address that. Is that not sufficient?
So you're correct. It does address a piece of it, but there are other types of lower cost alternatives besides generics. There are also biosimilars, therapeutic equivalents, and even over-the-counter medications that can be taken in combination. So we would want any sort of lower cost alternative, not just the category of generics.
Okay, so if we change that wording from generic to something more broad, that would be sufficient.
Yes.
All right. Thank you.
Thank you.
We have one more lobbyist come up. Do you want to ask the other lobbyist the question? Or do you think Heidi really knows the answer better than the other one? Sabrina. Anthem. Okay. I knew that. Where I'm at right now, I'm thinking that there can't be a lot of people who have these really expensive drugs. Okay? I'm thinking there might be, if we had 1,000 in New Hampshire, maybe just 1,000 of them. Why don't we just mandate that if they are taking any drug that has no competitor, that has no competitor, no alternative, it's the only drug that they can take, and it's gone through your formulary, and you tell the PBM that you beat that pharma down for the best possible price, and we're going to waive the copay on that particular drug, because it's only 1,000. 1,000, and the worst you can have is, the worst this was going to cost us a couple $100,000 in the state of New Hampshire, in terms of the rest of us paying the premium. But then the insurance companies, PBMs, beats down those companies for a cheap price. Say you can hold your assistance. We don't want your assistance. We'll get that from New Hampshire citizens, but we want you to give us these overpriced drugs that you have no competitor with. We want you to give us your best price. What do you think of that idea?
That sounds like Medicare.
So go ahead, Sabrina.
Okay. I appreciate that question. So I'm Sabrina Dunlap. I'm Director of Government Relations for Anthem, and appreciate everyone hanging in there on this. What I think the testimony reflects is how complicated these issues are. We are opposed to SB 354, and I think it's important. There seems to be some sort of confusion, understandably, between coupons and assistance programs. And
Right.
And my understanding is that they are quite different, including how carriers treat them. I don't want to misspeak, and so I will follow up on this, but my understanding, I'm sure carriers treat them differently in different ways, but for assistance, when it's needs-based, the payments from the drug companies would go towards deductible and out-of-pocket max. Now, if we're talking about the copay coupons, where they're not needs-based in many cases, and
Senate Bill 55.
those are rebates, so different.
Okay.
So that gets to an issue, which is this bill, the way it's drafted, definitely applies to assistance and to copay coupons. And that is what I'm focused on, because that is what I'm most concerned with. But I think there is an important distinction there. And also just want to point out, appreciate your talking about narrowing the bill, et cetera. But I don't want to lose sight of the fact that any statutory change on this issue would only impact fully insured members. So I don't know the people who testified, if they have a self-insured employer-sponsored plan, then this bill wouldn't apply anyway.
Right.
So I've got a few points I do want to make, and hopefully can clarify some issues, and I'm happy to take questions as well. But I do think this brings us back, similar to 555, it brings us back to this fundamental issue of the high cost of drugs. The reason copay coupon programs exist is because the drugs cost so much money. So when I'm talking now specifically about coupon programs, so non-needs based, these are offered only to specific patients for specific drugs for a short amount of time. Now, once the patient hits the deductible and they don't see the actual cost of the drug, that's when the drug makers stop providing the coupon. And I think this gets at your question, Chairman Hunt, you asked earlier, why don't pharmaceuticals allow the coupons to go on for as long as the patient needs them? I think it's a good question. I think that the way it's set up now, where a patient hits deductible, copay coupon program ends by the rules of the drug company, that allows the drug companies to keep their costs very high. That means members pick up those costs and employers pick up those costs. And to be clear, the copay coupon programs do not actually lower the costs of the drugs. The high cost of the drugs remain even with the programs. These programs simply create the illusion of affordability. I also, Representative Spear mentioned this, but I do think it's a really important point that copay coupons, I don't know about other assistance programs, they are considered illegal kickbacks by the federal government. They are not allowed under Medicaid and Medicare. And I think this gets at sort of the mechanics and the flow, at least with copay coupons. The value of the coupon goes from the manufacturer who issues the coupon to the pharmacy as a form of consumer payment applied toward the cost of the manufacturer's drug, and then back to the manufacturer as payment for the drug. At no point do carriers or PBMs receive the value of that coupon. So getting at this issue of like double dipping, I think that that's actually truly a misunderstanding of how the process works. I won't go into the studies about how this raises costs for everyone, but those certainly exist. Okay, so bringing us to the concerns I have with the way this bill will function. I think the language of the bill is confusing. It's not like you read it and it says this will ban X, Y, and Z. But having dealt with language like this in other states, we are aware that the point of bills like this and functionally is to stop programs similar to ones that Anthem has and other carriers have created sort of in the face of these coupon programs. And I think, you know, there's a lot of public policy concerns I have around the existence of these programs, but if they are going to exist, and I believe Massachusetts did actually ban some of them, and they're going to be heavily marketed to people on these medications, carriers should be allowed to find ways to most efficiently provide these high-cost specialty drugs to our members, and SB 354 would interfere with some of these programs. I'm happy to talk about this more offline. I don't want to get too bogged in the details, but the issue is that under our program, which helps our members afford these high-cost specialty drugs, which is what we want, and our goal here is coverage, part of our program is that the copay coupon amount does not go to the patient's deductible. And the drug companies don't like that for the reasons I mentioned earlier. But our program saves employers a lot of money. It's incredibly popular with our self-insured employer groups, and it's very popular among our members, including in the fully insured market, because under our program, they pay $0 for the specialty drug. And I believe the way we are reading this bill is that that program would no longer be allowed to exist under if this bill were to pass as is. I also just want to quickly address this idea of contributing to someone's deductible or out-of-pocket max. So my understanding is that if you have a deductible, the whole point is that certain medical costs to the patient go to the deductible. Usually, now there's so many different plan designs, but I think typically you hit your deductible, then you also have a portion of co-insurance. So it means you're paying some and the insurance company's paying some that goes to your out-of-pocket max. Usually, well, when you hit your out-of-pocket max, things are covered at 100%. And so I think it's a red herring and a misunderstanding, this idea that people would be like trying to contribute to your deductible and an insurance company would be saying you can't do that. It's simply not how insurance works. So payments for medical services will go to the deductible. So if somebody wanted to help you out, they would say, oh, you have a high medical bill from your provider, let me give you money for that. And they could certainly pay that bill, and depending on your plan design, that payment would go towards your deductible. So that's how it works. So I think it's really sort of nonsensical to suggest that there's some like deductible pot sitting there waiting to be filled, and somehow we're saying, no, you can't do that. So I just wanted to clarify that. And I echo what Heidi said. I think we'd support amendments that would bring in consumer protections. I'll end by saying this. I really appreciate the patient comments. And I will just note, I have a kid with a rare disease and live and breathe in the world of high cost specialty drugs, the world of rheumatology. And so I really appreciate their comments. And certainly, like personally and professionally, we want people to have access to these drugs. I don't think this bill helps. It does not help lower the cost of these drugs. I don't think it helps improve access. And I think it's really important to think about consumer protections. I was actually poking around a drug company's website today looking at their copay coupon program and how you sign up. I've actually experienced it myself. And in the language, it says, this copay assistance program is subject to change, reduction in monetary amount, or discontinuation without any notice. So I think it's important to think about, are these programs, something that we should be promoting in the first place? I don't think we should. And I think at the very least, we should be promoting more transparency from the drug companies about how these programs work. And also really put in more consumer protections if we're going to move forward with the bill. So anyway, I will end there, and I'm happy to try to answer any remaining questions. And thank you for your time.
Okay, Representative McHugh, you still have your question?
Does Anthem use any stop loss coverage for high loss claims, high loss patients, such as all the folks behind you and your own?
Yeah.
I would have to get back to you. I don't know the answer to that off the top of my head.
Okay, Representative Post, did you have a question?
Yes, so thank you very much. So I'm going to go back to the same question I had before, the woman who said she made a payment and it wouldn't go towards the deductible. But what you're saying is that money actually goes to, like, if they're done with their deductible, it goes to like a copay? Is that what you were saying?
So no, sorry. Thank you for the question. That's not what I was trying to say. And I'm trying to remember exactly what was said, but I think so. And I think this does get confusing. So copays typically are sort of set under your plan. So if you go to a PCP, you have a $20 copay. It's sort of always that. Depending on your plan design, that $20 may or may not go towards your deductible. So you have to hit your deductible. Let's say it's $1,000. Once you hit your deductible, again, depending on the plan design, then you may have a coinsurance that kicks in where the insurance company pays 80% of the cost and you pay 20%. Once you hit, so let's say you have a $5,000 out-of-pocket max and a $3,000 deductible. You hit your $3,000 deductible, then the coinsurance kicks in. You still are paying, your 20%. And when it's a high-cost drug, it depends on the situation, but you could hit that out-of-pocket max very quickly. So I don't know what the example was in terms of saying that somebody tried to pay someone's copay, because a copay is usually like, when you go for the service to your doctor's office, they'd say you owe your $20 copay. Anyone could pay that.
No, I'm thinking more of not so much the copay. I'm thinking about the deductible let's take the real numbers. You have an $8,000 deductible. That means the first $8,000 that are paid out in any of your bills, you've got to pay that. And then it's not until you got there that now the insurance company covers it. So that if somebody has this assistance, they're assuming that assistance is being paid to that copay. So if they're getting that $2,000 or whatever, a big large number, and they're thinking they're putting that to that assistance, what I heard you say is, no, that $2,000 is actually used to drop the price of what the medicine was. So the only person who really benefits from that is obviously the payees of the premium, i.e. the employer or they, because they're kicking in, but that's where it's coming off that payment. And they're thinking that it's supposed to help them reduce their deductible so they get to that $8,000 faster, but it's not being used for that. That's what I think I'm hearing.
Yes, I think I understand what you're saying. And I think my response, and I understand that, having lived through these issues myself, I think we would say that, sort of generally a lot a lot of factors go into setting rates. We have to set them far in advance. They have to be approved by the insurance department every year. When I talked to my team about these issues, they were saying that all these things fit together: deductibles, premiums, copays, coinsurance, everything fits together. And things like copay coupons sort of disrupt the way we have created the plan and the benefit design. And so I think also we have, because we have to deal with the existence of these copay coupon programs, we have designed programs that more efficiently use that assistance so that our members are paying $0 for the drugs. And it's true that that copay assistance isn't going towards the deductible, but I think that, that's the debate, is we think that's how our plans should function, because it should
Right.
be the patient's cost going to the deductible.
So, seeing no more questions, we have to get you out of here by 5. Right? I'm going to look at you, and no Peter Bragdon here, but I'm looking at Heidi. So, okay, you want to get in on this, Curtis? Okay. So here's what I think I would rather see us do, is that take what the testimony we heard today about Class 5 drugs, and I don't know how many drugs how many pharmaceuticals are in this category, but that their assumption is that they're one of a kind, and very unique. And I can't imagine that other states haven't looked at this and try to narrow this issue down to just that problem. Is how do we handle these very unique specialized drugs? Because we keep saying is, if there was another drug, if there is another choice. I think of yes, it is true that we have the insurance companies have a system where you call in and they'll and they're going to tell you, well, why don't you try this other drug? I guess it's the PBM that does that. No, who does when your doctor's giving you this prescription, then you're going to get, I guess it's the pre-approval, maybe, and maybe that has to be in that other bill that we have. But so that's some system where is that those unique drugs, and that we want to obviously. The intent was that because the dollar amounts to their deductible are so high, that's why there is this incentive by the pharmaceutical company to give a benefit, to say, oh, we're going to help pay for that, when it's not even sure whether that's what's really happening with the assistance. But now we have these two different things. So I want to just narrow this down to what we heard in today's testimony. Okay? And that, because the assumption would always be, if there is other choices, if there's other ways to solve it, then, the insurance company will certainly have an opportunity to tell the patient, by the way, there's something else you should do, and not be enticed by some carrot, whatever you want to call it, is dangling in front of them and say, if you take this expensive drug, you'll get this. But if that expensive drug has a competitor, no, we don't. That's what we're trying to avoid. We want you, to do what you guys do best, which is to get them to think of another choice. But if there is no other choice, and we're talking about a $300,000 medication, okay, that's Class 5, this unique thing, then I'm assuming that there's not more than 1,000 people in New Hampshire who are in this situation. That let's figure out how to solve it for them differently than everyone else who really does have a choice about what the medicine they're taking. Does everybody agree with that? Perfect. I will close the public hearing, and we'll see you all next week. We'll do Tuesday morning. Tuesday morning we'll do health insurance. Oh, that's right. I got another day for this fun stuff. Okay, and is it 10 or 9? Some reason I think we're 9, because I was trying to get everything in the morning so we wouldn't have to be here in the afternoon. I'm sure you enjoy that, because you have to be here Thursday and you didn't want to drive home.
No, I'm not driving home.
Yeah, that's what I'm saying. That's where you want to stay.